Good morning, Dr. Amol.
Good morning, Dr. Sitanshu. Good morning.
All set?
इको आ रहा है आपका, मेरे यहाँ इको है।
दूसरा वाला। Yeah, now it is better. Now it is better.
It's better.
Because I'll just take this call. Okay.
Please.
Hi, Harshal. You are muted, Harshal.
Good morning, sir.
Good morning. थोड़ा साउंड बढ़ा दीजिए.
Sir, share screen enable करना पड़ेगा, sir.
No, it's very feeble.
सर शेयर स्क्रीन इनेबल है. आप जब बोलेंगे अभी ऑलरेडी स्क्रीन शेयर हो रखी है, मैं इसको हटा देता हूँ.
Right.
You can
Great.
share.
Great. Great.
Now you can share, please.
कम है थोड़ा सा साउंड. Can you hear me well? Can you hear me well?
Yes, yes. Good morning, Dr. Dongre.
Good morning, sir. Good morning.
Good morning. Good morning. We are meeting first time on virtual mode. Heard a lot about you. Yeah.
Pleased to meet all of you. The video is lagging. I think video is lagging. Is it?
The video is not lagging,
It's
sir.
fine.
Okay.
It's fine.
we are waiting for Dr. Pradeep Joshi to join among the speakers.
Right.
Then we have two chairpersons to join. Harshal, Dr. Bari को मैं बता देता हूँ, आप रुको. Organizers हम हैं, sorry.
We can share the responsibility, no problem.
Yeah, responsibilities can be shared. That's true.
Yes.
That's true.
I will call her, ma'am. Don't worry. You just look at it.
So before we start, can you hear me?
Yes.
Yes, sir.
Tech team, can you just suggest, are we live?
Sir, there is two steps of live streaming. First we are live on Zoom.
Yes, yes.
Second
That's what I just
we will
wanted
go
to
live on a platform. So right now we are live on Zoom.
Okay, fine. Thank you.
We will go live when you say.
We will.
8:59.
Yes, thank you, tech team. So because Dr. Bari is just joining, and There is some issue with the camera, it seems. So then we'll start. So we have Dr. Tanu here. Good morning, ma'am.
Yeah, good morning. I am also sorry. I am having some network issues actually.
Yeah, now it is fine. It's all right. So because we are dot at 9 o'clock, 9:02 will go live once Dr. Bari ma'am actually admit. Yes.
Admitting. So,
Okay,
sir,
wait. I will sign out from this and probably join from my laptop now. So because I was trying to join from my mobile. Give me a minute.
Okay. All right. All right.
Dr. Sudhanshu, can you hear me?
Yes, very clearly. And
Okay.
your background also is looking great.
Okay. Thanks for the compliment. So, shall I share the presentation with someone if there is some technical glitch in?
Yes, please send your presentation to us. You can also share the screen from your end, but it's always good to have the backup in this side so that we can.
So this secretary IPHA thing, the mail ID or to your mail ID?
Yes, yes. No, secretary IPHA and mark a copy to me. So, Dr. Amol, just to check with you, you will play your recorded one or you will go live, sir?
I will go live, and if there is a technical problem, you can go ahead with the record.
All right. So all the four people, all the four speakers will go live. So now is everything set? Should we start the session?
Good morning.
Good morning, ma'am. Good morning. So I hand over the session to Stuti now. She will start the session. But Stuti, you have to check with tech team when to go live. So it's the floor is yours.
Yeah, so I just want to.
Yes, ma'am. Yes, ma'am.
So how sorry, because I had some problems connecting. So how do we go about it?
Ma'am, the session is from 9 to 10:30.
Yeah.
Okay, so initial two chair speakers, Dr. Tanu is going to introduce. Our team will introduce the chairpersons, and Dr. Tanu will go, and the CV of the speakers will be displayed from our end.
Okay. So I just have to read it out, right?
Yes, you can just have
so one at a time, isn't it? Like first I go with Dr. Joshi, and
yes.
yeah.
Then, and his presentation will be over. Then you go to the second one.
Okay. Okay, sure.
And we'll take the questions if there are some questions at the end of the session.
Yeah, sure.
Yeah. All right.
Sir,
Yes.
Sir, I'm putting the meeting on record.
Okay.
So if everything is ready, I'm giving countdown. Then we should start. Okay.
Sure.
Five, 4, 3, 2, 1. We are live.
Very good morning to everyone, and welcome to the 65th Annual National Conference of the Indian Public Health Association, Iphacon 2021, being organized by the Department of Preventive and Social Medicine, JIPMER, JIPMER International School of Public Health, and the Pondicherry State Branch of the IPHA. We welcome you all to day 3 of the conference. And to begin with, we have a plenary session on ensuring NCD care in pandemic era. Joining us today, we have Dr. Tanu Jain and Dr. Bari Dalin as chairpersons. So Dr. Tanu Jain is a public health specialist who has graduated with MBBS and did her post-graduation in community medicine, and thereafter joined the Maulana Azad Medical College as a senior resident. She joined the Central Health Services Government of India in the year 2007 and has an experience of working at ground level for outbreak and epidemic investigations and epidemiological studies. Ma'am has also coordinated the MPH field epidemiology training, and she has also worked as the head of media and head division of health education at the CHE. She has been acclaimed at national level for her various contributions in shaping and implementing the National Trauma Care and Burn Care program with the Ministry of Health and Family Welfare. Presently, she is coordinating the efforts being made by the Government of India to establish emergency trauma and burn care protocols and guidelines for India. Recently, on promotion as the DDG, she has been given the additional responsibility of managing the NLEP, the National Mental Health Program, and the NPCDCS. Ma'am has also been a program officer for monitoring the activities of 19 regional offices for the Health and Family Welfare Department, spread all over the country. She has also been actively involved in supporting various activities related to COVID-19 management in hospitals, and she has also been involved in collection and compilation of data and analysis countrywide for the same. So with this, we move on to the next chairperson for today. So we have Dr. Bari Dalin she's a professor at the Center for Community Medicine in AIIMS Delhi. So ma'am has more than 18 years of teaching experience as faculty at the Center for Community Medicine, and her areas of work include non-communicable diseases, cancer prevention and control, medical education, and primary healthcare. Ma'am has also contributed to the WHO package of essential NCD services and has been actively involved in the evaluation of NPCDCS. Ma'am also has around 120 publications to her credit. Over to you, ma'am.
So very good morning. Shall I start?
Yes,
Am
ma'am,
I
you can go
audible?
ahead. Yes, ma'am,
Am I
you're
audible?
audible.
Yeah.
Yes, ma'am, you're
Thank you.
audible. You can go ahead.
So thank you very much for that excellent introduction. And to start with, I would like to first of all thank the organizers and especially Dr. Sitanshu, who's the professor and head department of PSM at JIPMER Pondicherry, for giving this opportunity to connect with the conference which is happening in Pondicherry. I wish we all were there, but anyways, we are happy to join online also. So thank you so much for giving this opportunity. And I think it is a very important and very opportune time that we are here today to discuss these issues. I was seeing there's an excellent galaxy of speakers with us, and the chairperson too, with whom I have been working quite closely on some projects, and we've been meeting quite frequently in various meetings and names. So Dr. Bari, happy to see you here as well. And Dr. Joshi, I think he is one person who has contributed immensely to the NCD program, and he's the technical officer in National Non-Communicable Disease Program at the national WR level. And the topic that he's going to speak on is the continuum of care and people-centered care in NCD. So I think, as we are all aware, that in NCD, we have a population screening. And under the population screening, we are screening all people who are coming to the health and family welfare centers, primary health centers, district hospitals, for various diseases, non-communicable diseases. Now, what happens to them once they are screened? Where do they go? And what is the whole procedure? Because if you diagnose a case of, say, diabetes, or you diagnose hypertension, or you diagnose any other thing, then you really want that, the person should get the treatment that he wants, so that, there is a faith in the system, and there is, a continuum that is established. So at the program office, we have realized that it is easier for us to have continuum of care as far as diabetes, hypertension is concerned. But for cancer especially, we are struggling a lot how to go ahead and have that continuation of care. So without taking much time, I would like to introduce Dr. Pradeep Joshi formally. So he is designated as National Program Officer. Can you please lift it a little up so that I can? So National Professional Officer, WHO Country Office for India. He has experience of working in this field for 15 years. And he's been working for NCD in WHO Country Office for India, postgraduated from King George Medical College, Lucknow, technical assistance to various state government for strengthening the national NCD program. And he has been engaged in framing the National Multi-Sectoral Action Plan for NCD and participated in various operational research, including integration of communicable and NCDs. So this is a very small part of what Dr. Joshi does. He actually, his expertise and his contribution to the system goes much beyond. And I can vouch for that. Sitting in the ministry, I can see that whatever portfolio is given to Dr. Joshi, with his ever smiling face, he's always there with his wealth of knowledge, his ever smiling face. And I don't know, he is really something very much wonderful. Looking forward to hearing from you, Dr. Joshi. Please take us through this continuum of care. Thank you so much.
Thank you so much, Dr. Tanu ma'am, for your kind words, and Dr. Bari. And good morning, everyone, especially the JIPMER team and the IPHA team, and my speakers in this panel session, and the participants. A warm greeting from WHO Country Office for India. I hope my slides are visible. My slides are visible. Okay. So I was given responsibility to speak about the continuum of care and the people-centered care in NCDs. So first we have to understand what is this integrated people-centered NCD care. So if by the definition, if what we see, it is people-centered care, basically put the people and the communities and not the disease at the center of the health. And basically empower people to take care of their own health rather than just receiving the treatment. And one step ahead of the people-centered care is the patient-centric care. So where we define, and it's mostly at the health facility level, where the patient-specific needs and the health count comes, which drives all the care decisions. And it's not only decided by the clinician, it is jointly decided by patient and their healthcare provider. And it goes beyond the dimension of the clinical care. It also addresses the emotional, the social, and the financial concern of the person who is attending the health facility. So there is a 6 hexagonal which compromise this people-centered care. One is, first is the continuity of the care, whether the drugs and the treatment and the referral is there or not. Second is the communication about how we are communicating with the patients. Then collaboration and coordination between the different healthcare facilities and between the health systems. The engagement with the community, sharing and the leadership, the culture of sharing and leadership, and overall the comprehensive care. So this defines the people-centered care, which we are going to discuss today. There is a fundamental difference between the conventional care and the people-centered care. So what we see usually at our health facility level is focus is when the patient comes, is it about the illness and cure. But here in the people-centered care, when we are looking for that approach, it focuses on the health needs. So the relationships are only limited to the patients. But here in the people-centered care, it goes and it builds the relationship. There is a kind of a communication being integrated when we are doing this people-centered care. The third is that there is an episodic curative care. We just put the patient when it comes and provide the treatment, but in the people-centered care, we provide the overall comprehensive, and it is a continuous care, which is the focus of that one. Responsibility in the conventional care is limited to the effective and safe advice to the patient, while in the people-centered care, it is health of all. It goes beyond the patient itself. It goes to the community level and also addresses the tackling determinants of health, ill health. Lastly, the users are the consumers of the care. But here in the people-centered care, it partners with the community also for managing their own health. And when we talk about the NCD, if a person comes with the diabetes of the symptoms, so it is not carrying that diabetes, it is carrying a lot of other complexity or coexisting disease along with him, whether it is raised blood pressure, obesity, his behavioral risk factor, smoking, unhealthy diet, harmful. So if we go to the conventional care, especially for the NCD, we will not be able to address all these ill determinants of the health which coexist when the patients come to a healthcare provider. So what are these 5 interdependent strategies, which is defined in the WHO framework for integrated people-centered care? These are engaging and empowering people communities, strengthening the governance and accountability, reorienting the model of care, coordinating service within and across the sectors, and overall creating an enabling environment. These are the 5 strategies where the people-centered healthcare generally works. What we usually see when we are at the healthcare facilities, we think of early detection and the screening. then followed, if there is early detection and the patient is found, we provide the management. And if there, as Dr. Tanu ma'am was saying about the cancer, if it is in advanced stage, we provide palliative care. So this is a content of common NCDs which we provide at the health facilities. Or if we further go beyond how we make the NCD care efficient pathway, is broadly the services are provided at the primary healthcare level. Then we have at the secondary, there are general hospitals, and then medical colleges are there. And the 6 building blocks of WHO works to provide across this 3 levels of care, mainly on the stewardship, financing, the supplies, whether HR system and the information system. And it caters all the people, not specific to the particular gender or particular age group. And before going further into that, I will just focus on what at the country level or at the state level we are providing as a continuum of care. What is there? We have a national health policy, and in the national health policy, we have this Ayushman Bharat, which has 2 components, Health and Wellness Center and Pradhan Mantri Jan Arogya Yojana. And this is the entire continuum of care which has been conceptualized at the in the national health policy. So at the community level or at the sub-center level, we have population enumeration, their screening is there, they're raising awareness about the NCDs, is there risk factor counseling is there. And if we go to the above level at the PSC, where the diagnosis is there, treatment is being provided, and a facility to go to the, if there is a complication, providing the referral to the higher center. And at the CSC referral hospital, we have a more kind of a specialist sitting over there, providing more comprehensive care about the reducing the complication of the diseases and managing those complications. And at the final level, the district hospital provides the entire complicated cases management, especially the stroke, chronic kidney diseases, and CSD and cancer management. So this is what is being envisaged in the national health policy. And as you all are aware, there we have a population-based NCD screening program, which has more than 100 million enrollments and has potential to reach 500 million individuals. We are having this health and wellness center, which 76,000 are already being established and more are coming up, which provides promotive, preventive, and the palliative and rehabilitation care. We have free and diagnostic schemes, then there is a teleconsultation. Also at the higher level, we have this Pradhan Mantri Jan Arogya Yojana, which provides financial protection to 500 million people, individuals, and there is a convergence with other programs. So this is the entire spectrum which we have in the patient-centered care or people-centered care, as well as for the continuum of care. But are we able to address this issue? Are there any gaps in the health service delivery? How we can identify? So are the individuals at high CVD risk? I'm just taking of the cardiovascular diseases, whether the individuals with the high cardiovascular risk are optimally treated or controlled. If they are controlled, if they are not controlled, how to ensure the quality of the care? If we are talking about the CVDs, the hypertension and diabetes, the quality of care is ensured or not? How we are addressing to reduce the dropouts? How the referral and back referral need can be improved? How we can prevent the unnecessary referral visit to the hospital, and how we can improve the adherence to the self-care. So these are the questions which need to be answered under the overall umbrella of the comprehensive primary health care of government of India. And this is based on the recent survey which has been done in the CIR countries. And for if we want to see the continuum of care, how many are controlled out of the people we are suffering from hypertension? If there are 218 million people suffering from the hypertension, which is estimated number which we have. Only 24 million people are having their disease control. So this is the gap, and what I have presented in my earlier slide need to be addressed. How we can measure the success, and for the NCDs there are different components. For hypertension we know that what is the blood control rate. Similarly for the diabetes, asthma, whether the exacerbation is controlled or not. Cancer, whether we are able to provide treatment in the early stage of the disease. For rheumatic heart disease, whether the continuity of treatment is there or not. And for the palliative care, whether the access to morphine painkiller is not there. This is the success of the NCD services being measured as a patient outcomes. So these were the challenges, how we can address those, and especially for the service delivery part. And if we want to improve, one has to focus on the relationship management, the management relationship between the healthcare facility as well as with the person coming to the health facility. And if the person has been diagnosed with the disease, there should be a proper referral coordination should be there. There is provision of refilling of medicines at the regular interval, and most importantly, the recall reminders to the patient that their follow-up is due or their further diagnosis is due. So that recall reminder. So what will be the benefit that we have more patients closer to the PSC, unnecessary overcrowding of the hospitals, and unnecessary travel, which cause financial hardship to the patient. So the continuum of care, as I have mentioned, based on the screening, the diagnosis, the treatment, and after the treatment, the continuity of care, and it requires complete service reorientation with the people-centered hospitals and primary healthcare providers. And what it will actually benefit is treatment control and the treatment gap. That particular that gap will be reduced, and overall the NCD mortality, the stroke, heart attack, and CKD episodes will be reduced. So I have talked about all this from the continuum, from prevention to the palliative care, the entire spectrum, and this has to build on the health system component, the 6 building blocks of the health system, which will carry all this to the continuum of care. Continuum of care also has that integration component. So what we mean by the integration first means whether in the NCDs these services are integrated or not, whether CVD's services are integrated with the diabetes, whether cancers and other rheumatic heart diseases, stroke care services are integrated within the system. And once it is being integrated, how we are going to integrate or link with the communicable disease or sexual reproductive health services. And once that is also integrated, then integration across the health system is basically how you move from starting from integration from the NCDs to the this one. So and it cannot be done without having a partnership triangle. So what is that partnership triangle? Is basically a NCD department at the state, at national level. At one angle, we have knowledge partner like UN agencies, research institute, academic institute, civil society organization. And at the third angle of the triangle, which is the healthcare providers and the community. And the basic services which is provided will be across all this, from whether it is rural, urban, or tribal, from the primary healthcare to the medical college level. So what are the benefits basically of the primary benefit is that of people-centered care is it improved individual and population level health count. And overall, there is a satisfaction among the patients and their families. They value the health services more. There is a sense of ownership at the community level. And on other hand, what we get at the healthcare level is better image of the healthcare facility and the care providers. There is improved self-esteem, morale, and productivity among the healthcare providers. It overall improved the efficacy of the health facility and saved the cost, unnecessary cost to the providing the which patient also bear some of that cost, and overall improving the accountability in the system. So if we implement this continuum of care or people-centered care, what are the benefits? So these are based on the literature review, and it has been found that 75% of the patients who value seeing their they value who are providing their services. There is decrease in the primary care medical cost if we provide the people-centered care. 17% reduction is there. 4 out of 5 people with mental health can be managed at the primary healthcare level, and there is reduction in the 13% in the hospital admission. 27% people requires fewer emergency department visits. Overall, there is 19% reduction in the care cost level across the system, and so what are the enablers? Sorry, the screen is popping up, so I'm finding it difficult to see on the screen. So what are the enablers especially? So we need a dedicated department at the state level as well as the ministry of level to provide stewardship. At the state and district level, there is need of administrative and supervisor system for the health system. There is need for the use of protocol-based NCD management, equity-focused NCD policies and programs, especially the health insurance, access to the essential medicines and diagnostics, and the human resource deployment practice is required. And it will not be done in a single day or within a period of time. It is a gradual process. It takes time, and it takes around years to develop this people-centered care or the continuum of care. So we need to start somewhere, and already the government of India has initiated this in the health and policy, in the national health policy, this Ayushman Bharat program, which will help in establishing the people-centered care as well as the continuum of care. So as the as the participants, which we are from the community medicine and the public health discipline, what we can do, we have our rural health center and urban health center attached to the medical college. So can we set up a robust care model for the NCD, integrated people-centered care, at our the health facilities which is under the department? And can we systematically document the lessons and deepens the model, and share that learning with the state, with the districts, and then with the state and at the national level to further have a proper people-centered NCD care. So I will stop here, and if there are any questions, I will be happy to answer. Over from my side.
Thank you so much, Dr. Joshi, for your excellent deliberations and presentation. I think you covered almost every aspect. However, there are 2 questions, and I don't know, I think the decision was that we go ahead with the questions and by the end of the session. So maybe Dr. Harshal will be able to take up. And just to address a few points that you have raised, very important points there are. So say for example, if a lady is diagnosed by VI testing in the field that she may be having cervical cancer. Now, if she has no access to further go and confirm her, diagnosis and get the treatment, then the efforts of the government of India, will be wasted. So the government is trying its level best to maintain that continuum of care, and a lot of things are being done. And we are also planning a very big brainstorming session on how to, take this continuum of care ahead. And because there is a whole, group of experts today joined here and listening to us, and maybe we are also going live. So my request is that you may contribute to this cause as and when you want. You may contact whosoever is your HOD in the medical colleges, or you can write to me also anytime. My mail ID is there, and to Dr. Joshi or to Dr. Bari or Dr. Harshal, who are all involved in this kind of activity. And we will take your suggestions, because there is always, currently our new DGHS who has taken over, he always says कि कुछ नया नहीं किया तो न्याय नहीं किया. So that means let us think out of the box. Maybe we are missing out on something. Maybe we can, really do something. So let us not think that we have explored everything. So in the ministry, in the directorate, and in WHO, there is a huge, momentum right now to look at things from all angles. So even fresh candidates and fresh students who are sitting, and people who are especially working in the field, they need to reach out to us. So as we always talk as community health professionals, bottoms up approach. So I think in thinking also the bottoms up approach will work very well. And let us hear from our peripheral people that what are the challenges. And I think who better than the Department of Community Medicine to kind of, give us those inputs. So I think for various activities, I have been including the community medicine department across the country, even for burns and all. When we were having so many studies that are going on, we decided to include the community, because see, the community medicine department reaches to the the grassroots level, and their understanding of the grassroots level is really immense, and we need to utilize that. So again, thank you very much, Dr. Joshi. That was an excellent presentation, and I think it will help the students who are connected with us today to kind of understand what is NCD screening, and how we need to go ahead and maintain that kind of a continuum. So coming to Dr. Harshal Salve, can I have his yeah. Can you please enlarge it a little bit? I'm extremely sorry, a little bit. So Dr. Harshal, yeah, thank you so much. So welcome, Dr. Harshal. Dr. Harshal R. Salve is additional professor, Center for Community Medicine at AIIMS, New Delhi. He has a 13 years experience of being a physician, teacher, and a community-based researcher at AIIMS, New Delhi. Dr. Salve also works with the Ministry of Health and Family Welfare, Government of India, then state level and international agencies such as WHO on various expert committees, research projects, and technical reports. His major areas of work are NCDs, climate change, air pollution, mental health, and health system research. Dr. Salve is a member of WHO Collaborating Center and Minerva at AIIMS. Dr. Salve was part of inter-ministerial central team for assessing response of COVID-19 pandemic in the state of Maharashtra and Rajasthan. He is also contributed in generating awareness regarding COVID-19 among general public on print and TV media. So Dr. Salve has an experience of working in 15 funded community-based research projects. He's a coordinator for collaboration on air pollution and health effects research in India, funded by Health Effects Institute, Boston. He has 50 publications to his credit in national and international peer-reviewed journals. Dr. Salve has written a chapter on mental health in IAPSM textbook of community medicine. So welcome, Dr. Salve. Excited to hear from you about the assessment that you have been doing for continuity of NCD care in India, the approaches and findings. Over to you.
Yeah, thank you, Dr. Jain, for the introduction, and very good morning to all chairperson. And again, thanks to organizers, Dr. Sitanshu, and good morning to all participants who are attending this session. As Dr. Joshi rightly mentioned about theoretical aspects of the continuum of care and its importance, so it was a right time to assess its implementation on the ground. And also we all know that the COVID-19 is a sort of one of the pandemic which devastated all the health system across the globe, also has a repercussion in India as far as the health system is concerned. So with the help of Ministry of Health and a WHO India office, we have carried out this, and we are still in the process of carrying out this exercise of assessment of continuity of NCD care in the states and UTs during COVID-19 pandemic in India. So in this presentation, I will briefly present its approaches we adopted and the interim findings. So these are the teams from AIMS, along with me, Professor Balidalin and Professor Anand Krishnan are part of this exercise. And as Dr. Jain rightly mentioned, the expertise across the country should be leveraged for such activities. So we have involved 11 institutes in the country across which is spanning across the country, and 19 resource persons who are the faculty members of the community medicine who are extensively involved in this activity, starting from development of tool to the doing the field visits and assessment at the district level. So this will be the outline of presentation. So we all know that COVID-19 disrupted the health services, and Ministry of Health rightly put up a sort of a guideline that essential services should be ensured. And in response to that, few states also took extraordinary steps to continue the essential services, and NCD was a part of it. And this was the right time to assess as well as to document this good practices, which is help to continue the NCD services at various levels. So that's why we took this activity with the objective to assess and document best practices implemented for optimizing the managing essential NCD services at the subnational level during the pandemic. And this will ultimately lead to the development of the guidance framework, so that will help the country in future to implement the NCD services during emergency situation. So this was a cross-sectional study with the mixed design with both quantitative and qualitative approach. The reference period of study was from April 2020 to July 2021, so that we can capture both the first wave, we commonly call it, in 2020, and the second wave in 2021. And this was a pan-India study covering 28 districts and 14 states. So it has a two component, interaction with the state program officers and district level assessment by the field visits. The interaction of state program officers was done from the AIMS New Delhi team, and it was a virtual in-depth interview was being carried out currently. And this was focused on all these aspects which are mentioned in the slide. The quantitative assessment was shared using a checklist and the structured pro forma. It was mailed, and we are happy to inform that we have got a good response from the state program officers with the guidance from the ministry. So these were the districts which were chosen across the country. You can see, so we have divided country into 6 zones, and 2 districts in the 2 states, which is one is high performing as far as the NPCTC is concerned, and one is not so good performing were selected, and 2 districts in each states were chosen for this exercise. And these were the institutes which also collaborated with us during this very important nationally relevant activity. So in this exercise, the district during field visit, the district facility were visited, a district hospital, one CSC, one health and wellness center, one PSC were visited. The stakeholders such as district NCD officer, district nodal officer, medical officers, MS of the CSC, your CHOs at health and wellness centers, the medical officers, ANM, ASHAs. So all important stakeholders were covered by using an in-depth interview. And also health facility checklist was also carried out for assessing the facilities related to the NCD services at various levels. All these tools are developed by taking reference from the existing WHO guidelines and WHO tools which are available. Also, there are some tools which are available from NHSRC, and we also have some tools from a national NCD monitoring survey which is done by the ICMR. The series of consultation were taken up with the ministry, with the WHO India office and AIMS, and also the senior NPCDCS program officers which we have in the country. So inputs from all of them were taken so that the comprehensive tool was made. As I mentioned, one of the objectives was to document the good practices. So we decided to document the good practices on all these domains at district level, block level, and at the community level. Coming to the brief about the so far we got. So covered 10 state program officers. It has been almost nearly 2 months from when we have started this activity, and field visits are completed almost 68% of the districts. And the transcription, this is the qualitative data. So we are in the process of doing a transcription and analysis. Briefly about the impact of the COVID-19 NCD services as far as the infrastructure, we have seen, as this is an interim study finding, we are not going into details about the district level and the state level kind of issues. So a summary of the findings has been reported in this presentation. So 35% of district didn't had a dedicated infrastructure in the form of dedicated NCD clinic or separate NCD ward. And NCD, it has been observed that NCD clinic were closed during national lockdown in the 2020 in the most of the districts. Obviously, there were a few exceptions. And though OPD were closed in the first in the year 2020, the patients were seen in the emergency department. Like people were coming for the follow-up in the hospitals. They were been given the medicines in the emergency care. As far as the human resource, due to the priority in the COVID, at most of the places, the human resource were diverted on the COVID duty, but the recruitment process did not stall. As far as the capacity building activities are concerned, though the priority was the COVID-19, and a few of the districts and the states took up the online capacity building after the subsidence of the peak of the COVID-19 this year. Coming to the drugs and equipments, at most of the places, the drugs and supply were ensured. So there was no disruption reported at the district level as far as the supply of the essential medicines and availability of the essential equipment for NCD care are concerned. Most important services which got disrupted are the laboratory services, because at the district level, most of the laboratory technicians either are deficient or they are being given multiple responsibilities. And during the COVID-19, all were diverted to the COVID-19 related activities. So most of the dedicated NCD related laboratory services were affected during COVID-19. As far as the patient flow is concerned, it was reduced by 30% during 2021. So this is an important thing to notice, that during the first wave 2020, the hospitals were sort of closed because of the sort of start. It was the start of the pandemic, and there was a panic and some hesitancy among hospitals was there. But during 2021, this year, the patient were under sort of some panic and the hesitancy to visit hospitals, though the most of the hospitals were open during this year. Coming to the good practices, I will document few good practices which we have observed so far, which we have analyzed so far. Obviously, there are more to document in the subsequent time. Coming to the Lucknow district, so they have used the technology appropriately. They call it as a Hello Doctor helpline, where since HR involved in the initiatives, almost 212 doctors from allopathy, homeopathy, and Ayurvedic discipline were kept on the board, and they have also took help of the state IMA, Indian Medical Association chapter, and also the interns from KJMC were enrolled. The basic Shiksha Adhikari primary educations were enrolled in this. 30 telecalling operators were put up, and 3 command service centers and 3 networking experts were put up. So this was a initiative of Lucknow Administrative, Lucknow Smart City in the first COVID wave. Free of cost consultation with the expert across 22 specialties were given. Obviously, NCD was among the priority, and also provided consultation with homeopathic and Ayurvedic doctor, and also included the home delivery of the medicine with the help of field level staff. And the feedback was very good, which has been reported from the patients. So this graph shows the teleconsultation, which was there. You can see in the peak of the pandemic, there was a teleconsultation where sort of peaked also. And as the services were normalized, the teleconsultation went down. Coming to the another important service continuity, what we have observed in the state of Goa, that with the help of PPP, the hemodialysis services were provided in the Goa, and it is continued in all health facilities, both in public and private. And the government has ensured that the travel passes issued to the staff of the center to ensure the uninterrupted travel, and also to the patient during the peak of the pandemic. And the separate ESI hospital was identified as isolated dialysis treatment for COVID positive patients. And two also new dialysis center were launched during the COVID-19 pandemic in one of the CSC and the PSC. So this we have seen that this is a good practice which is done by the state level, and it is being evident in the numbers as far as the patient services for dialysis are concerned. We have also collected the patient perspective by observing at the health facility while their exit. So I will briefly present its finding. So far we have the data about 142 patients. We have seen that most of the patient have not adhered to the treatment of the NCDs, and most common reasons: unable to refill medicine, did not visit health facilities, unable to reach facilities due to transport related issues, facility was closed, and unaware to daycare facilities available in the districts, and medicines were not being provided at the villages and the facilities. We are doing the detailed district wise and the state wise analysis on that. Coming to the risk factors and how they have adhered to the risk factors during COVID-19 pandemic. So as reported for the medicines, 72% they haven't seemed to be adhered to the medicines, and also a similar trend was seen for the other behavior related risk factors. So you can see here, though the regular consultation was reported almost half of the patients. As far as the patient's awareness and the receipt of the services given by the government in terms of longer prescription was only reported by the 11% of the patients. The SMS and the messages for continuity of the medicines has reported in 13% patients. The teleconsultation service has been taken 11% of the patient, and home delivery of the medicines received by 22% of the patient, which is reported so far. So key takeaways so far of as far as our observations and the analysis of data we have done so far. The NCD services affected due to diversion of the HR mostly to the COVID care in spite of availability of the adequate drugs and the equipments. And the disruptions was majorly from the provider side during 2020 and from the patient side due to restrictions and the panic in 2021. The laboratory services were most affected, and good practices were observed in the domain of use of information technology for consultation and the field stuff for home-based drug supply and ensuring the compliance to the medication at the patient level. As I mentioned at the beginning, this is still work in progress, and we will definitely like to present our full, once we have the full information and the observations ready with us in the subsequent opportunity. So let me thank the Ministry of Health, Family Welfare Government of India. Dr. Tanu Jain is here, Dr. Rinku Sharma, who have contributed immensely from the beginning and who provided all support for this activity. And World Health Organization India Country Office, Dr. Pradeep Doshi is here, without which we could not have done this activity. Thank you so much.
Thank you so much, Dr. Harshal, for summing it up and sticking to the time. So this was an excellent presentation, and I know that the researchers have really been, thrown into a kind of a situation which is unprecedented, and all the things that we, set out to do now, they had to be changed. All the plans had to be changed because of the COVID pandemic, and so we have learned a lot because of this. So it has been very challenging for the researchers to modify and go ahead. So what we were thinking that we look into, instead of that, we ended up looking into various things. But I think this pandemic may not be the last pandemic, maybe of the kind of pandemic that this one was. Maybe we have a different challenge. So I think with research like you that you are doing, this is very good that you're bringing out the best practices and what the states are doing. Also, when you're trying to now go to the states and visiting the districts, just keep in mind that if certain kind of pandemics or epidemics keep on erupting, so the disruption chain that is going to be there in the continuum of care, how that can be tackled. So I think that also becomes an added kind of an objective for you now in the study, which will yield a very good result. And there is obviously an eSanjeevani platform which we are developing in the ministry side quite vigorously, trying to do all the activities through eSanjeevani. But any fresh ideas, any new innovations from all the participants who've joined today, most welcome, because you see, you're going to field and you're doing a lot of research at the ministry. When we are sitting in the seat of DDG, there is so much of implementation and policy matters going on. Becomes difficult for us to actually sit down with the researchers. I know I've been trying to sit with Dr. Harshal for so long, but somehow it had never happened, because you're looking at so many programs, and then every time you are into so many policy decisions and policy meetings. So I think it is very important that the researchers take a lead in guiding the ministries, across state ministries also, like the state also. So without taking much time, I think I need to now hand it over to the hall in charge or to Dr. Bari. I think from my side, thank you, extremely, concise presentation. Thank you, Dr.
Can I just add one point, Dr.
Sure, you're most welcome.
So in addition to what Dr. Harshal and his team is doing at CCM, we also undertook an activity to look at the client's perspective during this phase. So they took exit interview, but we're in touch with some states to get the details about what problems they faced, what are the issues and challenges, and also trying to document the evidences available in the literature regarding the disruption of NCD services during this phase. So I think this two components will go hand in hand, and thank you, Harshal, for such a nice presentation. Thank you, Dr. Tanu, for reiterating the fact that researchers should also play a major role in the decision making, and as a team approach, we should try to move forward. Thank you so much.
And also, I think very important for me to emphasize over here at the directorate, we have seen a major change with our new leadership, and I wish that all of you can change in that pattern. Like how our DG sir always says कि जब तक आपको रात में नींद नहीं डिस्टर्ब हो रही है सोचते हुए कि इस चीज का मुझे आंसर क्यों नहीं मिल रहा, till that time we as doctors, we have not fulfilled our job. So जैसे कि a surgeon would think कि मेरे को सुबह में क्या steps करने हैं, simply a researcher has to think कि भाई कहीं तो problem का solution है और वो मुझे ढूंढना है. So I have to look for that solution. I have to move in that direction. I think we need a lot of support from the research fraternity here, because we are facing very, very unprecedented times. So looking forward to a lot of support from the research to come and help the program implementation. Program implementation cannot happen unless we have good research backing, evidence backing, and a good team at the field to ensure that it happens. So these are the two, things which will complete the loop. Thank you, Dr. Sitanshu, for giving this opportunity.
Thank you. Thank you.
Thank you. Thank you, Dr. Tanu. And am I audible? Okay. Can I get the?
Yes,
Yeah. Can I get the introduction of the next speaker? Coming to the next part of the program, it has been a very exciting initial two presentations setting the stage for the COVID, and Dr. Harshal had mentioned a bit about the best practices that we had encountered during this study that we are doing, a pan-India study. And I believe that Dr. Anmol Dongre is also going to share a little bit more about provision of care during the pandemic and sharing of best practices. So without further delay, I would just like to introduce Dr. Anmol. He is working as a head of the extension program of SPARSH in the Department of Community Medicine and Medical Education at Gujarat. As an international fellow in the medical education, he has completed his master's in health professions through the FIMER program. He has conducted 20 national level workshops in qualitative research and 6 workshops on mixed method studies. I'm sorry. Okay, he's a faculty of the PSG FIMER Coimbatore and Manipal, India, and also at the FIMER Regional Institute, Philadelphia. So, Dr. Amol, it's a pleasure to welcome you here to this program, and then we look forward to hear from you as you share the best practices of provision of care during the pandemic. Over to you.
So thank you, Dr. Baridale, for your introduction, and good morning to all of you. Is my slide visible?
Yes, it's visible.
Right. Thank you for the feedback. I'm going to share a care of NCD patient during under SPARSH during COVID pandemic. SPARSH is a program started by Charutar Arogya Mandal in 2015, and it means Shri Krishna Hospital Program for advancement of rural and social health. So we are the team. I have joined this program in the month of April when the pandemic was at peak. And on behalf of my team, I'll be sharing how the continuity of care was ensured during that period. Now, this program is looked after by the Department of Extension Program in Iphacon University, Kadamsat, Gujarat. So let me give you a brief background about this program. So Charutar Arogya Mandal, which is now Iphacon University, started this community-based NCD care program, and it is there for last 1 decade. But in 2015, some revisions were done to meet the requirements in the given context. This program runs in 150 villages of Anand, Kheda, and Panchmahal district of Gujarat. And a team of female village health worker, field supervisor, social worker, paramedical staff, medical officer, under the Department of Extension Program, look after this program activities. Now, this program has been organized at 3 levels. One is primary level, where the primary health care to NCD patient is given through mobile health team with the support of a trained female village health worker. And they do the screening, they offer medicine, they give health education to the patient. And at secondary level, we have 3 extension centers. And at tertiary level, we have a medical college, which offers treatment for the complications. So this is a 3-tier care model under this first program. So this program, when it was started, so to begin with, they did a village level enumeration to identify the beneficiaries. They trained female village health workers in NCD care. And then the treatment protocols and health education materials were developed as a part of the project. And the focus was on giving individualized healthcare to NCD patients at village level. So mainly the services are provided through village health camps and health clinics. And these are some of the photographs which shows the moments captured in the field, that how the enumeration was done, and how health clinics run with the help of medical officer, and how the follow-up and how medicine packets are delivered at home. So mainly the program focuses on diabetes, hypertension, and screening for cervical cancer and oral cancer. And it also offers care to common mental health problems through Department of Psychiatry and palliative care. Now, what happened during the pandemic? There was a lockdown, there was restricted mobility, and face-to-face interactions were not possible. And that was the major mode of delivery of care, that you need a contact with your patient to deliver medicine, to give them health education. And most of the focus shifted to the COVID care. So there was a neglect of routine patient care required to this NCD patient. And there was an emotional reaction both from the people's side as well as from the health staff's side. And people had a big apprehension for getting into any mobile van for any checkup. And they were apprehensive for having any visit from any medical team to their village. So how did the SPARSH team address this apprehension? Because that was the major barrier in continuity of NCD care at that time. So the team approached village sarpanch to gain their confidence and trust that we are not going to do any testing for COVID, but we are here for continuity of care to those NCD patients who are enrolled with us for care. And then Panchayat made an announcement that the team is going to deliver medicine and not for any COVID test. So there was an apprehension. And when team approached, they also took the help from the community volunteers who came forward. And when the care was given, they also used this opportunity to educate patients about COVID appropriate behavior and its importance for their protection and community members' safety. So team followed the COVID appropriate behaviors for delivery of medicine, and the protocols were developed. And in some cases, the help from ASHA and body workers were taken. So they made their all kinds of efforts to reach out to all the available portals to reach out to the community for giving the NCD care. And there were lots of qualitative findings emerged during discussion, and it was found that many patients started reducing their medicine dose because they wanted to continue their treatment, and they themselves started reducing and adjusting the dosages so that they can continue with the drugs that they have. There was a little bit change, a small change during the delivery of care in pandemic time. So the main thing that was there at the village level was female village health worker, and she did a follow-up with those patients, and the telemedicine guidelines for that were followed. And she used a mobile phone, did a video call with the assistant medical officer and medical officer. And assistant medical officer and medical officer already had an access to the patient records. And the video call, the video call which was facilitated through VHWs, village health workers, was the major interaction between the AMOs and MOs, and they could ensure continuity of treatment for those follow-up patients. And of course, they required support staff who packed them, such as pharmacists, who packed the medicines in the offices and dispatched it back to the villages for the delivery at their doorstep. And the team also required the support from IT team so that the virtual communication which was happening during this time was seamless. So there was a requirement for training of program staff and field staff in use of these electronic gadgets and understand the nature of communication and the requirements. And so they used Google Meet, Google Sheet, Zoom calls, telegrams, and communication over phone. So if you see that they used variety of platforms for interaction and variety of platforms for online platforms for communication. So this is just one example how Google Sheet was used for assignment of tasks, giving feedback, monitoring of the assigned work. And the work was highlighted in the local newspapers stating how team ensure continuity of care. And now we are in process of setting up health ATMs in villages, which is a kind of an integrated machine where we can interact with the patient virtually and provide them medicine through our health ATM centers. So we have set up 2 health ATMs so far now on that. So the outcome of these services during COVID pandemic, that the team could provide care to 1,900 registered NCD patients in 150 villages, their routine medicine at their doorstep. And 44 patients who were on palliative care with the team continued to receive their care. And 129 poor patients who could not afford medicine, there is a mechanism for providing medicine free of cost to those patients. Under the scheme, student-run initiative scheme called Aushati, and through personal donations. And 84 immigrant labor families stuck in distant village in Kapadganj were supplied with ration kits for 15 days. So these are some of the moments from the field. how team carried out their various activities. So if we abstract out what lessons we learned from this experience, then the first thing that it was an interprofessional teamwork. So we required coordination from IT, from social work, from community and technical people working in the department. Then the second lesson that we draw from it is that the network community is more resilient. So that means using the different options and portals and connecting them with each other. And here, the virtual connections really helped them to achieve. And the complexity theory says that the more networked community we develop when we do program intervention, the more sustainability and resilience we develop in that program. So the team already had some experience of using this online tools and apps, and that prior experience helped them to cope up with this new challenge. So in future, I think we are already in process of having telemedicine and telehealth. But if it's continued or strengthened in the future, that will help us to sustain such kinds of challenges in the future. So training of staff in use of technology and use of technology in communication were the key for the success of this team in delivery of their care. So we acknowledge Sir Dorabji Tata Trust and GMM Fodler for financial assistance for this program, and all the patients and caregivers. And if you wish to have a look at the various training videos the team has developed, you can visit our YouTube site to access the various trainings videos that team has developed. And if you have any more questions, you can write an email to me or call at the given number. So since I have joined this program in the month of April, I could learn a lot of things from my team members, and I requested two of them, Mr. Amit Bhai and Mrs. Nasrin. They are sitting with me. So if you have any question, you can have a direct interaction with them. So thanks to Chairperson and Dr. Sitanshu for giving opportunity to allow us to share our experience on this prestigious platform. Thank you very much.
Thank you, Dr. Amul. That was really very interesting, and it is so encouraging to know that despite all this gloom of the pandemic, there was a lot of activities and innovations from Sparsh. In fact, I've been working closely with your previous head, before you joined, Dr. Shamsundar was there. So yes, so Sparsh has actually always been it has been an exemplary. It was a sort of a case study that we had always referred to when we talk about team-based care. So and I'm really happy to see that it has progressed further from the mobile-based activities and the innovations that you have been introduced in the during the COVID time is really something that I feel others should also learn and take a positive message from. There is a need to actually build linkages with the private sector. That's what we feel. Dr. Harshal has showed you the examples or the experiences from the public sector, but there is actually a need to also learn from what the private sector is doing, community-based organizations, NGOs. I think everybody has really contributed to improving the NCD care in our country. So really thank you for this excellent presentation, and I'm sure the listeners here would, those who do not know about Sparsh, I think they would really get an opportunity, or at least see what are the other activities that you all are doing. I personally know it, and I'm really quite impressed. And also, what you did not mention, Dr. Amul, is that your Sparsh is also the Innovation and Learning Center of the NHSRC. Yes. So that is one of, there are 6 centers in India, and Sparsh is one of them. So I think we will really have to work together to develop this kind of coordinated care, particularly to improve the management of NCD patients in our country. Thank you so much.
And that's really helpful, because whatever lessons we are learning from Sparsh is helping us to use those in our ILC activities as well.
Right, right.
Yeah.
Thank you so much. So with this, we go on to the next speaker. Oh, Dr. Sitanshu. He doesn't need any introduction, does he? So I think we do not need to introduce Dr. Sitanshu now. Sitanshu, I will not waste time. I know you have done a lot and people know about you. So I will just like to directly call you to share your experience about ensuring NCD care during emergencies.
Thank you so much, ma'am, and thank you for saving time, because 10:30 we have to start the oration, and thank you so much. It was a lovely discussion that is going on, and that's exactly the thing that we decided with Dr. Pradeep when we thought about this panel, that how do we look at NCD services and how do we ensure continuum of care. And in this, we initially thought that let's look at the idealistic situation, which where Dr. Pradeep came in, then a research finding where Dr. Harshal came in, and also to look at how the best practices is there in this country, to look at that and get some learning out of it. And finally, about how integration of NCD care in emergency response would be there. I have a disclaimer to tell, because this was supposed to be done by one of the NDMA representatives of Tamil Nadu state government, but somehow things didn't work out. So I'm pitching in. I'm not an expert in emergency response in this, but however, I'll try to do whatever best I have learned in this process of engaging with NCD services or NCD program over a period of last 10 years. So that's why. So to start with, our acknowledgement to WHO Country Office for India, Dr. Fikru Tulu, WR, Dr. Fikru Tulu, and Dr. Pradeep Joshi and his team for agreeing to support this plenary, and a lot of learning, mutual cross-learning has happened over the process. And this is what we are going to talk about in the next 15 minutes or so. So we'll first look at what is an emergency. Then we move to NCD services during emergency. We have heard how it has been, disruption has happened, but how to prepare for the future pandemics and how do we integrate the NCD services in our emergency response plan, and where are we now? So these are the four basic headings in which we are going to talk about today. So let's define what is emergency. So as we all know, there are two terms that comes to our mind when we talk about such humanitarian response. One is emergency and second is disaster. So yeah, emergencies are events or incidents that require action that is usually urgent and often non-routine. That means with your normal available resources, sometimes it is very difficult to handle such situation. We know the examples. Similarly, what is then disaster? Disaster are the large-scale emergencies. So there will be serious disruption of functioning of a community or a society involving widespread human, material, and economic losses, and that will require help from outside the community. That is what is the key point in this. So then when we're talking about all these emergencies, the next question comes to our mind: are we at risk? Is India at risk of having this type of disasters or at emergency differently? So now if you look at this map, there are different color-coded things that are being portrayed here. If we look at the left-hand side of the screen, where we, let me use the pointer. Yeah. If you look at earthquake, flood, cyclones, drought, and landslide, you look at the total number of percentage. So we are massively affected by this. We are prone to have disasters each year, and we are facing the same problem. So if we look at between 1970s to 2009, what has happened in India? India experienced around 371 natural disasters. Almost 1.5 lakh people were killed and 1.86 billion were affected. But you can very well ask, but we don't have so many people in this country. But it is repeated, the same activity is repeated again and again. So that's how the numbers are calculated. Now, the most frequent disaster in India: flood, cyclone, landslide. So with this background, now let's look at the index for risk management or inform is a risk score of natural hazards. Here, what is usually done is it's a score between the hazard and exposure that happens because of various natural calamities and the vulnerability and the lack of coping capacity of the country, and a risk is calculated. So if we look at India, India is at a vulnerable score of 5.4 out of 0 to 10, and lack of coping capacity is at 4.6. So we are 5.7. But if you see, look at Myanmar, it is the highest 6.6. We are almost there. So India is at a risk of, getting all these disasters often and we are at risk, and we need to do something about it. Now coming to the what happens when there is emergency is there or a disaster struck a particular region. So there are these 7 or 8 points that happen. The first thing that happens is there is interruption of care. It is understandable because everything is disrupted. So people will not be available to provide care. The services, health centers will be closed. There will be sudden shift in priorities. People will try to save lives without looking at the routine services being provided. Next is the health facilities will be shut. People will be not there. Either the health facilities will not be there or it is closed. There will be changes in the living conditions and increase in risk of in patients with pre-existing disease. So precipitation of diseases will happen. Medication adherence invariably will decrease. People will not get medicine because of the other factors that we just discussed. And ultimately, with normal stable patient, it may lead to a crisis situation. So this is how emergency affects the healthcare provision. Now, when we look at the NCD care during emergency, the first thing that comes to our mind is because NCD is a lifelong condition, it needs treatment over a long period of time. Continuation of ongoing treatment becomes a major issue during the emergencies. And with that, as I told you, there is precipitation of the care where acute emergencies are also coming out. What will happen is treatment of acute complications will be required, and there is disruption of the referral mechanism. So we have to ensure that how those people who develop acute complications are treated in a more comprehensive manner. The third point is the adjusting for reduction in people's ability. The normal situation, there is a coping mechanism that undergoes. But when there is an emergency, people are dealing with multiple things. Their own things were lost, people are dead. So all those mental health issues are also comes to the forefront. The last point is coordination of care and follow-up should be there. And we need to see that how things can be arranged in a more logical and a more coherent way. So if we look at that particular response, then how do we plan? What are the things that we need to do? If you this NCD management, as per the Slama's paper in Lancet, it has got 3-phase response. First is mitigation or preparedness phase. The second is emergency phase, and third in post-emergency phase. Now, what are the things that we should do beforehand? First, we need to identify the NCD, the priority NCD conditions. What are the, because it's a range of diseases, what are the things that we should include in our priority condition? How do we do that? Then the second is pre-emergency profile of NCD. Before the emergency struck, let's look at what is the distribution of these diseases, how it is, what are the more common things that are present in our population by looking at the prevalence and the mortality, morbidity and mortality statistics, looking at the health facility readiness and availability of essential medicine. So this is the, in the preparedness phase or in the mitigation phase, this can be done. The second thing is integrating when there is an emergency. How do we integrate NCD care in the rapid assessment? Map NCD services provision. We have to look at what services can be available where and how can we organize the service delivery mechanism. Then the post-emergency phase, how did we do? Did we do better or did we do worse? So that is what we should look at, lessons learned, strengthening the health system's response and developing some monitoring indicators so that you can track it over a period of time. How do we proceed further? So in this plan, there are 5 or 6 points that are given by the integration of NCD care document. It's a very nice document. I'll encourage all the participants to have a look at it. It was published in 2018. how do you map your NCD profile? So in the mitigation phase, there are tools available which helps us to quantify the burden of the disease. Then we look at different type of health facility preparedness plan and NCD service delivery readiness. The drugs availability, WHO PEN package, WHO is PEN package is package of essential NCD services available in primary care, support of patient-tailored disaster plan. So these are the list of things that should be done in the initial phase. I'll take you to the next phase where emergency has struck and how do you handle it. Includes first thing is, because whenever there is an emergency, there is a rapid assessment that is usually done. So this can be done using various types of tools that are available. Casper, Mira, the full form is all given here. Multi-cluster or initial rapid assessment techniques. You can map the NCD services provision. An important component is 4 Ws. Who will do where and when? That is what is very, very important during emergency, to have a coordinated effort from all the sectors that come together for a joint action to save life and reduce the suffering. So organize NCD services delivery with a focus on primary care. I'll just pay a little more attention to this particular component, which is there in my next slide. This is interagency emergency health kit. So there are basically in the how do we plan when there is an emergency and what type of health kit should be made available. There are basically 2 types of units that we consider during this point, is basic unit and supplementary unit. In the basic unit, the drugs that should be available or technology should be available, which can be done by the healthcare workers without having any training. In supplementary unit, we usually do by physicians. So this 2 components should also be kept in mind. In the post-emergency phase, we have to relook at our health system, reassess our plan, and try to move forward. So how do you, the framework of integration has 2 components. One is minimum response. So high priority responses should be implemented at the earliest. We identify those conditions and then try to look at how do we address those issues, like the minimum initial service package for RCH services. Can NCD be included in this package? Second is the comprehensive response. Once we have achieved the first one, then we go to the second part. In this minimal package and comprehensive package, conditions were defined, and there are also slow onset emergencies were also defined. So then what are we missing? If you look at the 3 phases that we just talked about, in all these phases, we are at a very nascent stage of our planning. What we need to do is we need to focus in each of these plan areas, like identifying priority condition, integrating NCDs in rapid assessment, and what are the lessons that we have learned from our previous pandemic to come together and should have an NCD management plan. So I have taken all these references, the topic for discussion today from this booklet. It's a beautiful booklet, and I'll encourage all of you to please have a look at it. And I'll stop here so that we can have some questions and answer sessions. Thank you so much, ma'am.
Thank you, Sitanshu. That was a very brief orientation. At least I hope the postgraduate students who are listening here must have gained a lot about this, the different perspective of handling emergencies and disasters. Because so far, whenever we talk about disaster management, we think about outbreak of diarrhea, of cholera, or all these infectious diseases, but we never really think about NCDs as a part of disaster management. But I think this has really brought a different light or a different perspective to the whole plan of disaster management. And I think this is a very important initiation. It would require, I think, maybe half a day workshop. We really need to do so. Yeah, so I'll hand over to Dr. Tanu now to conduct the question answer sessions if we have time.
Yeah, so I think we have still got 7 to 8 minutes to go. So there are a few questions which are online, but do we have a provision of taking offline also direct questions from the participants? I think I'll request Dr. Sitanshu to take us through this question answer session, because probably they will be in a better position to handle it.
Yes. So what we'll do is we'll have a look at the chat box, ma'am, and then we can go for one question. There is one or two questions which are not related to probably our session. Like the first question was, what all are included in population-based NCD screening? So probably Dr. Bari, ma'am chairing, but Harshal, would you like to take that?
Harshal, you're muted. Please unmute yourself.
Sorry, as per the Government of India initiative, this is a mammoth exercise, I will say, that includes the screening of hypertension, diabetes, and the 3 common cancers, that is oral cancer, breast cancer, and the cervical cancer so far. But I'm sure this basket is increasing in time to come. Definitely, we will have more diseases to be included. But definitely, this is a mammoth exercise which is being undertaken in entire country by the ministry.
Yeah, I agree with you, Harshal, that we really need to increase this basket. But it's a good start. And it's a good start in the sense that we'll have the service delivery platform ready with us, with a smaller amount of job on our hands. So 5 diseases, if we are able to deliver on that, we can build up on that in times to come. But currently, maybe this is a good idea to have a few diseases and build on the service delivery platform and strengthen it.
One more point I want to add here, that each state also have modified accordingly. So few states have also added few diseases in the population. Some state tuberculosis, some states added leprosy. So it's very sort of dynamic and provided good opportunity for population level screening.
Exactly. That's what I meant, that if the service delivery platform is there and the states add on to it, and then it's a cycle of learning from state to center, from center to state, and so it goes on. I think there is another one question, sir, what is pen service? Yeah. And this is from Dr. Manisha Sarkar. And I think Dr. Joshi, would you like to take this question because it was in your presentation?
Yeah, thank you, Dr. Tanu. So basically, WHO PAN is an acronym which stands for Package of Essential Non-Communicable Diseases Intervention. So it gives you, in the low resource settings, what can be done to improve the NCD care services. And if we want, and I would say here that the population-based NCD screening program, or the Health and Wellness Center program, which there is a NCD package which has been introduced, is basically whatever the principles of the WHO PAN interventions are there are being addressed over there. How from the community level awareness generation to the counseling services, and then what can be done, what is the protocol-based treatment and other things. They have been mentioned in our program. So if you want to learn more about, because it's entirely a big thing, if you can visit the WHO website. There is WHO.
Yeah, I put it in the chat box, Dr. Pradeep. Link to the pen.
Yeah, I will just paste the link over there. And I will also recommend WHO Hearts package also. If you are interested in the PAN services, also go to the WHO Hearts package. It's not related to the cardiovascular diseases. It's an acronym. H stands for health system counselings and other things. So I will not go more into the detail considering the time. So over from my side.
Yeah, thank you so much. Very, very nicely you have clarified. And I think Dr. Sitanshu also talked about a lot of WHO packages which are available, and a lot of material which is available on the WHO website also. So all of you may be, requested, whosoever are interested in, looking at whatever is there on WHO. The website is very, very nice, and it gives a very comprehensive view of all the things available. We just listed out a lot of packages available under injuries, because we are doing a lot of work under injuries, and excellent packages are available. So all of you, especially the students, would love to, go through those packages. And they're very simple actually to follow and to understand, because very nicely pictorial descriptions are there. So I'll just also take this opportunity to thank Dr. Amol and Dr. Sitanshu for their lovely presentations and very big insights into this problem. So I think we don't have any more questions here. So do we call it a very successful session and much required? And I think let's not close the dialogue here. My request would be to spread out further and take this. WHO has sponsored this session, so WHO is definitely working a lot in this field. So Dr. Joshi and Dr. Sitanshu and all the speakers today and the moderators and the team, let us take it forward. So let's not say we close the session, we say let's take it forward and let's integrate more and more and do as much as possible in this field. Thank you.
So maybe we can say, let's begin. Let's
begin a new chapter. Yeah.
Start the journey together. And thank you. We are just 1 minute away from the next session, which is going to be our oration. So please feel free to remain there and participate in that. I take this opportunity to thank all the two chairs here, Dr. Tanu Jain and Dr. Bari ma'am, and all the speakers. They're all very good friends and they have readily agreed to be a part of this. It was a lovely discussion and learning for all of us. So thank you so much. Now we close the meeting here.
Thank you. Namaskar, everyone.
Thank you, everyone. Thank you.
A very good morning to everyone and welcome to the JE Park Oration as a part of the 65th Annual National Conference of the Indian Public Health Association. Joining us here today, we have our chairpersons, esteemed chairpersons here. So we have Dr. Sangamitra Ghosh, the Secretary General of the Indian Public Health Association, and Dr. Shashikant, Professor and Head, Center for Community Medicine, AIIMS, New Delhi. And the orator that we have here with us today is Dr. Jayaprakash Pullil, former Principal, Christian Medical College, Vellore. Welcome, sir and ma'am. May I please request you to take your seats at the dais? Welcome, everyone. So now I invite Dr. Sangamitra Ghosh to kindly open the session and talk to us about Dr. JE Park, please.
Good morning, dignitaries on the dais and off the dais, the eminent epidemiologist and today's orator, Dr. J.P. Mudial, all IPHA members and all delegates. Welcome to second year of Iphacon 21 and to the prestigious oration in memory of Dr. J.E. Park. It's my honor to introduce Dr. J.E. Park, who was born on 20th March 1928 at a small city, Samalkot, near Kakinada, Andhra Pradesh, where his father was a practicing physician. He showed his excellence in academics from his childhood, clearing the metric examination at the age of 13 years due to double promotion in school. Being underage for admission in medical college, he did his BA from Andhra Christian College, Guntur. He joined Andhra Medical College, Visakhapatnam, and graduated in 1952. Took his DPH from Calcutta University in 1955 and MD from Lucknow University in 1962. He did his further studies at London School of Hygiene and Tropical Medicine during 1965 to 66 and visited Oxford, Cambridge, Edinburgh and Birmingham universities under Colombo Plan. He held various teaching and academic assignments during his illustrious career. He was professor of preventive and social medicine at various state medical colleges in Madhya Pradesh, Gwalior, Jabalpur and Indore during 1963 to 79. He became professor and chairman, Department of Community Medicine, Al Fateh University, Tripoli, Libya, 1979 to 81, and professor of community medicine, Gharenius University, Benghazi. Remained visiting professor to Tripoli and Benghazi University, advisor to WHO CRO, New Delhi, member Nutrition Expert Committee, ICMR, New Delhi. Other assignments by him were as member Scientific Advisory Board, ICMR, New Delhi, Dean Faculty of Medicine, University of Jabalpur, and Inspector Medical Council of India. He was awarded Fellowship of Indian Academy of Medical Sciences and IAPH and recognition of his extraordinary contribution to his subject at the age of 44. He was also Fellow of Indian Public Health Association, member of International Epidemiological Association. He was a renowned author and prolific writer. He wrote several well-known books, mainly the textbook of Preventive and Social Medicine, which became the cornerstone of the subject in Asian countries. He also wrote a short textbook on community medicine, published by Al Fateh University, Libya, textbook of community health for nurses and essential of community health nursing, which has been translated into Hindi and Marathi also. He died on 6 October 1989 at Tripoli, Libya.
Thank you, ma'am. May I now invite Dr. Shashikant to kindly introduce us to our orator for the day, Dr. J.P. Mulial.
Thank you very much. And it's my privilege and honor to introduce such an illustrious speaker as Professor J.P. Mulial. I am supposed to read the text that has been provided to me, and I had a quick glance. It is so modest, an understatement of his achievements, that I suspect that it is written by himself. So it doesn't do justice at all to his achievements, but here I go. As per his wishes. Dr. Jayaprakash Mulial completed his undergraduate studies in medicine and postgraduate study in community medicine from Christian Medical College, Bangalore, and joined the faculty of community health there. CMC Vellore has a community health and development program with a secondary hospital as a base hospital which covers a population of about 100,000. Dr. Jayaprakash Mulial was specifically in charge of leprosy control program. In 1985, he went to Johns Hopkins University, Baltimore, from where he completed his MPH and DLPH in epidemiology. Then he became a professor of community medicine in 1990. His the first formal course in epidemiology in India was started at CMC Vellore in 1992. From 2002, he served a 5-year term as a principal of Christian Medical College, Bangalore. He is closely working with Government of India on various health projects and was also a member of scientific advisory or strategic committees and served national and international institutions. Professor Mulial has published over 160 papers in international and national journals, and I welcome him here as the prestigious Thank you.
Thank you so much, sir, for that wonderful introduction. May I now request Dr. Sagamitra Ghosh to kindly felicitate our orator. Thank you so much. I now hand over the stage to Dr. Jayaprakash Mulial.
Thank you. It's really an honor to be standing here in front of you and to delivering this oration, and I hesitate to going to call it an oration, a talk, okay, in memory of our favorite teacher, J. Park, and on the invitation of this Public Health Fraternity of India. We are all used to that book, and I remember finding it extremely difficult to go through the various divisions or definitions of public health, community health, social and preventive medicine, and it never stuck in my brain. But during my life, as a practitioner, I changed my opinion about the whole thing in many ways, and we call our department in CMC Department of Community Medicine, sorry, Community Health, not the university name. And it's not called Social and Preventive Medicine Department, it is Community Health. Now, why did that happen? And a very well-known, you must know this guy, he visited Vellore, and as he was chatting and walking down, every time I said community health, he would correct me to say public health. Then I'll walk down a little more and say, and community health, public health. He was an adamant fellow, so I can't help it. But the thing is, I did mean something different. and it is difficult for people to understand unless you have practiced this art in the context of developing countries like India. And what is that? And to understand that, you have to differentiate between a developed country and a underdeveloped or developing country. And the key issue is that developed countries are organized. Underdeveloped countries or developing countries, for example, India is a kind of half organized, half not organized, like that kind of a situation. So what happens to a bulk of our population? Public health as practiced in UK or US, that doesn't work. They don't vibe with you. They don't talk the same language. And it doesn't mean what restrictions you offer. Now, this made a difference in our catastrophe that faced when this virus walked into India. Now, before I touch upon, and I need to take this through this because it has serious significance. When H1N1 came in, what happened was, that time the ministry said, we will not allow H1N1 to come into this country. That was an announcement. And what did they do? They put people to check temperature in the airport. And then we went on checking temperature, and the epidemic came, epidemic prevailed, and it stopped. But the guys who were taking the temperature didn't stop because nobody told them to stop. Okay? Now, why do we do that? And you should pardon me, when I was 12 years old, we had a little chicken farm at our house. And my father had a friend who invited me and my father to have come and see his chicken farm. And he told me, is the volume all right? He told us, listen, I am breeding thoroughbred chicken. That means I have Rhode Island Red, Black Minorca, White Leghorn, Wyandotte, separate. And he sells all these eggs of thoroughbred chicken at a high cost. It's profitable. So we went to see Mr. Maya. I remember his name even now. I hope there's no Maya out here. But anyway, when we went there are all the chicken walking around together. And my father, I remember asking, but Maya, you said thoroughbred egg, and what are these birds all walking together? So he said, looked at him in a super serious manner. But at night, I put them in different cages. Okay? Smart fellow, right? Now, when we started controlling diseases, sometimes you wonder, well, do you understand what this is all about? You do strange things. Even in the COVID pandemic, we had the night curfews where COVID virus was not allowed to come out. Okay, or they would have some, weekend curfews. Okay, poor chap, no weekend. Now, the point we had to understand in the beginning is that there is a group of people in the country who are trained in public health and knew exactly the mindset of people, how people work, and a disease control without people's cooperation, participation never works. It's a sham. But we went on with I don't know what kind of a doggedness we had in that mentality. We said, we are going to get rid of the virus. Now, the number of entries that you have into a country decides the possibility of eliminating it. And New Zealand did that to some extent, but they are paying price even now for it. Kerala did an excellent work, but that is not on the card for a country like India. Where does it work? You got to know this is going to spread. One of the things I learned, as I did learn, was this thing, there's something called direct adjustment and indirect adjustment. You all teach everybody, every class. Now, watch it. That indirect adjustment is actually a dummy. It doesn't make logical sense. But for various reasons, because the reason why we can't compare two rates from two countries is they are different in age structure. So you adjust for the age. To do that, when you bring in another group, a standard, and then create an SMR based on indirect standardization, it didn't make sense to me. And I kept asking people, why should it do it well? And in fact, one of the authors in textbook also showed how you can have the same standardization done, direct and indirect, on the same data, and one will show one direction, other will show one direction. I was overjoyed and said, I was talking about it. But then I realized one more thing, that the justification for indirect standardization is because the mortality worldwide follow a particular pattern. It's all the countries of the world. You put the mortality on one graph, they all show like a tick shape, okay? A tick, but the tick's tail is exponential. And the only difference is the level. Poorer countries have a higher level, developed countries have a lower level, but the shape is same. Now that is the reason why we can tolerate indirect standardization, because that justifies it. In other words, you can't have all kinds of funny rates and then indirect standardization doesn't work. But as long as you follow the parallelism, it works. Why I'm saying this? The first thing about COVID, when it comes, as a professional, we should worry about how many people are we going to lose. So we sat and calculated. Verity et al. And had published the data, and there is a group from UK published the data, France. And the brilliant part is, in different countries, all the age-specific mortality rates were same shape. Same shape, okay. Now, that means this bug will act similarly in all countries. So we took that number, age-specific infection to mortality ratio, and calculated how many people will die in India. It was 2.2 million, assuming a herd immunity, my favorite concept, of about overall 55%. Now, I actually took it to an appropriate committee and said, this is what we have in our hands, okay? And look at that. Majority of the deaths, largest number will go from elderly. So, but look at the young people. They are not in trouble. Okay, they can work, they can go to school. No, it doesn't work for them. Why not? The reason is because it takes a little while of life, working in communities, working in villages, working in slum, to know the pattern of life. And then you shut the whole thing down, lockdown, on a moment's notice. That was sad, okay? And the scene that emerged was sad, not very painful. But why am I saying this? There are two ways to look at it. One is to say, hey, listen, I think we haven't done enough in our training, in our teaching and preaching, including preaching to the medical student. We haven't done enough. We have to look at ourselves. Can we do a better job? That's number one. Number two is also a time of opportunity. You know, I had a tough time when I came back from Hopkins, introducing to everybody, who are you? I'm Jayaprakash Mulil. What do you do? I'm an epidemiologist. What is that? Many people thought epidermiologist, something to do with skin, okay? But not now. Everybody, every Tom, Dick and Harry in the country is an epidemiologist, okay? They know R naughts and doubling time. Brilliant. Now, so at least I believe that if we cooperate and say, listen, watch that, it went wrong because they didn't have the leadership to show you which way. Okay? Now, there is a line that keeps coming up. I'm afraid to say it out. Excess mortality. And what is this excess mortality? Many people think it is just because that they didn't report to the whole thing, the real mortality higher. That is not excess mortality. Excess mortality is because many people who would not have died normally could not access healthcare. And that is a huge number. Okay, I'm happy that people are coming out, trying to eke out and see. And I think especially in places like Pondicherry or anything, we should try and look what is the amount of mortality, not only in terms of what is excess compared to the previous year, but also in terms of the period of time when the mortality occurred and in terms of probable cause. Now, we don't need a whole sample size for the whole country. Take a few areas, work hard on it, and you will get the total impact of the COVID and impact of not only COVID, but the impact of lack of health care during that period. Pregnant women had difficulty in reaching out and a whole lot of things. And the concept that people and us are actually two groups. We belong to the elite and most people are down there. Because we could pass rules saying that lock down the house, don't anybody get out, put chains around it or board it out. How do you do in a country like India? It's a democratic country. How do they survive? Agreed, some states and some areas, they took care of those issues carefully, but not so in every way. And that's sad part of thinking people, for example, who brought the disease into the country? The well-to-do, like us. We traveled around and got it. But who got punished for it? The slum dwellers. Okay, and that is ethically wrong. And public health or community medicine is basically rooted on social justice. And we watched it in despair and we couldn't do anything. And I think that should not come as a situation in future. And the promise we have to make is that this is not the way we allow things to happen in this country. Now, many years ago, I was doing a survey in Kerala, and this is organized by National Leprosy Eradication Program. And there I met a woman on the beaches of Trivandrum because I had to take down the questionnaire that was prepared by the office and I had to fill it up. And one of the questions is leprosy a problem in your community? She looked me in the eye and said, at the moment, it's not a problem. But if you start a program, I'm sure it will become a problem. What vision? I mean, I realize very often the problem is us, people manage. Our country, every year, those who seek job, 90% go into unorganized sector or what called a marginalized sector. That is the way they survive. They don't ask government for any help, no dole. So we'll somehow manage. Let us do our work. We'll do whatever and make both ends meet. We'll get married, have children, look after them. That's how nice Indians are. And what did we do? We went and closed the whole thing for them and said, sit at home. Sit at home so that it'll go away. Now, if you notice carefully, that is unjust. And in injustice, there is when somebody does injustice, what is the reason he does it? One is greed. Okay, there may be greed for a whole lot of stuff. But to make injustice happen, you have to somehow create a stigmatizing situation. Because it's unfair, but you should make sure it's okay to do that to them. Slum dwellers, that's okay. They are not good people, we can lock them up and things like that. So basically what I'm trying to say is, I remember one person called me and said, sir, me and my family are COVID affected. COVID affected. What does it mean? I remember I used to work in the leprosy, they say leprosy affected people. It's a transient cold. What the heck is the saying it affected forever? Impressions that we created were wrong. And Shashikant was just telling me he's comfortable with the fact that he has faced COVID and he has overcome it. I mean, but is there an official recognition yet that natural infection gives you long-lasting protection? Not yet. Why not? We went through this drama, and I want you to know this little bit that we do things not with the intention of helping people. We do things to protect, guard our interests and say, which is not fair. There is something called healthcare, smart healthcare, which we all propagate. But what we need is a healthcare with a heart, which feel for people. And our job is to create doctors, young people who feel and say, this is unjust, we can't do that. Okay, and in that lies our future. Thank you, ladies and gentlemen.
Thank you so much, sir. It was such a pleasure listening to you here today. May I now request Dr. Shashikant to present the memento to Dr. J.P. Mullian. Thank you so much. So with this, we come to the end of the JE part oration. And now I request you to join us for the next plenary sessions. So we have a plenary session on MCH, time to complete the unfinished agenda, which will take place in Hall A, and the untapped solutions for India's tuberculosis epidemic, which will take place in Main Hall. Thank you. 11:30. Yes, sir. So the session will start at 11:30.
Hi, Natasha. Can you hear me?
Yes, I can hear you. Good morning. Or
Good morning. Yeah, we are
Good
live on
morning.
the platform now. Good morning, Pranay.
Good morning.
Good morning, Anil sir.
Hi, Pranay, Natasha, Sonali here.
Hi, Sonali. How are you?
I'm good.
Sonali.
Good to meet virtually.
Yes.
Hello, Dr. Anurag. Welcome. Not able to.
Dr. Anil is also.
Dr. Anil Puthi, you are able to hear us?
Yes, we are able to hear you. Thank you.
Thank you. Thank you for joining, sir.
Thank you, sir. We are live on the platform now. So maybe we'll take a couple of minutes. 11:30, we'll be able to start the meeting. Yes, thank you.
Hello, Anil Purti. Is Dr. Anil Purti there?
Good morning, sir. Anil here. Nice to see you, sir.
Nice to see you, Anil, after so many years.
Yes, I know. I was just watching you just before Dr. JP started the oration, and then so nice to be able to see you.
Are you still with PIMS?
Yes, sir. I'm still with you, sir. Yes, sir.
You've been serving long there.
Yes, sir. Yes, sir.
That is good. That is good. Great. So nice to see you.
Thank you. Thank you. Yes, sir. So nice.
How is your wife?
Yeah, she's fine, sir. She's fine. She's in microbiology now. She's
Yeah.
leading the department right now.
At PIMS?
Yes, sir. Yes.
Oh, that's good. Good. A large number of Jipmerites are distributed in different colleges in Pondicherry.
Yes, yes, yes.
And a good number at, I think, Mahatma Gandhi.
Yes. Yes, sir.
Good. Okay, well, I'll wait for your presentation.
Okay, thank you. Thank you.
Good morning, sir. And thank you for joining this plenary. I'm so happy to see you.
Who is that?
This is Sonali, one of the chairpersons from PSM department, JIPMA.
Oh, Sonali, I know. But I am not seeing you.
No, the video is off.
Okay.
We'll come on live, sir, just in a few minutes.
Okay. Right. Thank you, Sonali.
Yes, sir.
A very good morning to all of you, and I thank everyone for coming here all the way, amongst your busy schedule. So I welcome you all to the plenary 7 of the 65th Annual National Conference of the Indian Public Health Association, jointly conducted by IPHA Pondicherry and JIPMA International School of Public Health. So this session is on untapped solutions for India's tuberculosis epidemic, and we have divided the session into 2 parts. The first part will be on the nutritional interventions for TB. So, and we have 2 very eminent public health experts to moderate the first session. So Dr. Sonali and Dr. Anil Purti. A short introduction to both of them. So Dr. Sonali is a professor at the Department of PSM JIPMER, and she has over 19 years of working experience in the field of PSM.
And she has contributed in the establishment of JIPMA site for Report India Consortium. And she is also involved extensively in a lot of international and national collaborative research projects. She is also the chair for the Clinical Ophthalmology Working Group on Report India, and also a member of India's TB Research Consortium of ICMR. And she's also the Indian chair for Report India Phase 2 and one of the chairs for Report International as well. And ma'am has over 98 publications in several esteemed journals, international and national journals. And she has also written a chapter on maternal and child health scenario in Odisha in a book titled Contemporary Odisha, Realities and Vision. Dr. Lanil Purti is a professor and the head of the department, Pondicherry Institute of Medical Sciences, Pondicherry. And sir has over 25 years of teaching, training, and community-based research experiences. And he has been awarded several fellowships by the ICMR. And he is also a vice chairman for the National Tuberculosis Elimination Program Task Force. And he's also a member of the Central TB Division, Ministry of Health and Family Welfare Task Force for the TB elimination in India by 2025. And he's also the member for the advisory committee of the ICMR's Pandemic Preparedness Partnership. And sir has over 89 scientific publications so far and has contributed for 6 books. So I welcome both of you for the session. And I now request Dr. Sonali to take over.
Thank you very much, Jeffrey, for those kind words. Very good morning.
I'm sorry, Dr. Sonali, it's got muted. Perhaps you are just adjusting. Thank you.
Am I audible now?
Okay. Yes, you are.
Thank you. Thank you, Jeffrey, for those kind words. Warm good morning to all the participants in this plenary. No discourse on public health in India is complete without a discussion on tuberculosis, which continues to be the #1 killer among the infectious diseases, and India contributes, unfortunately, to more than 1/4 of this global burden. So here we have a plenary to discuss about the untapped solutions for India's tuberculosis epidemic. In the first session, as Ms. Jayashree just now said, we will be discussing about the nutritional interventions for TB. And we have got very eminent speakers for this plenary. We have speakers who have worked in the field, have experienced this, which they will be sharing in their sessions, which they have got from their field experience. And speakers both from India and US who are working in this area of nutrition in TB. So we have among the speakers, Dr. Padma Priyadarshini, who's the director of National Institute of Research in Tuberculosis at Chennai. We have Dr. Anurag Bhargava, who's the professor of Department of Medicine of Ennapoya Medical College in Bangalore. We have Dr. Pranay Sinha, who joins us from Boston. He's infectious disease fellow in the Boston University. We have Dr. Sharon Cox and Dr. Natasha Hochberg, all from Dr. Natasha is also from Boston University, but Dr. Sharon Cox from Nagasaki School of Tropical Medicine and Global Health. So it is going to be an exciting discussion. We need to know how we can, what we can do in India to fasten the control of tuberculosis, which has been slower than expected towards achieving the goal of TB, which India has actually set the goals a decade earlier than those set by the NDB goals in WHO. So let us see what we can do as part of public health community in India towards control of tuberculosis, because we all know that undernutrition is contributing to the major burden of tuberculosis in India. So with this, I would like to introduce our first speaker, Dr. Padma Priyadarshini. So it's my good fortune to have known and worked with Dr. Padma Priyadarshini since 2013. She was a very active member of the Report India consortium. And she is now the director of the ICMR Institute, that is the National Institute for Research in Tuberculosis. We know how NERT has contributed towards research and control in TB in India. It also has a supranational laboratory, which is the WHO recognized lab for the Southeast Asia region. Her awards and fellowship and contribution is, she has been awarded the Lupin Tuberculosis Association of India Award in 2015. She was also awarded the Tuberculosis Association of India Oration at the National Conference on Tuberculosis and Chest Diseases in 2020. She has more than 87 publications and 2 chapters to her credit. She is a very hardworking and relentless energy in research and clinical research, especially in tuberculosis. So her leading the National Institute of Research in Tuberculosis is going to be a good contribution towards TB control in India. Welcome to this plenary, Dr. Padma, and thank you for agreeing to speak in this session. Over to you, Dr. Padma.
Please stop here.
Good morning, everyone. Thank you for inviting me to give the plenary for the 66th Annual National Conference of IPHA. So my talk would be on burden of TB and elimination goals for the country. Yeah. So as per the Global TB Report of 2020, the global estimate of TB incidence of 2019 is around 10 million estimated cases, which is equivalent to 130 cases per lakh population. Now this varies across the various regions of the WHO. And we fall under the Southeast Asian region, where it is 217 cases per lakh population has been estimated. India, it varies between 130 to 180 cases per lakh population. And this is different between HIV positives and HIV negative individuals. There are 30 high TB burden countries, which account for 86% of all estimated incident TB cases. 8 of these countries account for 2/3 of the global TB burden. And India being the topmost in that list is 26% of contribution for the incident cases in the globe. This is followed by Indonesia and China with 8.4% of cases each. The global incidence of rifampicin resistance or isoniazid resistance is little different. It's around 3.3% of new cases. And 18% of previously treated cases are RIF resistance, whether MDR or RIF alone resistance. There are 465,000 incident cases of MDR in the last 1 year. 50% of the global case is contributed by 3 major players, India, China, and Russia. Looking at mono-H resistance, where rifampicin is sensitive and only resistance to isoniazid, 13% of new cases and 17% of previously treated cases have been shown to have isoniazid resistance. Now, MDR, which is rifampicin and isoniazid resistance, along with resistance to any other fluoroquinolone, there are 20% of cases of MDR, which also have an additional fluoroquinolone resistance across the globe. So TB forms the 10th leading cause of death worldwide, and it is the single most infectious agent causing death, which is higher than HIV/AIDS. India accounted for 36% of global TB death among the HIV negatives, and for 31% when it was combined with both HIV negative and HIV positive individuals. Over the period of years, there has been a decline in TB deaths, both in terms of HIV negative and HIV positive TB cases. But however, we still have quite a handful of TB deaths among the HIV negative individuals also. The absolute number of TB deaths among the HIV negative did fall from 31%, but however, the best estimate even now is much above than what is desirable. The mortality rate fell by 45% in the last 1 year. The global estimate of TB cases notified based on the age and sex. As we know, TB affects all age group. Adult men are the most commonly affected. Around 56% of the global estimate is among the male gender, followed by women and children. The male-female ratio is varying across the different regions of WHO. In the Mediterranean region, it's around 1.3, whereas in the West Pacific, it's more male preponderance. Sorry. Shifting from human TB to zoonotic TB disease, around 140,000 new cases of zoonotic TB occurred globally in 2019, and most of this data has been derived from Mycobacterium bovis, the most common cause of zoonotic TB globally. However, the research at NIRT has shown that it's slowly you're seeing Mycobacterium tuberculosis also among bovine TB, or among the cattle. They're finding more and more Mycobacterium tuberculosis among the cattle and pet animals in the state. Now, moving from the global burden of TB to the burden of TB in the country, India accounts for about a quarter of the global TB burden. And this is the India TB report released in 2021, where we have the estimate from 2019-2020. The estimated TB incidence around 26,40,000 cases. And if you look at the drug resistance TB, MDR and rifampicin resistance, around 130,000 cases of drug resistance TB in the last 1 year. The second highest number of estimated HIV-associated TB cases have also been reported from India. 9,500 HIV positive individuals, an estimated of 436,000 TB deaths among HIV negative individuals has been reported in the last year. If you compare the differences between the WHO estimated numbers and what has been notified in the country over the years, if you can look at this graph bar diagram on the left, the blue chart shows what is the WHO estimated incidence of TB, and the orange one is the incident TB cases as notified in the country, and the gray bars are the total cases notified. If you look at the difference between the estimated number of cases and what has been notified, this gap is much higher in the previous years, and the gap is slowly narrowing as we move towards 2019. In 2019, NTEP achieved a notification of 159 TB cases per lakh population against an estimated 199 per lakh. So this gap is really narrowing. So the 26 lakhs and what we have seen is 24 lakhs, around 2 lakhs missing cases is what is currently being estimated. Now, month-wise TB notification in 2020 during the pandemic period, did we see a dip in notification? Yes, we did see in early part of the year. So in March, April, when we were just entering the second wave, there was a severe dip in the notification, and the dip was more from the private sector. But subsequently, as more and more services became available, the dip slowly started coming up, and by May, June, July, we were almost paralleling to what we were in the 2019 target. In 2000, so the orange line below is the 2020 notification rates. The blue one is the 2019 notification. So we kind of slowly picked up in 2020. Later half of the year, our notification came very close to what it was in 2019. So by December 2020, 18 lakh cases of TB had been notified to NTEP. 31% of them were from private sector. And what is the age gender distribution of notified TB cases in the country, which is very similar or parallel to what has been notified globally. 61% of all our TB cases arise from the male gender. 5% of total cases is around from children below the age of 14 years. So in the country, the preponderance of TB is between the age group of 15 to 30 years, and this slightly varies in southern states and Manipur and Tripura. So in states of Tamil Nadu, Karnataka, Andhra, and Kerala, so it's less than 30% of preponderance is seen between the age group of 15 and 30 years. And our children proportion is less than 6% below the age of 14 years. Now, moving from the notified and prevalence and incidence of TB cases, what is the treatment status of notified TB cases in 2020? Our success rate is around 82%. And if you look at private-public partnership, if you look at the treatment initiated, we had equal number of cases being initiated both in the private sector and in the public sector. 97% and 94% were initiated on treatment in the public and private sector respectively. 3% of cases in the private sector were notified but were not initiated on treatment, as compared to 6% of notified but not initiated in the public sector. Currently on treatment, we have 56% of patients in the private sector and 44% in the public sector. So you can see a huge number of patients are on treatment at the private sector in the country. Our death rate is 4%, and we have 4% of patients being lost to follow-up before completion of treatment. and 2% of patients required change of regimen because of toxicity to the drugs. Now, moving away from the burden of TB, what is the plan of elimination of TB in the country? So we have a national strategic plan, a document. So this is basically a framework that will guide all activities of stakeholders, which include policymakers, NGOs, academicians, researchers, treatment physicians, on how to achieve TB elimination by 2025. Our aim is to direct all attention of the stakeholders on the most important activities that will bring a reduction or significant change in the incidence, prevalence, and mortality of TB in the country. So one particular change in the current strategic plan from the previous year's strategic plan is NTEP is currently encouraging private providers and private physicians to provide quality care and treatment. This was instead of this is much better than encourage. This is more of encouraging the private providers to send the to have treatment given in the private sector itself, instead of asking them to send the patient to get treatment at NTEP. So now the program is facilitating the private providers to get free treatment, get the drugs from the program, give them free treatment. That way the patients can still go to the private providers, continue treatment, but it's encouraging the private providers to notify the program the number of cases they have diagnosed, the number of cases that are on treatment for them. So what is the impact and outcome indicators that we are going to look at for achieving a target of NTB strategy? So as you all know, our elimination goal is 2025, much ahead of the SDG goal of 2030. So currently all our projection is based on the baseline of 2015. However, by 2020, we were supposed to achieve certain targets, which we were not able to reach because of the COVID pandemic. So we had to re-estimate or recalculate the way we will go forward with these milestones. Our baseline, which was taken originally, was 2015. The three main impact indicators we are looking at is to reduce the estimated TB incidence rate, reduce the estimated TB prevalence rate, and reduce the mortality rate due to TB. The last point would be to reduce it to catastrophic cost, make it zero catastrophic cost to the families of TB individuals. So in 2015 baseline, we had 217 incident TB cases per lakh population. Our target at 2025 to bring it down to 44 per lakh population. We did have certain milestones in 2020 and another milestones in 2023. The 2020 milestones, we should have achieved 142 incident rate per lakh population. Now, TB prevalence rate at baseline in 2015, it was 320 per lakh. The milestone in 2020 was to bring it down to 170 per lakh, so that we can reach a target of 65 per lakh prevalence case by 2025. So currently there is a national TB prevalence survey that's ongoing. We have almost completed the survey. We are in the process of analyzing. The entire country took part in the TB prevalence survey. We very soon would be expecting the results from the TB prevalence survey, which would give us an estimate of 2020, the prevalence rate. Currently, we are working with the assumption that the prevalence rate would be somewhere between 159 and 200 per lakh population. And this is what we want to achieve by 2025, bring it down to 65 per lakh. The mortality should come down to 3 per lakh population, and there should be zero catastrophic cost to families affected by TB. Our outcome indicators would basically depend on the TB patient notification, the private providers notification, patients of drug-resistant TB that are notified, and proportion of notified patients who are offered DSP. So if you look at these numbers, all these numbers are expected to go up from baseline 1.7 million in 2015. By 2020, we expect it to go up because there will be more of mobilization, more of private providers taking part in this activity. And slowly by 2023, they expect all these numbers to come down, which includes including the private providers notification. So the entire TB elimination program is based on 4 main pillars: detect, treat, prevent, and build. By detect, we want to detect all DSTB and drug-resistant TB cases with an emphasis on reaching out to the private providers as well as to those with undiagnosed TB in high-risk population. For that, we plan to scale up our freely available diagnostic kits, freely available drug sensitivity kits to as many private providers as in other than the public sector. Universal testing for drug-resistant wherever TB is diagnosed. Systematic screening of high-risk population. The high-risk population here includes all household contacts of a known TB case, patients on immunosuppressant drugs, on dialysis, transplant. We're also looking at vulnerable population who will be later considered as high-risk group. Treat all the cases that have been diagnosed have to be initiated on treatment, and they have to sustain on treatment so that they complete the treatment, whatever they have been started on. And the treatment would be more a patient-friendly system would be there, and social support would be offered to the patients. And this mainly, how do we do it, is prevent the loss of TB cases in the care cascade system. Free TB drugs for all TB patients. Universally, a daily regimen is being offered to all patients. We're also looking patient-friendly adherence monitoring mechanism like social support system, DBT, direct benefit transfer, everything to help patients complete the treatment. The prevent pillar is mainly concentrating on preventing emergence of TB cases in the susceptible population. You have to concentrate more on airborne infection control and treatment of latent TB infection in contact of bacteriologically confirmed positive patients. And also address various social determinants of TB through the intersectoral approach. The last pillar being build is mainly to strengthen or enable the policies in various institutions, which would basically consist of training HR in various cadres, starting from your treatment supervisors, lab assistants, lab technicians, to supervisory role being given by the physicians. The reforming various laboratory structures, getting more of medical colleges involved, getting the research institutes on board, whatever research findings are coming out from various studies to bring it to the policy at the earliest, scale up the technical assistance. So these are the 4 main pillars on which the TB elimination of the country is being planned. The most important thing would be direct benefit transfer. The direct benefit transfer is basically providing support to the patient so that the patient is able to complete his treatment without much of catastrophic cost involved in the patient management. The other one is reducing out-of-pocket expenditure to the TB patients. Program is currently taking care of cost of diagnosis, cost of treatment. Both of them are available free of cost. Also, cost of travel, the nutrition support and loss of wages is also being packaged into this, addressing the out-of-pocket expenditure for the patients. So NTB strategy at a glance. So this would be the various milestones of 2020, 2025. The targets would be 2035 for NTB strategy, but we expect to have our targets reached by 2025. This again is addressing 3 main aspects: absolute reduction in number of TB deaths per year, reduction in the TB incidence rate, and also catastrophic reduction in the catastrophic cost. We expect the catastrophic cost to be totally zero by the time 2025. So where do we stand currently? Globally, there is a decline of TB incidence rate from 1.7% per year in 2000 to 2019 to 2.3% per year in the last 1 year. The cumulative reduction, however, the 9% is still not where we wanted us to be when we initially started this whole program. So this is where we are TB incidence rate, but this is for the trajectory that is being planned. So is India on course for TB elimination by 2025? So impact there, the COVID-19 did have an impact on the TB services. However, India was able to bounce back, go back to its normal course, and slowly we are recovering. The central ministry did launch the TB Harega Desh Jitega campaign that is now going full-fledged. We do have a national strategic plan in place. So there is a plan. It's all now left to us to mobilize the plan and have it done in the field conditions. The whole program is now geared up to subnational certification of disease-free status. So this is something towards a free India movement that has been launched. Many districts can claim that they have reached a disease-free status based on the notification rate, the drug sales data, and the survey. So when a district approaches central TB division, it could be a district or state. This program started last year, claiming to have a controlled TB or disease-free status. Then the institutes would be, one of the national institutes would be asked to verify the claim. The verification of claim is done by looking at the notification rate, the drug sales data, and the survey would be done for the district or the state. And if they have reached the status, they would be given a they would be given a medal as well as cash award. Last year, 67 districts, 2 states and 1 union territory had applied for the subnational certification, that is progress towards a TB-free India. Of them, many of them did get an award of achieving that status. So this is what has been given to them, 20% if they have reached achieving the reduction of TB incidence as compared to the 2015 target. If there's 20% reduction, they get a bronze medal. If there's a 40% reduction in TB incidence, silver, and then 60% is gold. Once they reach an 80% reduction of TB incidence as compared to 2015, 2015, they are given a TB-free state award. This also has a cash award for the state or the union territory or even the districts. The other thing that we are doing now is TB survivors to TB champions. Many of the TB survivors are being used now as champions to talk about early diagnosis, awareness among the community, completion of the treatment. That movement is catching up now. We also have a booklet on how to make this uniform book, modules on how the survivors can be converted into TB champions. Of course, TB Mukt Bharat is a 2021 is a year for TB. And so these are the 4 pillars that I talked about: detect, treat, build, and prevent. This is what we hope to achieve, hope to stand on to achieve our elimination target. Now, the diagnostics have been really geared up with mobile vans available. Mobile vans do have an X-ray machine inside. They have a CBNAT cartridge, so TrueNAT is available for diagnosing early. The treatment we hope to have, so this is the one currently patients are taking treatment for drug-resistant TB. This many number of drugs, we want to bring it down to less number of drugs. Shortening the duration of treatment, reducing the number of pills. The third pillar of prevention of TB, we are bringing in more preventive medicines now. After diagnosing latent TB infection, either by IGRA or by CTB skin test, they would be given a 3-HP regimen or a 6-INH regimen, prevention of TB among the high-risk group. And of course, building the TB survivors to talk about TB control. They will become the TB champion. This is a training curriculum that's available on the CTD website. I want to end by saying ensuring affordable and quality healthcare to the population's priority of this government. We are committed to achieving a zero TB death, and therefore we need to re-strategize, think afresh, and have to be aggressive in our approach to end TB by 2025. Thank you.
Thank you very much, Dr. Padma. That was a very comprehensive presentation about the TB burden in India. We will take questions at the end. If you are going to continue, I know you are an extremely busy person, but you could spare some time for joining this plenary and giving a talk. So we really appreciate your efforts in doing this. And if you are able to continue to be online, we can take questions at the end, or if you are willing, we have some questions in the chat box. If
Dr. Sonali, thank you. I think we can take the questions at end. I will be online. I'll attend the whole session.
Okay, thank you so much. And by the way, I just wanted to inform all those who have joined us online, either in the Zoom platform or in the conference platform. We have a number of participants here in person also. This is actually a hybrid model, and we have tried to involve all the stakeholders. So we have our officers from the District Tuberculosis Center of Kadlur, and we have program officers from ICDS who take care of the nutritional supplementation in our country. And so we have many other program officers and NTEP program officers, including the state treatment supervisors and many others. We have nutritionists, social workers, field visitors, health supervisors. So there's a very comprehensive group of people who are actually working for TB in the field. So we are actually trying to make it as a very holistic approach for coming up with some strategies. So we can go on to the next speaker. We have Dr. Anurag Bhargava with us. Thank you for joining us on this plenary, sir, today. I know whoever is working in the field of nutrition and tuberculosis knows you. You don't need an introduction, but still to introduce to many who haven't heard of you, the work you're doing. Dr. Anurag Bhargava is a professor of medicine in NAPA Medical College, Bangalore. He's also an adjunct professor of medicine at McGill University, Canada. He is a member of the Strategic and Technical Advisory Group for WHO Southeast Asia region. He's also a member of Strategic Advisory Group of Experts for in vitro diagnostics, and also a member of the National Technical Working Group on TB and comorbidities. He has a vast experience of 31 years working across 6 states and has developed a comprehensive TB program for a non-profit organization in rural Chhattisgarh. He is actually working there with the vulnerable population in our country. So he has received the Dr. P.R.J. Gangadharam Endowment Award by MGIMS Vartha in 2021 for contribution to TB control in India, and especially for the cure of TB patients in rural India and researching TB nutrition interactions and the technical inputs to the NTP. He is an author of 3 national guidelines developed by the National TB Elimination Program, ICMR and NHM, including the guidance document on nutritional care and support for TB patients that we all refer to. So this is a very small introduction to the work you are doing. He is also the PI of the recent study that is still ongoing. We would like to hear from you, Dr. Anurag. Thank you for joining again.
Thank you, Dr. Sonali.
Hello, everyone. I thank the organizers for giving me this opportunity of discussing the role of nutritional interventions in TB care and prevention. Our ongoing trial in 4 districts of Jharkhand of a nutritional intervention in TB-affected patients and their households will provide definitive answers on the impact of nutritional support being delivered as food baskets on TB incidence as well as TB mortality. On the left side is a picture of a child who has pneumonia with severe acute malnutrition. And on the right side is an 18-year-old tribal with active TB and severe malnutrition, which are in fact comparable situations. However, while there is a consensus with regard to the child with pneumonia and SAM, that malnutrition in this child is related both to previous poor diet and disease, and that treatment of SAM reduces mortality, which will require admission to a facility for stabilization and nutritional support. On the other hand, we leave patients with active TB and severe malnutrition without this kind of nutritional care and support. The problem of TB in India is closely linked to the larger problem of malnutrition. India being home to the highest number of malnourished adults and children. And according to NFHS data, the prevalence of undernutrition in adults actually exceeds the population of a country like Brazil. A large number of deaths under 5 are related to malnutrition. We often talk of a bidirectional relationship between TB and nutrition. However, it is important to know that this is a cycle, and a vicious cycle at that. So, undernutrition impairs cell-mediated immunity, and in patients with latent TB infection, this can lead to progression of latent TB infection to active TB, which in turn, because of anorexia and cytokines, can worsen the undernutrition, which in turn can lead to more extensive TB. And this combination of worsening undernutrition and extensive TB can both lead to death. So undernutrition is a single most widely prevalent risk factor for TB incidence, and also the most prevalent and easily identifiable treatable comorbidity in patients, which is increasing TB mortality. However, despite these facts, it is still under-recognized and unaddressed in relation to either TB in patients or at the population level. I will first discuss nutrition as an integral component of TB treatment in India. And our study in nearly 1,700 patients with pulmonary TB in rural Chhattisgarh over a 6-year period provided the first data of body mass indices in adult men and women with TB. And these were very low in terms of comparable statistics from other parts of the world. The median of 15 and 16 in men and women, and weights of 34 and 42 in women and men. And the NTP data, which was published in 2016, actually showed comparably low weights for both women and men. These levels of nutrition were found to elevate the risk of death by 2 to 4-fold. And we also found that if we feel that the undernutrition will just respond to TB therapy, that is not the case, because weight gains in the absence of nutrition support are poor in the range of 2.5 to 3 kgs only. And most patients with undernutrition remain undernourished even at the end of treatment. And this has implications for their long-term outcomes. Apart from deaths, undernutrition is a major risk factor for drug-induced hepatotoxicity. It also can delay sputum conversion, and malabsorption of key drugs like rifampicin have been seen in undernourished patients, which can lead to treatment failure. Also, low BMI is strongly associated with the risk of recurrent TB, which in India is high. On the other hand, better weights and weight gains are associated with improved outcomes. And this has been seen even in patients with drug-resistant TB, including those with XDR TB. Nutrition supplementation program in the RNTCP in Bengal found that this improved adherence and resulted in a 50% reduction in unfavorable outcomes. People often interpret the Madras trial as having shown that nutrition has no role in the management of TB. However, the patients in the sanatorium group actually had double the weight gain and faster levels of sputum conversion and more persistent microbiological cure. Also, the Cochrane review in 2016, which concluded that there is insufficient research to judge the effects of nutritional interventions. And how insufficient the research is seen in these figures, with only 567 patients being subjected in a small number of studies to macronutrient supplementation. But even in these small underpowered studies, there was a trend to reduce mortality. So the WHO guideline for nutrition care and support, which was released in 2013, concluded that an adequate diet is a requirement for patients with TB infection as well as disease, and that nutrition screening, assessment, and management are integral components of TB treatment and care. But the uptake of this guideline has not been that prompt and satisfactory. In the context of India, if we talk of patient-centered care in the new strategy, this should include effective drugs along with nutritional care and supervision. The program will need to implement 3 components of nutritional care. One is of nutritional assessment with height, weight, looking for edema and estimating hemoglobin, which can be done at the same time as screening for diabetes and HIV. Educating the patient on diet, emphasizing lower cost alternatives, sources of protein, and implementation of nutrition support which can be community based in most patients, while some patients with severe undernutrition may require initial inpatient care. Nutrition support can be looked at in 3 ways. In those with moderate and severe undernutrition, it can be considered part of therapy. While a larger number of patients experience food insecurity, in those patients, this could be a form of social protection. And in all patients, nutritional support could act as an incentive and an enabler. Our experience in Jharkhand reaffirms the point that nutritional support is an essential, not optional component of patient-centered care for vulnerable populations in India. And this shows the progress of a patient, a 16 kg weight gain with effective therapy and nutritional support in this young boy. A poor nutrition status is also a proxy for severe TB, and this can be picked up at the peripheral level with by any healthcare provider and can predict early mortality. So in the guidance document, a team which included us recommended that the body mass index should be estimated in all patients, and those with these cutoffs should be referred for inpatient care. Inability to stand a poor performance status is also a good indicator of patients with severe TB. And this is one example again of an extremely undernourished patient doing well with an initial referral and effective therapy and food support. There are some opportunities and challenges in the operationalization of nutritional care and support in India. The opportunities being that now undernutrition is recognized as a comorbidity and that NTP recommends that weight and height should be measured. There are this NTB app and the Arogya Sathi app which can allow BMI to be calculated by any health worker. The Nikshay Poshan Yojana with its direct benefit transfer to enable a nutritious diet has been launched. And to consider food support in kind, there are lessons from other supplementary nutrition programs and a large PDS system. The challenges in the current DBT include issues of timeliness and coverage. And one major lack is the lack of documentation of impact of DBT on clinical and nutritional and programmatic outcomes, which should be a priority. In-kind transfers will of food in kind would require creation of logistic chains and ensuring that there are no leakages. Finally, I'll refer to very briefly to the role nutrition can play as an aid to TB prevention apart from LTBI treatment. So active TB is the balance of infection with the patient's immunity, and undernutrition is a risk factor for progression of LTBI to active TB. In the Global TB Report 2020, for the first time, it was estimated that out of the 5 major risk factors, undernourishment accounted for 2.2 million cases globally, which was more than the combined number attributable to HIV, diabetes, and alcohol misuse. So it's a leading driver for TB epidemic globally, especially so in India. A previous systematic review showed that there was an inverse exponential relationship between TB incidence and BMI, which translates into a very significant 14% decline in TB incidence if the BMI were to increase by 1 unit. So the population, the BMI of a population is a determinant of TB incidence. And indirect evidence of this, of the improvement in nutrition and TB incidence comes from the McCune study, where he documented that TB burden declined significantly in the West, even before the vaccine or the drugs were discovered, under the influence of better nutrition. And similarly, modeling study based on the TB in the Indian states has also shown that this could have a very significant impact on TB incidence. There are two small but dramatic examples from the era before drugs or vaccines were discovered. One is from the Papworth village settlement, which I had the opportunity of reanalyzing, where adequate nutrition and the better housing led to a remarkable decline of TB incidence and contacts. While in a German prisoner of war camp, again, Red Cross ration supplementing the poor prison diet resulted in a dramatic reduction of TB incidence in British soldiers compared to Russian soldiers, despite living in the same conditions of overcrowding and stress. So finally, I would like to conclude that when we discuss the NTB strategy and the pillars of the NTB strategy, nutrition has to be integrated into each of these pillars. In pillar 1, we should implement with vigor nutritional assessment, counseling, and support in our program. And with the added advantage that screening for nutrition would offer a tool for identifying patients at high risk of death, who can be then referred and saved. The pillar 2, which talks of bold policies, there is a role for implementing multi-sectoral efforts to address undernutrition at the population level. And we know that there are pockets of high prevalence of undernutrition in many states in India, which can offer the ideal grounds for such efforts. And lastly, there is a great role for conducting basic clinical and implementation research related to undernutrition and the impact of nutritional interventions on TB outcomes. It's my pleasure to acknowledge the support I've received from the rations trial team, Dr. Badhvi, my colleagues in the Department of Medicine at Yenepoya Medical College, Professor Dick Menzies and Madhukar Pai, Central TB Division, ICMR, McGill University, and the Levzine Foundation. Thank you very much for your patient listening.
Thank you, Dr. Anurag. That was a really good insight into the role of nutrition in TB. We will have a lot of discussion. This is a very interesting topic, and we have a good audience also. But I think we'll take it at the end. You're going to be here, I hope, for the whole length of the plenary. If that's okay, we will move on to the next talk. Dr. Anil Purti will take over from here.
Yes, Dr. Sonali, if I'm audible, I'll be there for this entire session. Sir.
Thank you very much, sir. Dr.
Thank you very much, Dr. Sonali, and it was great, always great to listen to Dr. Anurag and of course Dr. Padma, who spoke earlier. Just before we go to introduce the next speaker, Dr. Pranay, I think Professor D.K. Srinivas, my guru from JIPMER, who's also joining. Pranam, sir, to you. And sir, I just mentioned in the chat box that they have been stalwarts, probably the first MBBS women doctor and another maths wizard who were victims of TB or malnutrition due to TB. It says doesn't affect only possibly the poor, but also those who are able to afford. Well, moving on, thank you very much, sir, for sharing those excerpts. It's my privilege to introduce the next speaker, Dr. Pranay Sinha, who is a postdoctoral fellow at Boston University. And Dr. Sinha has had a long career of experience of TB research, his field of experience both in India and South Africa. At present, he works as an infectious disease physician at the Boston Medical Center and treats both active and latent TB. Also involved in the TB clinic there. His primary interests are between the relationship between undernutrition and TB, and conduct of epidemiological studies, health economic modeling, and working with the team to find ways to improve the national policy to end TB in India. A great work, Dr. Pranay Sinha, and over to you for your talk. Thank you.
It's a pleasure to speak about nutritional supplementation as a way to eliminate TB in India. I don't have any conflicts to declare. And the learning objectives are really around the health economics of nutrition supplementations for TB in India. If you look at what is happening in the US and the UK in the late 1800s, early 1900s, we were seeing TB mortality and incidence just like plummeting. There was no medicines, no vaccine for TB yet. So why was this happening? It was happening because there was real socioeconomic progress and people were no longer as hungry and they were living in better conditions. There were also some public health interventions happening. But really, remember, there were no medicines at this time. There was no test, there's no gene expert. So a lot of experts believe this was due to the resolution of undernutrition. Even today, undernutrition is the leading risk factor for TB, with 1 in 5 cases in the world attributable to undernutrition. Not only does undernutrition increase the risk of TB, it also worsens mortality. And this has been demonstrated both in populations with and without HIV. In India, as Dr. Bhargava has spoken already, at least 1 in 3 cases is attributed to undernutrition, probably higher. It's a really hard word to say. And so the policy relevant question we were trying to ask was, is nutritional supplementation a cost-effective strategy to eliminate the impact of undernutrition on India's TB epidemic? So we looked at India's public distribution system, which serves 800 million Indians. And we were thinking of using that infrastructure to provide a high-calorie diet, 2,600 kilocalories per day, to Indians with BMI less than 18.5 kilograms per meter squared. These were considered undernourished. We would do this through the TPDS fair price shops and use the infrastructure of the TPDS. The intervention itself, we designed based on the TB Lion study that you'll be hearing about in a few minutes from Dr. Hochberg. And then the model overview, really, it was designed from the perspective of the central government. We looked at it 5 years because we were designing this in 2020, and India was hoping to eliminate TB by 2025, although that looks unlikely. And we were looking at TB cases averted, TB deaths averted, and the ISA. We picked a willingness to pay threshold of $2,104, which is the per capita GDP of India. Just a quick word on ISA. ISA is a metric used in health economics to determine whether intervention is cost effective or not. And it's not rocket science. It's just the cost of whatever you're proposing minus the cost of whatever is happening right now, divided by the benefit of the new intervention over the benefit of what's going on right now. That's as simple as it gets. So we simplified all models of simplifications. And so we simplified TB in India to this. So you are living without TB, then you either remain healthy, you die of other causes like heart attacks and so on, or you develop TB. If you develop TB, you either die or you get cured, very simply. And then when we give augmented rations, we imagine this is what's going to happen. So they get nutritional supplementation if their BMI is less than 18.5, and they get that until they hit that BMI of 20 threshold. And the reason we put that there was we didn't want them to keep getting fatter and develop diabetes, which that would be bad too. And so once they attain a BMI of 20, they graduate, quote unquote, from the program. And at that point, they get whatever subsidies they would have gotten anyway, but they don't get the augmented rations. We got our epidemiological data from a deep dive into the literature. We used WHO estimates of TB incidence in India. We did simulate a secular decline in TB incidence, which is happening. The disability rates we got from the global burden of disease. And so you read this as, for example, with chronic undernutrition, we got that disability rate from severe wasting, from worm infestation, for example. And so we estimate basically that life with that is 13% essentially worse than it is without a sort of chronic undernutrition. We also spent a lot of time actually simulating weight gain, and we had some data, at least for 6 months, from over 6 months, how much people were estimated to gain on a high-calorie diet. Beyond 6 months, there's a paucity of data, really, so we made very conservative assumptions. So we really underestimated how much people would gain weight. Again, because we're trying to bias ourselves against the nutritional intervention when we were developing the model, because we want to be ultra-conservative. Despite being ultra-conservative, we found that the augmented rations were highly cost-effective. The ISA was $460, which is 1/5 of the willingness to pay threshold. We found that 10 times more people were lifted out of undernutrition in the augmented ration strategy, and that the TB incidence and mortality were 78% and 88% lower than the usual scenario. And so a 78% reduction in TB incidence sounds insane, but I showed you that this is what happened in Europe and the US as the nutrition status of the population improved. So, really we want to know what, you could say, well, you made a lot of assumptions. Maybe one of those things is sort of giving us a false flag here. So let's start with the deterministic sensitivity analysis, which is what we do to sort of test our model and see if there's something weird in it. And so in the deterministic sensitivity analysis, we changed one thing at a time. And when we did it, we found the thing that the model was most sensitive to was the cost of the intervention. And this is where we need to do more research to think about what can we do from a systems level and from an intervention level. Can we give less food and still be as effective? So this is the kind of operational research, clinical research also, that needs to happen. The other two things that were very important here was the rate of weight gain and the disability rate of the chronic undernutrition, which is an assumption, right? We're assuming that being chronically undernourished is 13% worse than being well-nourished. So even if you say that, people would only really gain 1.5 kilograms in the first month. Well, hey, I'll tell you, even then we'd be cost effective. And as somebody who's gained 1.5 kilograms in the last week because of the pandemic, I don't think it's unrealistic that our intervention would sort of push weights up much higher than that. And then you could say, well, Pranay, the assumption that life with nutrition is 13% worse than with perfect nutrition, that seems a bit far-fetched. Even if you said it was only about 3% worse than being perfectly well nourished, we would still be cost effective. So, you know, this sort of makes us feel better about a model. The other thing you can do is you can imagine like 10,000 different universes where, you know, every detail is slightly different. So in one universe, the intervention costs maybe $50, the other one costs $100. In one universe, it's the weight gain, you gain 5 kilograms in the first 6 months. The other one, you gain 1 kilogram. So even, you know, developing these 10,000 different worlds using Monte Carlo simulation, we found that in more than 99% of those 10,000 worlds, the intervention came out to be very cost effective. And really, if your threshold to pay is $1,260 or higher, the intervention is always going to be cost effective. That's what the probabilistic sensitivity analysis told us. Now you can say, listen, like the 2,100 number seems a little off. Well, just compare our intervention to the other interventions that are very enthusiastically adopted in India, things like antiretroviral therapy for serodiscordant couples, or even isoniazid preventive therapy to prevent the reactivation of latent TB. All of these things are actually at the same ISA level or higher than the intervention that we are proposing here. So I'll just close with this, that nutritional intervention is could be a highly cost-effective intervention in reducing TB incidence and mortality in India. Most of the benefit will likely derive from reducing disability associated with malnutrition, which makes sense because even though India has the most amount of TB of any country in the world, it is still much, much rarer than undernutrition. And about 200 million Indians are undernourished, and even more so now because of the pandemic. So clearly, like the positive externality of addressing undernutrition through this nutrition intervention, that kind of makes sense. That packs a bigger punch than the impact on TB, which is huge. You know, if you're looking at 78% reduction in incidence and 88% reduction in mortality, that is a massive reduction. So ultimately, I really hope that all of you will agree with me that nutritional policy can be wielded to expedite India's TB elimination efforts. And I have so many people to thank. I don't have time for that, but I'll close with this line from Tracy Kidder, which says, giving people medicine for TB and not giving them food is like washing your hands and then drying them in the dirt. Thank you for your attention.
Thank you very much, Dr. Pranay, for that wonderful overview. We would now like to introduce our next speaker. And up she's there, Dr. Sharon Cox, who is, next slide maybe, thank you. Dr. Cox did her clinical training towards a doctorate at Ghana on low-dose maternal vitamin supplementation and its effect on the immunity in malaria in pregnancy. A really commendable and difficult work that she's been able to do. She became a staff at the London School of Tropical Medicine within the MRC International Nutrition and has worked in malaria and anemia in Gambian children. And then she's moved to be at Tanzania, mostly working with sickle cell anemia. Well, she's been appointed as professor at the School of Tropical Medicine at Global Health Nagasaki and held a joint position as an associate professor at LSHTM. And to her credit, she's got over 75 peer-reviewed publications, really a remarkable achievement. And in her new position, she's now the lead epidemiologist for TB in UK. It's really a great opportunity that Dr. Cox could be with us to enlighten us. And over to you, Dr. Cox.
Thank you very much. It's an honour to be invited to speak today at your meeting of the Indian Public Health Association. So I'm going to try and share my screen. And hopefully this is going to work. Yes. Okay, so everyone can see my slides. Okay. So I have no conflicts of interest to declare. So for the session today, I hope that the participants will take away the sort of main messages and understand what the main types of food delivery and food alternative delivery models and their probable advantages and disadvantages. And as Dr. Anurag Bhagava has already sort of indicated, the limited availability of evidence from well-designed evaluations of any interventions so far of nutritional support for persons with TB disease. And obviously I'm going to focus on low and middle income settings. So I'll talk a little bit about malnutrition and TB, but I think most of that has already been said. And then I'll talk a little bit about some of the work we've been doing in the Philippines and look at the risk factors. And there's a reason for that. And then we'll look at some of the food delivery and nutrition sensitive strategies in TB and evidence base, and then some conclusions, which are really my sort of personal conclusions. So in the Philippines, the experience there is that, like in India, undernutrition is the single biggest risk factor, so has a population attributable risk factor of about 30% compared to 55% for India, although we have to remember that these are estimates. But you'll see in the figure on the right that the relative distribution of the size of the attributable fraction of these risk factors are actually very similar. So as we said, we know that undernutrition is a very big risk factor for active TB disease. And in the Philippines, like in India, there's a low prevalence of HIV, and the TB epidemic in the Philippines, which actually has I think it's the third or the fourth highest incidence currently, estimates, it's not being driven by HIV. So it's a very different situation to Africa, where a lot of the research and the work is being done in an African setting. In India and the Philippines, it's quite different because it's not being driven by HIV. And so, again, as you're all aware, I hope TB causes acute malnutrition through sort of biological mechanisms, from increased energy, protein and micronutrient requirements. And this also occurs at the same time that TB is causing through both biological decreased intakes through loss of appetite, nausea, difficulty eating when patients are very sick, and also through social mechanisms where people have reduced earning capacity, job loss, or are unable to farm effectively. So in the Philippines, the prevalence of malnutrition in adults is much lower than in India at 10%. And also in the Philippines, to see moderate or severe malnutrition in adults in the absence of TB or other illnesses or other sort of major catastrophic events is really quite rare. So although the population attributable fraction is quite high, there won't be many people, adults, who are severely malnourished before getting TB. So a quick look at the cohort that we started in the Philippines. So we've enrolled 900 persons within 5 days of starting a TB treatment in 13 public facilities in 3 regions. And you can see in the figure on the right is showing the prevalence of malnutrition in the 3 regions. So in metropolitan Manila, so very urban, Negros, which is mostly rural, and then Cebu, which is much more sort of a mix of peri-urban, urban. So the highest rates of malnutrition are in the most rural area, but also in the urban area, and we were working in the kind of poorest urban slum areas, which also has the highest prevalence of severe malnutrition. And as expected, and as seen many places, the undernutrition was highest in those started on multi-drug resistant TB regimens. But when we look in more detail, some of these urban-rural differences, I think, are probably due to differences in case presentation, delays in case presentation and management. So in the table on the right, this shows a multivariable adjusted analysis, and the take-home message from this analysis is that the major risk factors for being malnourished at the start of treatment is duration of TB symptoms before starting treatment, and again the history of having been treated for TB before and being classified as relapse or failure, or it might be recurrent because treatment could have been several years ago. And interestingly, when you adjust for these two factors alone, the association with multi-drug resistant TB entirely disappears. So it's confounded by these two factors. And another interesting observation was that the biggest risk was actually in the younger age groups, not in the elderly. So the middle here we used as the reference. So that's just to give a bit of background to the Philippine situation, which is similar but not entirely the same as in India. So how might we want to intervene and provide food or food alternatives, and what are the best delivery strategies to do this? So I want to talk about three main options. So ready-to-use therapeutic foods, similar to those that have been developed for community-based treatment of acute malnutrition in children, and this is especially so in Africa. And then the use of food baskets, and then finally consider the use of cash transfers. And what about the combination of all of the above? And then what I'm not really going to talk about here is other social protection interventions that might be nutrition sensitive. So first I want to talk a little bit about ready-to-use therapeutic foods. So what's important to remember is that these can actually be made using locally appropriate ingredients, and they're fortified for all micronutrients. And in adults, these are not actually meant to replace normal diet, but to provide a very sort of practical, easy to distribute and use and safe, high density package of protein, energy, micronutrients. So in the figure on the right, I'm actually showing a version of this that's made by a not-for-profit called Valid Nutrition, who have set up production facilities in a range of different countries. And you can make these with different ingredients. So what most people think of as the peanut-based pastes, the most well-known is called Plumpy Nut, made by a company in France. And obviously that's not the ideal situation. You want to be able to make these locally using ingredients that are produced and farmed locally. And increasingly, lots of different formulations are becoming available, being developed. And this can include more like a muesli granola bar, which probably adults prefer, or even a milk-based drink, which might be suitable, especially perhaps in an Indian setting. Another potential advantage of using RUTFs is that as evidence is generated, they could be tailored to include additional target nutrients and bioactives as a sort of complementary therapy. They also, of course, don't need cooking, and so if you're very ill and you're poor, you don't have the time and the effort and the resources to cook, this provides some food that you can eat even when you're feeling completely knackered. Less storage space, easy to distribute and carry, for example, than raw foods. Now, it depends on the context, but potentially you could argue that it's more sustainable because you would have a single supplier. You would hope that supply should be reliable and there should be less waste and less price fluctuations. But that really depends on whether you've got it being made locally or whether you're having to ship and import costs, which then might make it more expensive. As I said, taste and acceptability is an issue. Adults often don't like the versions that are made for children, but different formulations can be made. And then there will be less sharing with family members potentially with this, and this is really good or bad depending on what your objective is. So what about food baskets? The advantages here, again, it can be made up locally using what's available in the markets, affordable, and using culturally appropriate foods. And this could be considered a longer term solution, especially if you're also providing nutrition education, and therefore could also be seen as more empowering to individuals and households. And as is being done in one trial, another way of looking at it is that you can provide a sort of nutrition vaccine to the whole household if you provide enough to ensure that the whole household receives enough to either treat or prevent malnutrition that may be present. However, this is not a simple operation. Distribution, maintenance, quality of supplies, who is responsible, that is a big undertaking, and I'm not sure that TB programs, it would be very difficult to ensure that TB programs are suitably resourced to make that happen. An alternative way of doing it, which I personally think would be a very good way to think about this, is using food basket vouchers to local retailers. So then the program only has to manage the voucher system, and then that takes away a lot of the logistics nightmare and puts it more on to the local retailers. Of course, you wouldn't have as much control, but it'd be a lot simpler to manage. And then I think another factor that needs to be always remembered is that with this kind of food basket, it's very important that you have the nutrition skilled personnel involved in the planning and the management, because as supplies go up and down and prices, you need to have a nutrition person who can keep adapting the basket so that they are suitable and cost effective. Another thing that we thought about and wanted to do was cash transfers. So arguably just giving cash instead of food might be actually much more cost effective and simple to manage. And then you're assuming that individual patients and households, that they are the ones who are best able to decide how to use the cash in their own set of circumstances and priorities. And therefore you could argue that this is actually the most empowering and would be important to prevent households dissaving and protection against future shocks. And this could be done alongside nutrition education. However, again, like food baskets, you need to give a sufficient amount to have a significant impact. So often I think cash transfers, whether it's just about reimbursing travel, the amounts that are being given are just not enough to really make a big enough impact. So disadvantages, you have to accept that some will not be spent for the benefit of the patient or the household. And you can try and put in more and more control to prevent that, but then you just increase the expense of your program. And I suggest that it's better just to accept that some of it will not be spent how you want, but that's life, and that's actually keeping it simple is probably the best strategy. It would also be harder to assess the short-term impacts and the impact specifically on nutrition. And then finally, the local context will make a big difference. So in the African setting, there's mobile microfinance and money transfer systems are very, very common. And if you have this in place, it's actually very easy to manage in that you don't nobody has to handle actual physical cash, and you can transfer money on a daily basis if that's what was the best option. Daily, weekly, monthly, it makes this kind of intervention so much more logistically simple. So what is the evidence to guide best practice? Well, and as again Dr. Bhargava has already sort of said, there's actually very little evidence, and it's not that there's evidence that it doesn't work, there's just no evidence really either way. And of course, there's not so many clinical trials, but even where programs are providing food or food interventions, often they're really not designed to be evaluated, or they're not evaluated properly, and they're often poorly managed. And from my experience in the Philippines, where food was being provided through the World Food Programme to MDR TB patients only, it was completely impractical and not useful for patients, and a burden on the staff in the programme who were supposed to manage these huge amounts of rice. And again, just rice and oil is really not a balanced diet. One of my personal bugbears is that the objective of providing food supplements is often stated as improving treatment adherence, and therefore not enough is provided to support weight gain in already malnourished individuals. If we should, and as the previous speakers have emphasised, if you have malnourished patients, this is not about adherence, this is about managing a clinical comorbidity of malnutrition. So what about studies for cash interventions? So there was a recent systematic review by Richterman et al. And although there were 7 studies included, by the time they excluded those with high risk of bias, there were 3 studies, didn't assess impacts on nutritional status, but they did show improved TB outcomes. And I think that's pretty powerful evidence that cash interventions can make a big difference. And one thing I'd like to talk about is that there's actually substantial research comparing cash versus food in developmental economics, so outside of TB. So there's been a lot of work looking at this in poor households with pregnant women or young children, for example. And the general conclusions are that there's very mixed results. And again, it really depends on the context. So where the context is appropriate and the study is implemented well, you tend to get better effects. There's no published studies comparing cash versus food transfers in TB, at least to my knowledge. However, there's one study, a very small pilot study, was interesting, which looked at food baskets versus ready-to-eat therapeutic foods. And this was using the peanut-based commercial one. So I would argue that a locally made one would have been better. But in this pilot, they demonstrated that this really was feasible and acceptable, in that 100% received the monthly supplies of both interventions, transported it to home and consumed it all. But food baskets were preferred and were cheaper. But again, because it was a commercial and imported, 50% of the cost of the IUTF was shipping and import. Whereas if it was made locally, I think that the cost would be very comparable. So what are the conclusions? So as a researcher, of course, I'm always going to say more research is needed. I think that best practice is going to be determined very much by the local environment and needs. I think it's really important that skilled nutrition personnel are involved in all stages. And I think, all TB programs should recognise the need for nutrition skills at every level to be built in as part of their program. I think a lot of lessons could probably be learnt from development economics and the food versus cash interventions that have been done in other settings. And as I said, I think the implementation is actually probably as, if not more important than whatever the intervention is. It has to be frequent, regular and reliable, with good communications and clear appropriate targets. And in an ideal world, I think a flexible combination of all 3 is likely to be optimal. And I'll just let you know that we are still trying to get funding for a pragmatic trial of a locally made granola bar biscuit formulation versus cash transfers on TB and nutritional outcomes, and also impacts on long-term poverty. But unfortunately, we weren't funded this time. This is being led in the Philippines by my collaborator, Dr. Juan Solon of the Nutrition Center Philippines. I forgot my acknowledgement slide, but I'd like to thank everybody that I've worked with, especially in the Philippines. Thank you very much.
Thank you very much, Dr. Sharon Cox, for enlightening and sharing from your wide experience of looking at this very important area of food delivery models and how it has worked and the ways that we could move forward with regard to this important area of nutritional intervention. Thank you very much. With that, could we move on to the next topic? And perhaps if you have the time, you are most welcome to be with us towards the end when there could be a few questions. Moving on, we are glad to present the next well-renowned speaker, Dr. Natasha Hochberg. She holds a position of an associate professor at the Boston University School of Medicine and Public Health at the Tropical Medicine Institute, and also has a coveted position as the director of infectious disease in the fellowship program there. Truly commendable. She has a wide experience and is the president-elect of the clinical group of the American Society of Tropical Medicine and Hygiene, a very prestigious professional body that we know has been there for a long time, and a lot of learning lessons that we've had from it. She's been a former EIS officer of the CDC program. We know much of what we know about epidemic intelligence, much of which has come from very hard work put in by the EIS officers in various parts of the globe. We're so glad that Dr. Natasha, you could join us and share from your important area about nutritional interventions for TB. And over to you for your talk.
My name is Natasha Hochberg, and I'm an associate professor of medicine at Boston University School of Medicine and in the School of Public Health and at Boston Medical Center. Today, I'm going to be talking about our study called Tuberculosis, Learning the Impact of Nutrition, or TB Lion. I wanted to start by just acknowledging I have no conflicts of interest to report, and to thank BU Foundation India for funding to help put on this symposium, as well as other funders for the work that I'm going to discuss. The learning objectives for today are going to be to describe the rationale for studying TB and malnutrition, to evaluate whether the TB Lion intervention is effective at increasing weight, and to understand the impact of malnutrition on the immune response to TB. So many of you might have seen this slide, which is put out by the WHO, thinking about the NTB strategy. And that if we continue with our current global trends, we are going to be nowhere near the NTB goals. But to optimize use of current and new tools and to introduce new tools in a vaccine, we can potentially start to reach this target. But I would argue that we already have this effective vaccine that's not being utilized, and that's food. So the goal of our study, you've heard a lot from Dr. Bhargava, very effectively describing the importance of thinking about nutrition and driving TB, our study really set out to answer, why does this happen? How does malnutrition impact the immune response and promote the development of tuberculosis? And more importantly, can we reverse this process by feeding malnourished individuals and prevent the development of tuberculosis? So we are studying malnourished and well-nourished housemates of people living with TB. So we identify a pulmonary TB patient and then enroll their household contacts. And then we look at their immune response, including things like blood signatures that help us understand if that person is going to go on from infection to develop active tuberculosis. So as part of this, we're doing a number of different nutritional assessments. We're doing anthropometric measures to try to understand the nutritional status, including BMI or body mass index, the mid-upper arm circumference or MUAC, the waist and hip circumference, skin fold. We're doing serial dietary recalls over time, and we're looking at also blood measures, including albumin, electrolytes, and micronutrients. Now, importantly, what we're doing is we're providing a food intervention. This is a package of rice, ground nuts, lentils, and oil that provides 2,600 kilocalories for adults and 1,300 kilocalories for children, as well as a multivitamin. And this is provided for 6 months, which overlaps with the period of time that that person with tuberculosis is getting treated. We derived this intervention with assistance from Dr. Padma at NERT and Dr. Bhargava, and this was derived from the Indian TB nutrition guidelines and clinical feeding guidelines. Importantly, we're providing food to the whole family, recognizing that we couldn't just provide food to the one person that's really at risk. People were going to share the food, and that ethically that was important for us to ensure that the whole family was adequately nourished. So what we do is we enroll participants over here at a screening visit, and then we select a subset of them who we follow over the course of 2 years. And that includes providing food that you can see here. We also check blood over time, stool over time to look for parasites. And when parasites are identified, we provide antiparasitic treatment. And then importantly, we're looking in that blood over time to look at that immune response and looking to see if people develop tuberculosis or develop those blood signatures that they suggest they will develop tuberculosis. To date, we've enrolled almost 500 individuals, of whom 72% were eligible. You can see that we're screening out people that have diabetes, that are younger or older age, as well as other factors. Among those, we select individuals who have evidence of tuberculosis infection. That's with the interferon gamma release assay, or IGRA, and you can see more than a third of individuals are IGRA positive and then can be enrolled. And then we select a subset to enroll longitudinally over those 2 years, and that includes individuals with parasites, individuals that are just malnourished, or those that are malnourished and have parasites, and then a control group. You can see that this population is relatively poor, that it's a crowded household, up to 8 individuals in the household, some with lower levels of schooling. And you can see that a lot of these individuals are really exposed to this TB patient, both with the number of meals that they're eating with them, sleeping in the same room. The majority of almost 80% are sleeping in the same room, if not the same bed as the TB patient. And this doesn't tend to change once people start on TB therapy. So a very exposed household group. Our intervention works. So we can see here when we compare those who are well-nourished, who have a normal BMI and don't receive the food package, versus those that are malnourished and do receive the food package, you can see that based on our 24-hour recall data about calorie consumption, you can see a marked increase in calorie consumption among those receiving the food package. And as a result, we see a really nice increase in weight over the time of the intervention. So what does this mean from an immune perspective? Well, data that we've analyzed suggest that those that are malnourished have an increased inflammation and sort of senescence of their immune response, suggesting that it's almost like an aging response in response to tuberculosis infection. And as a result, we can see that those who are malnourished in red compared to those who are controls or well-nourished in blue are more likely to have these signatures of risk, these signatures in the blood that suggest these individuals are going to go on to TB disease. So in conclusion, we've shown that malnutrition increases the risk of TB disease, potentially through this immunosenescence and immune dysregulation, that our TB Lion food package is effective at increasing weight, and data to come on the impact of weight gain on this immune response and the risk of progression to TB disease. This is the work of many individuals. I'd like to highlight our incredible team at JIPMER, led by Dr. Subhita and Dr. Prakash, with a fantastic group of field team, co-investigators at Rutgers, the National TB Elimination Program, Boston University, NIRT, Dr. Bhargava as well. Thank you very much.
Thank you very much, Dr. Natasha. That was really enlightening and commendable, and the team efforts that's been working on this important area of intervention for TB control in India is remarkable. Well, we would like to request Dr. Subhita to be our next speaker, and if I can please have the slide to introduce her. Well, there is she. Dr. Subhita is additional professor at Department PSM JIPMER with over 10 years of teaching in international collaborative research projects. She's been awarded the Ford Foundation grant by the IAPSM, has been associate editor of the International Journal of Medicine and Public Health, is a reviewer in the Indian Journal of Medical Research, perhaps one of the best and well-known journal for that we have, was awarded the B.K. Mahajan Award for the best paper published in the IJCM 2018, and has been a resource person for workshops related to capacity building, epidemiology, research methods, and health systems. She has coveted over 98 papers published in national and international journals, and also contributed to a book. Really proud of all the achievements that young Dr. Subhita has been working and achieved. And on behalf of this panel, may I request you to please make your presentation.
Thank you very much, sir. Yes, thank you. So thank you, sir. So I'll be picking up from the earlier speakers. So far we heard about nutritional supplementation for tuberculosis, and we saw about how it's called a vaccine, a nutrition vaccine for people, not only for the patients, but also for the household members to protect them. We saw about the various methods that are being explored in other countries and settings, like food baskets, locally available foods, ready-to-use supplements, cash vouchers, and what works and what doesn't work. So this is just a small experience sharing from the earlier presentation. That is the TB Lion project that we are currently undertaking in this institution. So next slide. So we'd like to share the perspectives of both the household members as well as the healthcare workers about how this nutritional supplementation is viewed from their side. Next. Yes. So as I mentioned, this is a subcomponent of the TB Lion study to explore the beliefs and attitudes of the household contacts of persons living with tuberculosis and key informants with respect to the nutritional supplementation. Next. So we've seen about this supplementation package from the beginning. So what the guidance document says, and which is also being practiced in the earlier study that Dr. Anurag Bhargava was mentioning. So was mentioning about his ration study. So here in the TB Lion study, we are undertaking, basically it's a smaller component number of participants looking at the immunological component and biomarkers, but we are also tracking the weight gain and the participant experiences. So here the nutritional intervention is targeted at malnourished household contacts of TB patients, okay, and which is delivered in their homes through bi-weekly visits for a period of 6 months. So again, as Dr. Natasha was mentioning, it is directed for all the household members, for the whole family, and the nutrition component is also higher than what is usually prescribed to take into account that for their weight gain. Next. So this study, basically, we look at the qualitative component of in-depth interviews and focus group discussions. So among the household contacts and the healthcare workers. So we've completed 6 interviews and 3 among healthcare workers so far. So these are very preliminary results, but it gives an insight into what they are feeling at their end. Next, please. So audio recorded data was transcribed into text and following the usual thematic analysis. So we've built a conceptual framework on revolving around the acceptance, utilization, the perceived benefits and challenges, and also their suggestions on alternate delivery models and what may work in their settings and so. Yes. So first we look at what the household members had to say. So we looked at the different themes. So what emerged was more like what were the attributes of food that they received, the delivery methods for delivering the food in their households, the benefits as perceived by them, and finally, some other observations by the field team members. So coming to the attributes of the food, by and large, they were satisfied with the quality of the food, though there were some initial issues, and then we replaced with by a wider variety and a more stricter quality control. So this was well received by the participants. In terms of quantity, most of them felt that it was adequate, while 1 or 2 of them felt that it was in excess of their requirement for the household. But most of them said that it is adequate for their regular use. Regarding the frequency of delivery, they felt that we were visiting them once in 2 weeks and doing the household refills. They felt that it was just sufficient for them. Regarding the choice of the food items, so we had given a variety on the type of food basket. So based even on the nutritional document, only thing based on the formative research, we went in for rice and dal combinations, and further we widened the dal combinations as well, because the focus here was to make sure that people eat the right amount so that there is a weight gain and we are able to see some translation in terms of the immune effects that we were looking for. So this choice was also well received, and we received further suggestion to maybe modify 1 or 2 based on their requests. So in terms of delivery methods, currently we were doing a house visit and a door delivery. So there were suggestions, though many were happy about it, but a few suggestions were to a different team that gives. It's not because when we go from the hospital, though we try to maintain as much of this thing, they feel that when it's a research team that goes or so, there is some amount of curiosity from the neighbors. So that was another observation that was there. So they felt delivery through some others would be useful, or their collection or their pickup from Anganwadis or from the program offices or from the local health centers. So that also was suggested by 1 or 2 of them. So food vouchers, again, 1 or 2 of them mention about how food tokens can be given. Moving on to benefits. So weight gain was one which was commonly felt by most of the participants, and increased energy, the correction of their tiredness, anemia. These were the other health benefits that was perceived by the household members. So one other effect was their savings on food, because we were providing them food. They felt that they could use the amount that they usually spend on food for purchase of other items, like be it household items or even for a wider variety of nutritious food. So the other observations were overall there was a level of satisfaction among the participants, But this was one thing to note was the reaction of the neighbors. So it was either in terms of curiosity or the stigma, or they had to say something else because they were receiving food quite a lot and compared to the others. And when we saw the initial profile, they're all from a lower socioeconomic status. So they had to say some other way because tuberculosis still has its stigma around it. So this was one more thing we noted. The last point was because this is also cutting through the COVID period. So the general coping during COVID. So many of them had lost their jobs. They had to take loans. They had to sell their things to survive through this period. So what our field team observed was for many of them that this food assistance at this time really helped them to sustain during these times. So this was a major observation from our teams. Now quickly on some of the quotes told by the participants. So this was from one of the female household member that it was the intervention was helpful. So initially her mother was not was very feeble and was not able to even stand. But now with the help, she's able to regain her vigor. So next, so these were some of the overall comments that we got about the supplementation. Next. So quality of food, again, as I mentioned, they were satisfied with the way it was, the food, the variety was given, the way it was stored in damp-proof containers. And so the way the quality in terms of easy cooking and less amount of sorting or cleaning that they had to do. So this was the observations during COVID, that when they had no income, that this food security as a measure helped them. Yes. Next. So briefly on the healthcare workers' perspectives that we were able to capture. So they felt that apart from the tablets and the direct benefit transfer, so this food rations that is was being provided for a few of the members was, they said that it is ultimately very beneficial and also life-saving for the patients, not only for the patients, but also for their household members. So this is about the utility of the cash transfer. So it was very well known that people use that money for other things, not exactly for the food supplies. So giving it in terms of in a different alternate method would definitely be welcome. Next. So they also said that bi-weekly, because though we give food, the healthcare workers suggested a check or a monitoring mechanism in place. So they said bi-weekly is good, so that they really, it reaches them and they use it rather than using it as a source of income. And regarding the food basket that is being provided by this intervention, they said that the rice and dal is okay, but the oil quantity that we had given was quite less. So that was their perception. And finally, again, a word of caution was that the program was already loaded with enough patient care and monitoring services. So they said that if it's an independent, a different organization or a different stream of people doing it, then it would be really serving the purpose. So these were some of the perspectives that we could gather. So quickly to summarize, so this was just an initial exploration. So basically, our idea was that from what we learned, we were planning to suggest a few things in terms of either a gathering of people or a symposium, which was initially planned. But with COVID, we could not take it further. So with some help and support and our previous a few of the brainstorming sessions, we were able to reach out to many people that you see now on the platform. So they were all very forthcoming and very helpful when we said that this is cost to an initial advocacy type of effort. So I really extend my heartfelt gratitude for all the speakers for all working for a common cause and hoping that we'll be able to really make a change to meet the goals as Dr. Padma had mentioned. So that is how this was. It's more like a hybrid. So we have many people watching it live on the platform as on the virtual conference. We've also tried to mobilize our local partners here. So stakeholders from a wide variety of fields who are here, and a few of them who have joined outside of the platform as well, watching it online and live. So I'm very thankful for all the good response and support from the field workers and from the other stakeholders as well. So next. Finally, I'd like to thank all our field members. I would have left out a few of the names here, but our field teams, our collaborators, our program supports, and other stakeholders. It's all your well wishes. Thank you. All of us are working for a good cause. Let us continue. Thank you. Over to you, ma'am.
Thank you, Dr. Sudhita. That was a wonderful summary of the good work that you are doing. It is so encouraging to see that the supplements have been well received. So, Dr. Purti, I just thought we are actually half an hour above time, but I want to acknowledge the commitment of our speakers who have joined from US. I just realized that it will be middle of the night for them, very, very late, but still they're awake and online to answer questions and be here with us, even though virtually, shows their commitment towards TB and also nutrition support for TB patients. So are there any comments? We haven't received much questions in the chat box. 1 or 2 questions have already been answered by Dr. Anurag. If you have any comments, or can we have the final remarks from you, Dr. Purti, and then we will like to close the session.
Yeah, thank you very much. I think it's been a wonderful session, hearing from all the esteemed speakers based on the work that they have collaboratively been able to do. I'm sure there's a lot of work to be done, and because of the time shortage also that we have, we need to work together towards TB elimination in India. Thank you very much.
Thank you, sir. We are actually running short of time, not only for the plenary session, but as such for TB control in India. Just final thoughts I would like to add, if it's okay with everyone, because we are also encroaching on the lunch time here in India. It was good to see the variety of talks we had. We got the idea about the TB burden from Dr. Padma. That gives us an idea about if at all we are trying to have an intervention, nutritional intervention, like all of us need, we feel the need is there, but how it will be possible to implement such a program for the huge number of patients in India. It is definitely going to be a big challenge, though we understand very well that the DBT, direct benefit transfer, that is happening now may not be actually getting translated into food on the plate for TB patients. As Dr. Subita was saying, it is used for many other purposes, though it is a support for the family of the TB patients, but may not be getting translated directly as increased food intake for the patient. As Dr. Sharon Cox was telling, items like the food basket or ready to use therapeutic food would be better. But we in our setting need more research on cost effectiveness. Dr. Pranay was telling about the cost effectiveness of this intervention. We agree, definitely it is effective, but we need to know more about which of these interventions, what will be the type of food that can be provided, which will be acceptable to the families without increasing the stigma, and it will be more cost effective. So if we have a comparison of which intervention can work better operationally and also cost effectively, that would be better to do such studies. We are of course waiting for results from Dr. Anurag Bhargava's ration study. That would be definitely showing us the way forward. But I think we need to do more. Dr. Anurag may take up this later about which of the types of interventions would be better received and more cost effective. And finally, it was encouraging to see the results from the TB Lions study about how it has actually improved the families of TB patients. And again, this result would show whether we are able to reduce the activation of TB among household contacts of TB patients. That reduction would also lead to a contribution in lowering the burden of TB in India. So I think I'm able to close the session now. Dr. Purti, is that okay? If there are no questions from anybody else?
Yes, I think that would be a meaningful time to bring this session to an end by thanking all the speakers, all the audience, all those who asked questions, and to all the esteemed speakers who did take time off from their as you mentioned, it's been late night in other part of the world, but so encouraging to find out that they were up there to see that we are able to be part and participate in Iphacon 65.
Thank you, sir. So we can move on to the next part of the session without a break. The next part of the session is going to be moderated by Dr. Natasha and Dr. Pranay on socially responsible industries, looking at the corporate social responsibility and how they can get involved in TB control in India for different interventions like the nutritional interventions. So over to you, Pranay and Natasha. And thank you for being there at such an odd time of the day for you. Thank you once again, and over to you, Natasha.
Thank you so much. And I think we're gonna jump right in. Pranay, do you want to go ahead and start with the introductions?
Absolutely. And it is an absolute pleasure for me to introduce Matt Oliver, who is an incredible global health advocate. He founded and ran the Global TB Caucus, which really is amazing. It's like herding sort of 2,500 cats, except those cats were actually members of parliament, and he got them aligned on the cause of TB. And now his work is regarding ending workplace TB. And so without further ado, because we're running short, we should get going with Matt's talk. Thank you so much for speaking, Matt.
Great. Thank you, Pranay. And hello, everyone. My name is Matt. I am the project lead at an initiative called Ending Workplace TB. And first of all, I would like to thank the organizers for inviting me to speak and for all their efforts putting on this event. And to you, the audience, I appreciate that schedules are busy. So thank you in advance for listening for the next, hopefully less than 10 minutes. So I've been asked to speak about the economic and social consequences of TB, or otherwise put, why should anyone care about TB? And the challenge, I think, when talking about this to an audience of largely public health experts or TB people, is that you already know the answer. There is something about TB as an issue or public health more broadly that resonates with you. And so in some ways, the last group of people who need to be told why TB is important are you. So what I'm going to try and do is instead talk you through the process that we follow at the initiative that I lead to try to convince some of the world's biggest companies to prioritize TB within their workplaces. And in doing so, talk about some of the different cost components that TB carries, but that people don't always recognize. So first of all, who or what is Ending Workplace TB? We are an initiative set up to bring together world-leading technical expertise with big employers to improve TB care and prevention in the workplace and in global supply chains. We help companies by sharing best practice, providing technical support and resources and materials. And as a consequence of trying to do this, it means that we spend a lot of time with companies trying to convince them to prioritize TB. But before I jump into the what exactly we say, there are a few things that we've learned along the way that I think might be interesting. The first is that moral arguments are insufficient. I think a common theme in TB and almost all health issues, in fact, almost all campaigning issues, is to assume that if you could only just give decision makers the facts as you see them, they would be inspired to do all the things that you want them to do. And I have worked with parliamentarians before I started working with Ending Workplace TB. I set up a global network of members of parliament. And so I know, parliamentarians and companies are both constituencies that can be really powerful allies. And I know that the moral argument is just insufficient. It's important, but it's not enough. And the reason is simple. The minute that you walk out, having made your carefully prepared pitch with all the best stats you can find, somebody else walks in with an equally carefully prepared pitch with equally carefully prepared stats that shows that their issue is just as important, or maybe more important. And then when they leave, there's another. And another. So we should never assume that simply giving people information about TB is enough to get them on side. The second point that we've learned is that it's very rare that the person that you speak to in the first instance of talking to a company, or even if you're talking to a politician, is the final decision maker. So what we actually have is a double task. The first is to make an ally of the first person you're influencing, and then work with them to find the best way to influence the people that they need to get on board with whatever you're proposing. So it's important to keep an eye on who your targets then need to influence. And the third point, and I think it's related to the first, is that everything is really local. There's no not much merit in talking about global or even sometimes national statistics. What matters to a parliamentarian is their constituency and maybe something within their political portfolio. And to a company, it's about the workforce, the community, and sometimes their customers. The rest is really superfluous. It can be useful, but it's not going to win you the argument. So with that in mind, how do we talk to companies about the impact of TB? Well, there are 6 things. I mean, there are more, but there are 6 core things that we talk about. The first is risk mitigation. So repeated studies have shown that even in well-ventilated offices, office environments, in high-income countries, one active case of TB can result in widespread latent infection and then risk of onward conversion. So if you're at risk of maybe half of your workforce falling ill if just one person gets sick, it's a very real and tangible reason to act quickly. The second point is that it doesn't require a lot of technical expertise. Many of these interventions are quite simple, and people just want to know what they can do, how much it will cost. And so by highlighting that interventions are simple and not making it sound too technical, we can change how they think about the costs and benefits of working on TB. The third point is productivity, and I'll come on to that a little bit more in the following slides. But ultimately, somebody who is sick is not going to be delivering the same output as somebody who is healthy, either when they're in the workplace or if they have to take time off to recover. The fourth point, particularly important during the pandemic, is resilience. Many of the measures that we're talking about are cross-cutting. So policies that can tackle TB can apply for COVID or other lethal respiratory pathogens, and not just respiratory diseases. You know, it goes broader. We're talking about obviously nutrition today. It has an impact on TB, but that has an impact on so many other factors of an individual's health and well-being. Fifth is brand. Quite simply, an outbreak could be lethal for your workforce, but it could also be lethal for your brand. Nobody wants to be the site of a public health crisis. And then all of this comes together to make a return on investment. Jameson Malamela, who is a member of Ending Workplace TB with Sibanye Stillwater, is speaking in a few minutes, and he can speak much more about the return on investment. But I'm sure that he will tell you that it is financially beneficial to a company, as well as being the right thing to do to look after their workers. So digging back into some of those productivity costs, we see 5 groups or buckets of costs that add up to really significant numbers. The first is absence before diagnosis. So this varies massively from individual to individual, but studies have suggested that in India, as many as 180 working days could be lost prior to diagnosis, which is an astronomical amount of time off work. And then that can be compounded after diagnosis, because in the best case scenario, you're maybe looking at 2 to 3 weeks where you need to isolate. But in all likelihood, particularly if there was a long period between falling sick and being diagnosed, that absence after diagnosis is going to be considerable as well. The third packet is productivity itself. So side by side, how much work does a healthy person get done versus somebody who is infected with TB? And we don't know for sure. One of the things that Ending Workplace TB is trying to do is dig into this, but we anticipate that it's between 10 and 20% based on other illnesses. And so if you think 20%, that is a lot. That is a day of work a week where you are getting through less output than somebody who is healthy. And that is would be a problem for any employer. The fourth category is to do with the cost of replacing the labor that you are losing as a consequence of their sickness. Even in low-skilled workforces, it's not a given that somebody will get up to speed and be as effective as an experienced worker straight away. That takes time and that carries cost. And then lastly, healthcare costs or statutory costs, or even retirement due to being sick. This varies a lot from country to country in their legislative framework, but all of that carries a cost to a company, whatever it happens to be. So overall, putting all of this together, we estimate, and we're hoping to run some studies to really drill into these numbers, but we think that the cost of a single sick employee is between 6% and 38% of their annual salary. It could be higher, of course. This is a kind of a range, and it could be higher, it could be lower, but most likely we think it's going to be in that bracket. And that is a lot of cost, and that doesn't even take into account the prospect of somebody else getting sick as a consequence of a colleague being ill. So overall, if you put all of these things together, the 6 factors on the previous page, and these productivity costs, it's quite easy to make the case that the cost of an individual being sick or an outbreak is significantly less than the cost of the interventions, that some of which are being discussed today. One final point that we make to companies that is slightly tangential to this is that one alternative that some people might think would be effective for dealing with TB is to get those people out of your workforce as quickly as possible. And you hear stories about employers firing people who have been tested positive for TB. It is hard to think of a single less productive or effective disease control strategy. Treating people affected by TB in such a way that is forcing them out of the workforce is not going to stop there being TB in your workplace, but it's going to stop it being talked about. And it's going to stop it being tested for quickly. It's going to stop people getting treated. And that means people are going to be sick for longer and carrying more risk of passing it on. So ultimately, all of these things considered, the cheapest intervention of all is building a positive workplace culture around health. And that comes from managers, that comes from colleagues. It's free. It just means if you are feeling under the weather, go and get checked out. Your company will support you, and that makes everybody healthier in the long run. So that's the end of my 10 minutes. If you're interested in joining Ending Workplace TB, you can contact us on partners at Ending Workplace TB. Thank you for listening, and I'll be around for any questions later.
Wonderful. Thank you so much.
Thank you so much, Matt. And the next speaker is going to be Arvind Kumar Pandya, who is our partner from USAID. He has extensive experience with designing, implementing, and monitoring social development commercial programs. Most importantly, right now, we've been talking a lot about the corporate TB pledge, and we'll hear from him a little bit about how he's been motivating Indian businesses to engage in the TB elimination program using their financial and human resources. So without further ado, let's go with Arvind Kumar Pandya's talk. Thank you so much, Arvind.
Good afternoon to all of you. Thank you for giving us this opportunity to share our experiences of engaging the corporates and fostering socially responsible businesses. On behalf of USAID, we would like to congratulate and share our deepest appreciations to the Indian Public Health Association and JIPMER for organizing the 65th National Conference. My name is Arvind Kumar. I work at USAID as the Senior Advisor for Strategic Partnerships. For those of you who are not very familiar with USAID, we are the US government's premier agency for developmental programs. We work in about 100 countries. In India, we have been working with national government, state governments, private sector organizations, civil society organizations, research and academic organizations for more than 70 years on different developmental programs. Our programs include promoting education, food security, clean energy, and public health. Public health continues to be a major portfolio for USAID. We largely focus on 5 major health goals: ending preventable and maternal child deaths, eliminating TB in India, creating an AIDS-free generation, promoting comprehensive primary care, and very recently focusing more on emerging pandemics, including COVID. I have a brief presentation. Let me share this with you on our experiences. I hope you can see my slide. TB, as all of you know, is one of the world's most deadly infectious diseases, killing more than 1.5 million individuals annually. Unfortunately, India has the world's largest burden. Annually, we lose about 400,000 Indians to TB, and several $1 billion are lost every year because TB affects the most productive age group of 15 to 59, and most of the people who have been affected by TB falls in this age group. The Prime Minister has identified TB as a major challenge and has given a clarion call to eliminate TB by 2025, much ahead of the goal set by the Sustainable Development Goals. However, though TB continues to be a major challenge, still it cannot be addressed just by the government alone. You need a lot of other stakeholders to also closely work to eliminate TB. The recent initiative of government, Jan Andolan program, is exclusively and primarily focused on eliminating TB as quickly as possible in India. The corporates, the private sector have a very important role to play in eliminating TB in India, not only at the national level, but even at the workplace and at their society level. However, many corporates have not played a very active role in eliminating TB for various reasons. Some of the reasons could be they are not aware of the magnitude of the problem of TB in India. Some of them may be thinking that this is a government's responsibility and their role is very limited. Some of them may be thinking that there's definitely a role that they can play, but they are not sure how to go about it. Or some of them may even think this is a too complicated process and are probably hesitant to support TB awareness and prevention programs in the country. This is precisely the reason why USAID and the Government of India, particularly the National TB Elimination Program, jointly launched the Corporate TB Pledge in 2019, primarily to address some of the issues that I just mentioned. So the Corporate TB Pledge's primary goal is to galvanize as many companies as possible to support TB awareness, to support, eliminate, and promote TB treatment, as well as support the TB elimination cause. So one of the main things that we of this Corporate TB Pledge is to keep the effort very flexible and simple. So if you see in the slide, we have in the Corporate TB Pledge 4 levels: the silver, gold, platinum, and diamond. Silver is a very simple and a basic level for corporates to join. It's just a commitment by the company saying that we are committed to doing something for TB in our workplace programs. And this could be just a policy signing or just a commitment made in their organizational mandate. Gold is the next level, where there is a commitment plus there is a clear plan of how they are going to create awareness within the workplace settings. So in this case, the companies put together a plan. Okay, we will have TB awareness programs on the following days. Maybe it's on the World TB Day. Maybe it's on the World Health Day. So they give up a clear commitment, and there is a plan and some dedicated resources provided for undertaking TB awareness and prevention programs within the workplace settings. The third is the platinum level, where companies, besides giving the commitment and creating awareness within their workplace settings, also invest their corporate social responsibility resources, CSR resources, for undertaking TB awareness and prevention efforts within the catchment area. So that's the third level. And the fourth level is the diamond level, where in addition to doing awareness, in addition to doing having a commitment, in addition to undertaking some community level programs, they also take a leadership role wherein they motivate other corporates and other organizations to join the fight against TB. So that's broadly the 4 levels. When we started this effort in 2019, we thought that most of the companies will be at the silver level, but in 2 years, we have now more than 125 companies who have joined us in the Corporate TB Pledge. More than 80% of them are either at the gold or at the platinum or at the diamond level. This is to just give you an idea about some of the companies who have partnered with us. So flexibility, giving the flexibility was one of the major factors we felt could bring in a lot of companies to join for the social cause. And it definitely did bring in many companies to join at different levels. The second aspect that we wanted to consider and address some of the critical issues is that we wanted to make sure that whichever companies are joining us are getting the right type of support. So we have a Corporate TB Pledge Secretariat, which has got a 5-member team, and this Corporate TV Pledge Secretariat offers a range of support to the companies, whether it's developing a work plan, whether it's developing a CSR plan, whether it's providing them the communication materials that they could display in their workplaces, whether it's training their healthcare providers, linking them to the government for treatment and diagnosis, bringing together other private sector organizations in the same area to work together. As well as document and disseminate the company's experiences widely. So this is the type of corporate PB pledge support that's being provided to the companies. So the companies don't have to at any point of time worry, okay, what should I do? What am I supposed to do? They can just pick up the call, or they can just send a mail, and our secretariat will immediately respond and support them. The third thing which we did was to ease in the whole operations. Many times companies do not want to spend a lot of time where people or NGOs come to them and undertake programs. It's a limited time they have, and we have to be mindful and respectful of that. So what we did is we created an online platform where the company's own team can undertake the various activities. There is a clear formats available. Like if a company wants to develop a policy, there are examples of policies which they can review and then prepare their own templates. There are templates and forms available for them to prepare their own work plan. There's a templates available for them to get an idea as to how much does it cost for these operations to be done. There's information available on who in the district or in the state they should contact for diagnosis or treatment support. They have other supports, like, for example, the moment they do something, immediately a dashboard of their company's performance they can see, and they can compare how they have performed against the plan. The dashboard also provides an opportunity of overall the CTP program, how various companies have performed. And so individual companies can review and see how they have performed against the different companies. There are also other opportunities within the online platform, like webinars, any technical material, sharing of best practices. Those are also available in the online platform. So we just wanted to ease it and make the corporates to own this program on their own. The fourth thing is that we provided multiple opportunities for corporates to collaborate with the National TB Elimination Program. And this includes both corporate social responsibility models or philanthropy type of models, as well as business models. So there are several examples where companies have just used their CSR resources to create awareness and facilitate testing and treatment in their local catchment areas. But there are also opportunities where companies have integrated business models. For example, Fujifilm has partnered with QRAI to integrate an artificial intelligence solutions whereby the X-ray reports are now quickly read by machines. This saves a lot of time and addresses the critical human resources for health issue. Same way, there are other companies which undertake many other programs. For example, there are also opportunities that we have created where companies don't have to provide their funds in advance. So it's outcome-based financing that we have provided. For example, if you achieve a certain thing, then only the corporates provide their resources to support the programs. We also have Johnson & Johnson's, Becton & Dickinson organizations who are involved in training a lot of healthcare providers, training a lot of lab technicians, thereby strengthening the overall system and infrastructure to manage TB in the state as well as in at the national level. The fourth area of support that we have provided is to not just limit the work to only their corporate premises or to the district level. We had made through USAID and our partner, we have made all the efforts to make sure that the good work of corporates are widely disseminated, widely appreciated, recognized by various stakeholders. So there's a best practices compendium that we have given, which is shared widely across the industry bodies. We have from the health minister to various state ministers to business bodies, recognizing and appreciating these organizations for the good work that they have done in our TV programs. So that's another support that has been provided, which is a critical support for companies to get their work recognized. Finally, we also had a lot of partnerships and local governments ownership. If you see here, we have partnerships with, at the national level, the Confederation of Indian Industries, FICCI, ASSOCHAM, the American Chambers, the US India Strategic Partnership Forum. All of these associations have contributed in a big way to for the corporate TB pledge, promoted it amongst their members. So it's a big support, and I wanted to acknowledge their them at this time. Similarly, we have also had regional associations who have partnered with us. For example, the Federation of Kutch Industries Association. Same way, sectoral. Like for example, we have taken many organizations like the Indian Tea Association or the Agra Footwear Manufacturers and Export Collaboration Association, who have all partnered. So there are different types of associations who have also partnered with us on the corporate TB pledge and elevated its complete role today. Similarly, the local government's ownership has also been phenomenal. I need to acknowledge the tremendous support that's been provided by the Central TB Division, the National TB Elimination Program, the state TB officials, and the district TB officials for this program. So at the district level, all the district TB officials have been oriented on the corporate TB pledge. Directives have been provided by at the state and the national and at the national level for supporting the corporate TB pledge. And there are also several states who have now got it as a workplace policy. There's state level workplace policies for TB. All those things have enabled and brought in a sort of a togetherness for the industry and the government to collaborate for eliminating TB in India. I'll stop here. This is just a slide on the organization, our implementing partner, a union who is supporting on this. This is a slide that is available to share who should they contact in case of any help or support that is required. Thank you. I'm happy to answer any questions if you have. And once again, congratulations to the Indian Public Health Association. And I wish the conference all the very best. Thank you so much.
Thank you so much, Arvind. Yeah.
That was fantastic. And I think I know we are right before lunchtime, but I think, you know, sometimes hunger really makes us focus on the critical issues. And so we ask you to hold on just a little bit longer. Unfortunately, one of our speakers, Jameson, was not able to participate, but we are thrilled to have our final speaker. And this is Nalin Kulatilaka, and he's the Wing Tet Lee Family Professor of Management and Professor of Finance at the Questrom School of Business at Boston University, and the Director of the Susilo Institute for Ethics in a Global Economy, and has a number of different awards and fellowships, including being at Stockholm and Taipei, and has a number of publications. And I'll say that one of the genesis for having this symposium was a conversation I had with him where he was talking about ethics in the global economy, and I was talking about tuberculosis, and we were on a panel together, and we said, well, we really need to think about how we can merge these two ideas. And so it's just amazing to see this all come to fruition. And I'm incredibly grateful to the Indian Public Health Association, to JIPMER, and to Dr. Subita and Dr. Sonali and their teams for actually making this happen, because I think it's been a tremendous panel discussion with a lot of really fruitful ideas. And I'm hopeful that we can move forward with and sort of carry some of these onto the next stage after this symposium. But with that, we'll take a listen to this next talk.
Let me begin by thanking the organizers for inviting me. And a very special thanks in advance to you, the audience, for taking time to listen to me. I'm Nalin Kulatilaka. I'm a financial economist at the Questrom School of Business at Boston University. My research and teaching interest these days is on finding innovative ways to direct more capital towards socially beneficial projects. I must confess, I have no particular expertise in dealing with the TB epidemic or specific business realities in India. So my remarks today would be quite general. I hope you will see their relevance to the issues at hand, why and how businesses need to focus on the challenges of TB in India. I begin with a bit of history. We know that most of the world has experienced unprecedented rapid economic growth over the last 5 decades. This has lifted millions, if not billions of people out of poverty. What's interesting is that businesses played a critically important role in bringing about this growth. But these measures of growth, as GDP increases, miss an important side effect that have come with growth. Environment has been polluted to such a point where human health is compromised, and entire ecosystems are facing severe stress and even extinction. We also know that the growth hasn't been shared by all. Inequalities have widened across the world, stressing our societies. It is against this backdrop that the likes of the TB epidemic in India need to be addressed. So the question is, can businesses play an equally key role in helping solve these grand challenges? This is where CSR comes in. Modern business corporations are designed and structured to make profits for owners, the shareholders. Why then should businesses have the responsibility to society at large or to the communities they serve? What's the motivation for CSR? Over 3 decades of experience has shown that CSR investments yield clear benefits to corporations. And this comes from several established channels. First connection is that responsible business behavior increases consumer affinity for the products the company produces and thereby improves its brand. For many, this alone is ample justification. More recently, there's also the connection that responsible business behavior increases the employee affinity to a company, and thereby it helps acquire talented and motivated workers and to retain them. So there's a labor market response as well. The one that I'm mostly interested in, that I think you will be convinced as well, is that increasingly, in more recent years, investors have also began showing interest in CSR activities by firms. They direct their capital towards companies that are more environmentally and socially friendly. Here's a graph that shows this, a survey result that shows this affinity. You see that there's an increasing number of people over time and coming up to 85% of the general public who say that this is either somewhat or very important as they make their investment decisions. What's even more interesting is that this interest is greatest amongst younger people. So this is something to be very optimistic about the future as well. Now, this interest doesn't go unnoticed with the asset management industry, which is the group of people who manage trillions of dollars of people's investments. And you see that their statements here are showing that they've recognized this and they're shifting their investment strategies accordingly. And this is in fact something that is a global phenomenon, as this very successful Singapore sovereign fund shows. It's in fact become part of the mainstream investment analysis for them as well. What is staggering is the amount of assets under management. So here's a graph that shows the number of firms that have been signatories to the United Nations Principles of Responsible Investing guidelines, and over 3,000 firms had signed them by the end of 2020. And what's even more staggering is the number of assets under management by these firms. It's over $100 trillion of assets. Even though this has been a phenomenon that began in the West. The take-up in Asia has been encouraging. And as this graph shows, you see that Asian firms in various parts have also been picking up on this theme. So there are a number of ways in which investments can be directed towards socially responsible projects. The two on the left here is where portfolio investors, these are people who would be directing their resources towards portfolios of market-traded firms. They take into account and integrate the environmental, social, and governance, or ESG factors in their investment decision-making. So they'll move away from companies that are doing harm and move towards companies that are acting responsibly. In others, portfolios are constructed by aligning people's values with the values of the company. So if the original asset owners, the investors, care about certain social outcomes, then they align their portfolios with those. There's also, on the right-hand side, these purple blocks are showing that there is a different kind of investments, mostly private equity and venture capital investments that are directed towards entrepreneurs who are trying to explicitly solve social problems. This kind of capital tends to be having the mission first, but economic viability as a necessary condition as well. So where does the topic for this conference fit in? It is in fact in this S, the social part of these ESG metrics. So the investors now see the activities of corporations that are beneficial and responsive towards the social needs, and those are rewarded by driving and directing more capital towards those firms. So that is the hopeful message that I wanted to convey to you. Thank you.
Thank you so much, Nalan. That was a wonderful, wonderful talk. And it really, I think, the idea as a millennial, it does resonate with me very much. The idea that when I invest, money should go to do good in the world and not just sort of exacerbate the situation as it is. So at this point, we'll welcome you to sort of this post panel discussion. I think, Natasha, you're going to start us off with the first question. For this panel, we are using a tool called Mentimeter. And what this allows to do is if you go to menti.com on your phones or your computers, and you enter this code, you'll actually be able to participate in this discussion somehow, because whatever you type into that into the box that you find when you enter that code, that's going to pop up here, and we're going to have a word cloud. And at the end of it, we'll know not just what our speakers think about it, who are experts, but also what you, from your from your sort of grassroots level experience, think about the barriers and the opportunities that we have in front of us. So with that, I'll stop. And Natasha, I think you're going to ask the first question.
Sure. So just to sort of reiterate to everybody, I think that our speakers have really nicely laid out some of the rationale, and I think Arvind has clearly addressed the effectiveness of the program and in engaging Indian businesses, but we really want to hear from the audience to understand how can one convince businesses to engage in addressing TB. While you're answering that question, again, go to menti.com, and then there's a code at the top that you can plug in. While you're doing that, I'd be curious to sort of hear, Arvind, if you have additional thoughts, and Matt, about this topic, about particularly engaging businesses in India.
Thanks a lot. That's a great question.
I think in general, if someone sees the trend over the last 10 to 15 years, I think the corporates are becoming a lot more socially responsible. One, there's a younger group of CEOs taking charge who has a greater vision for supporting public health programs. Second, I think some of the supportive policies of both the national as well as state governments are an enablers for more private sector to engage. And third, I think the whole space of corporate engagement has now expanded. It's just not limited to only corporate social responsibility and philanthropy. Today, you have so much of business opportunities. Even in my speech, I was mentioning about how companies can support programs, which has also got their own business interest into account. For example, even in the corporate TB pledge, we had undertaken linked corporates with new ideas with the Central TB Division and National TB Elimination Program. As a result, new supply chain solutions, new ways of reaching behavior change communications have all been provided. This is not only in TB, we are also now seeing this in COVID. COVID has further sort of amplified the whole role of the corporates for public health programs. So this is really encouraging. As soon as the economy improves, it's already starting to show signs of improvement. I generally feel that there could be more and more corporates coming and supporting public health programs.
Super, that's great. And I think it's really interesting to see the audience responses. Feel free to keep putting those in as we're talking briefly. Matt, I'm not sure if you're still on, if you have any other thoughts that you wanted to add to that as well.
Yeah, first of all, I'd agree. It's fascinating watching these words pop up, and I agree with a lot of them. And on the India context, obviously defer to Arvind and his considerable expertise. Just want to pick up on one thing that he said, which is sort of alignment. And I think that it's fairly common in the global health world, definitely in TB, to think that what we need to do is kind of convince companies or any other stakeholder to pursue our issue. Whereas the most effective way, I think, in convincing a business to engage in addressing TB is to make sure that TB aligns with the other things that they are doing. And so we've got to find different ways to make it easy to align TB-specific interventions into broader wellness programs. And one of the speakers earlier talked about Cure AI, and their system will use a single X-ray screen and can diagnose as many as 30 different conditions. And so what you're talking about there is a comprehensive approach to wellness, of which TB is a part, or the thin end of the wedge. And so that would be the way that I would consider going about it, at least if I'm in front of a company making a pitch, to say, look, you're already doing all of these things. It's easy to add on TB. And then the benefits, exactly as the audience is pointing out, around productivity and health and recognition can follow depending on the initiatives of the government or awards or so on.
Fantastic.
Brilliant.
Super.
So I think our next question was fairly similar. I think we'll move on. If you want to contribute to this question, you can continue to do so, but we'll actually move. I see people have thoughts about this as well, which is what is the biggest barrier to engaging businesses in India's TB elimination program? This is kind of similar to the first question. Given the paucity of time, I think I'd actually really like to move to the next step, which is often at the end of these inspiring conversations, we're all fired up, but this is, as Matt reminded us, tomorrow we'll meet somebody else who's very passionate about something, and we might forget about the problem that we're discussing today. So that's why it's actually really helpful to sort of take a moment and write down something for yourself. What will you do as a businessman, as a researcher, as a public health official, as an advocate, as a TB survivor, perhaps? What would you do after hearing all that you've heard today to contribute to India's TB elimination program? And you can enter your thoughts, and they're going to pop up here. Cross-disciplinary efforts.
Could I offer a quick thought on this one, Pranay?
Yeah.
So I think, one of the challenges with engaging businesses is they don't naturally have to listen to people like us, right? Their constituencies are their shareholders and their board and to a certain extent their employees. So what we've kind of got to think about in terms of getting companies on board specifically is who can influence those companies who does have to listen to us. And so, in that instance, it may be, a high profile academic institution, the senior leaders there connecting regularly to businesses, or parliamentarians, to speak to my previous role, or your own employers who can then sort of show an example. So I think it's not just about the kind of direct route about what can I as an individual do to influence some of the biggest companies in the world. It's who do I have access to who will listen to me, who I can then convince to go and target those people because they have a bit more clout or access than I do. And so I think that's one way that we can think about what we as individuals can do.
Absolutely. Yeah, and that's exactly what we were hoping with this was that this is a moment to think about what we can do individually. And for me personally, I think that the idea has actually changed my entire career. I've gone from being like a pure epidemiology, pharmacokinetics kind of a researcher to being somebody who now does health economics research with an eye to policy, because I see that as a way in which we can make an economic argument to business leaders and governments to invest in TB, in nutrition, because it is an incredible problem otherwise. I see some look for more efficient technical solutions to counter TB, especially extrapulmonary TB, sure. So this poll will actually remain open. I know our time is limited. I don't want to overstay our welcome, but this poll will remain open, and you can continue to contribute. And one thing that we're hoping to do is to encapsulate a lot of the amazing things that have been said today in a paper and publish it. And so we will definitely try to sort of incorporate verbatim what you're putting in here, if that is okay. Natasha, any final words?
I just want to thank everybody again. I think it's been really inspirational, and I think we've hit on a lot of really important topics, and hopefully this is just step one, and that we continue to build off of the excellent work that Matt and Arvind and Nalin and all of the teams are working on, and to sort of follow up on the first half of the symposium and really think about the impact of nutrition, because I think there's a lot of important work that we can do there. So I just want to thank the organizers again, thank the BU Foundation India for helping support the symposium, and we appreciate everyone taking their time. So Sonali, back to you, or Subita at Chipmer.
Thank you so much.
Thank you, Natasha and Pranay and all the speakers. We really appreciate your time, and it is such an odd hour being awake and contributing to the discussion. So because of lack of time, we are not able to have more discussion, but I hope all our participants here who are present in person have also learned something today. We'll carry forward this discussion, definitely. So we have taken the pledge today, so we will. Thank you all.
Thank you. Over to the main hall. Dr. Stuti, please take over.
Sati, over to you. Yes, ma'am. Thank you so much, ma'am. Thank you for that. Thank you for that wonderful session on India's tuberculosis epidemic. We now move on to the next plenary session that we have in store for today. So we're now going to be talking about immunization 2.0, targeting adults, a rather important topic in today's day and age. And to chair this session, I am pleased to invite Dr. T.S. Selvavinayagam. So sir is a joint director of the Department of Health and Family Welfare, Government of India, and is situated in Tamil Nadu. He has a vast experience in health insurance schemes and non-communicable diseases program, and he has also been involved in the implementation and management of the same. Sir has over 6 original research works to his credit, and not to mention many more that would do justice to Sir's many credits. So with this, I am pleased to invite Dr. T.S. Selvavinayagam.
Now starts. So, good afternoon. Am I audible? Yeah. Thank you, Mr. Tans. First of all, I want to congratulate JIPMER for organizing this Public Health Conference 2021. I personally like to extend my sincere thanks to Dr. Sitan, Sonali, my colleagues Gautam, Premraj, and everyone. And as you all know, when you are responding to the COVID pandemic, you will understand the value of the public health response, which become prominent day by day. And adult vaccination will be one of the things which very soon we are going to handle it. So, for example, when I entered this campus today, I was searching for the location where it is. People guided me to say that Usi in Tamil they call it. That means where the vaccination is happening, go to that building. It is near this place where the conference is happening. So this is the value which we are going to get it. Maybe this is the point of this afternoon discussion, where we'll be talking about the adult vaccination, which has become very critical in the days to come, mainly because of the epidemiological transition, and also definitely it has got a bigger role to play in reducing the morbidity and mortality, but also to reduce the overall healthcare cost in the coming days to come. So to discuss on this, there will be a different ways in which it need to be handled, like which disease need to be covered, or what are the approaches which we need to have, and what is the expected challenges which you are expected, or although existency, all those things. For discussing on this, we have 3 eminent speakers today. First, I would like to introduce Dr. Madhu Gupta, Professor, Department of Community Medicine and PGI MR, Chandigarh. She'll be talking on why adult immunization and what disease to target. She's having an experience of 18 years in teaching and research post-MD, and she's an awardee of International Network of Voice, an R.N. Roy Best Paper Award, and also participated in the multicentric study for COVID-2-3 Covishield vaccine trial. And she has around 127 publications and books to her credit. I welcome Dr. Madhu Gupta.
Thank you, sir. So it's an honor to be here with the August gathering, and it's a great opportunity. I'm very thankful to the organizers. I think there's a video which probably is being run. Hello, everyone. Today, I'm going to speak on need for adult immunization and target vaccines. At the outset, I'm thankful to organizers of Iphacon 2021 for giving me this opportunity to share my views on the need of adult immunization and target vaccines. So I'll be covering why there is a need, what are the target diseases for adult vaccinations, which vaccines are available for adults and also healthcare professionals, what are the barriers to adult immunization, strategies to improve adult immunization. Vaccination is one of the most cost-effective strategies available in public health today. In addition to protecting the vaccinated individual from developing a potentially serious disease, vaccines help protect the community by reducing the spread of infectious diseases. And what other disease can demonstrate that now better than the COVID-19 pandemic itself? And we have seen that after the vaccination, the cases have really come down of COVID-19 disease. So what are the reasons why we should have adult immunization? And this is also one of the advocacy for immunization version 2, where we should focus on adult immunization as well, in addition to childhood immunization. So first reason is immunosenescence. Immunosenescence is the waning of immunity over time. So as we age, we become susceptible to serious diseases caused by common infections. So you can see in this graph that this orange line, dotted line, is the immune competence, and this blue line is the risk of infectious diseases. So when the child is born during infancy, this immune system is not well developed and they are at a higher risk of getting the infection. And they are protected through the national immunization schedule, and in each country this is the structured immunization program, and also there's a high vaccine coverage and awareness also is there. And as the child grows into childhood and adolescence, he's quite his immune system is well developed and he's quite protected from the infectious diseases. And in adulthood, then gradually there is a waning of immunity, which is seen with many infectious diseases. And once they reach the older age group, there is a very low, almost a very low immune competence with the adult and especially elderly population. And we can see that when the immunity is low, there is a higher chances of risk of infectious diseases. But on the contrary, contrary to what is happening in the childhood, we see that for the adults, although their immune competency is reducing and their risk of getting the infection is increasing, there are no national guidelines for covering this group for any vaccine. So there is negligible vaccine coverage, and also there is not much awareness, and there is no demand for adult vaccination. So this results in preventable, if we give vaccines in adulthood, it results in preventable morbidity and mortality, especially excess hospitalization. Also, if we do not take care of their infectious diseases, they diminish quality of life, especially we can see that post-herpetic neuralgia in elderly patients, and this can be avoided by giving vaccines. Missed work period, medical complications, and economic loss, because this is the adulthood is the most economically productive age group. So routine vaccination in adults expected to protect against a range of contagious diseases. Then we also know that there is a life expectancy which is increasing. So population above 60 years has increased from 10.4 crores to 17 crores in last 10 years, and we have more number of elderly population now. So they are already suffering from non-communicable diseases like diabetes, hypertension, cardiovascular disease, and cancer. So their immune system might not, and also we have seen their immune system is also not that competent to protect them from various infectious diseases. And they might also get the infection from the grandchildren at their homes, from the diseases they might not be expected to acquire, like pneumococcal diseases and or COVID-19 disease in their homes. The severity of the diseases is more among the elderly population than the younger age groups. So, and leading to higher morbidity and mortality among this group. So preventable morbidity and mortality is higher among this group. So by having a immunization program, so elderly and adult vaccination, elderly can be protected from life-threatening complications of communicable diseases like invasive pneumococcal disease by offering vaccination. Also, what we have seen that there is an epidemiological shift in the affected age group. So shift is seen from childhood to adulthood for diseases like pertussis, diphtheria, measles, rubella, and these outbreaks have been reported in adults due to incomplete immunization coverage in childhood, especially seen in developed countries where there's a lot of vaccine hesitancy because they're not seeing the measles cases among children. But then this susceptible uncovered population is when they grow up, they enter into adulthood in an unimmunized state. And whenever they're exposed to these viruses, then there's an outbreak among this susceptible population. Another reason could be that the coverage of these vaccines is so high in the childhood that the organisms, they find adults more susceptible than children. Then emergence of antimicrobial resistance. So drug-resistant infections result in more than 100,000 deaths annually worldwide, which is projected to reach 10 million per year 2050. So vaccination can resolve the multi-drug resistance crisis by reducing the antibiotic requirement, thus supporting their appropriate use and curtailing their unnecessary usage. So especially vaccine may be helpful to target drug-resistant variants of pathogens like Salmonella type 3, Streptococcus pneumoniae. Then we definitely can protect the high-risk adults in various occupational groups like food handlers, for typhoid, healthcare professionals, hepatitis B, influenza, COVID-19. And now with the experience of COVID-19, which we have implemented throughout the nation after 16 January 2021, the healthcare delivery system is better prepared to take up adult immunization. We have COVID-19 vaccination centers, we have trained staff, they are managing the cold chain equipments, we have even our COVID portal system, and we are monitoring adverse event following immunization. So I think we're all good to go and launch sustainable adult immunization program. The health system is more prepared, and there are definitely benefits of adult immunization. So particularly for older adults, it breaks the chain of transmission of infection, build the herd immunity, reduce the burden of disease among patients with chronic conditions. Then there are reduced incidence of vaccine-preventable infectious diseases in the community, reduced hospital admissions, reduced treatment costs for the population, and improved quality of life. So what are the various target diseases which we must consider in immunization version 2 for adults? Dash et al. Have very nicely consolidated table showing the outbreaks, especially affecting the adult population from 2006 to 2017. So according to this data, the meningococcal disease, which there was an outbreak in Delhi, hepatitis B from Gujarat, influenza outbreaks in West Bengal, Kerala, Maharashtra, measles, Karnataka, Japanese encephalitis, West Bengal, and influenza again in Rajasthan, diphtheria in Assam, varicella in Tamil Nadu, hepatitis A in Kerala, and varicella in again Rajasthan and Nagar Haveli. So this shows that in these outbreaks, the number of adults, proportions of adults were more as compared to other younger age groups. So there are associations which are recommending that vaccines should be given to adults, especially for these diseases, like Association of Physicians of India, API. Then in United States, we have adult immunization program for last so many years. So CDC, Center for Disease Control, Advisory Committee on Immunization have their own guidelines. American Academy of Family Physicians, American College of Physicians, American College of Obs and Gynae, and American College of Nurse Midwives, they all recommend that vaccine preventable diseases such as influenza, typhoid, pneumococcal pneumonia, measles, mumps, rubella, diphtheria, pertussis, tetanus, meningococcal meningitis, HPV infection, chicken pox, varicella, shingles, hepatitis A and B, and now COVID-19, the vaccine should be offered to adults. So this is the schedule as per CDC. So influenza is recommended in all age groups, especially inactivated and recombinated in all age group. One dose annually should be there because the strain changes every year. And live attenuated is only for population less than 50 years. Tetanus diphtheria produces one dose DTaP in each pregnancy, and we already have tetanus and diphtheria, 2 doses, and one dose DTaP and TD or TTaP booster every 10 years for adult population. Measles, mumps, and rubella, 1 or 2 doses depending upon indication, and if born in 1957 or later. Then varicella, 2 doses if born in 1980 or later for the population up to 45 years. Then 2 doses recommended for adults with an additional risk factor after the age of 45 years. Then this is zoster recombinant vaccine for ages more than 50 years of age. HPV vaccine is also, we have started giving for adolescents for prevention of cervical cancer. So 2 or 3 doses depending upon the age of initial vaccination or condition. And it can be given after that in 2 doses up to 45 years of age. Pneumococcal conjugate vaccine for the adult, single dose, or polysaccharide vaccine can be given, and 1 or 2 doses depending upon the indication. Hepatitis A and B vaccine depending upon the brand, 2 or 3 doses. Meningococcal vaccine, 1 or 2 doses. And HIV influenza type B, HIV vaccine can be given 1 or 3 doses depending upon the condition. Then we also have special certain circumstances like special situations, pregnancy, immunocompromised situation, asthenia, and renal disease or on hemodialysis patients, heart or lung disease, chronic liver disease, diabetes patient, healthcare personnel, and men who have sex with men. There is a recommendation by CDC for adults. API also have given their this year they have given their taken out a paper wherein they have recommended DPT, MMR, influenza, pneumococcal vaccine, varicella, HPV, and zoster vaccine for adults. So briefly about these vaccines. So influenza vaccine for adult immunization, for the policymakers, it's important to first of all show them what is the burden. And the burden is not easily available for these diseases. So because we do not have a surveillance system, which is currently a gap at the national level, that we are not keeping a record of how many cases are occurring because of influenza and what is the mortality. So there are a few of the articles which are there in the literature. So during peak periods of influenza activity circulation, that is during monsoon period, 20% of all hospital admissions have influenza positivity, and there are around 40,000 deaths that occur due to influenza annually. And person aged over 65 years, young children, persons of any age who have some comorbidity medical conditions are at higher risk. So this data also shows that these deaths or this morbidity number of cases can be prevented by giving influenza vaccine. So single dose is required annually, and live attenuated vaccine given to less than 50 years of age. Special consideration should be given to high-risk groups, preferably in the months of October and November. And vaccine having the latest strain should be used. Now we have a quadrivalent influenza vaccine, which is better than the trivalent, and that should be taken. It is given intramuscularly. It is overall a safe vaccine. There is not much safety concern. Then hepatitis B vaccine, definitely very much indicated, and it prevents especially deaths due to chronic hepatitis and also hepatocellular carcinoma. So there are high-risk groups like IV drug users, household contacts of hepatitis B, post-exposure immunoprophylaxis, patients with chronic liver disease, persons beginning hemodialysis, diabetes mellitus, so and also contacts of household members, sexual contacts, medical staff exposed to oral respiratory secretion, they should be offered hepatitis B vaccine. 3 doses should be given at 0, 1, or 6 months. Then pneumococcal vaccines, this also have a lot of potential, especially for the elderly population. So around 85% of invasive pneumococcal disease occurs in adults. And among adults with community-acquired pneumonia requiring hospital admission, Streptococcus pneumonia ranks first as a cause and accounts for most of such cases. There are about 155.8 million clinical cases of pneumonia globally, which contribute to approximately 1.9 deaths, 70% of which occur in Africa and Southeast Asia, and this can be prevented. So we have two vaccines, Pneumovax, which is a 23-valent pneumococcal polysaccharide vaccine, and pneumococcal conjugate vaccine. Now, 13-valent vaccine is available. So these are effective vaccine with good efficacy, and they reduce the spread of pneumococci from small children to unvaccinated older children and adults. So single dose is recommended, and the ASAP also recommend that sequential administration of both pneumococcal 13 and PPSV 23 to all adults more than 65 years of age. HPV vaccine. So Punjab had already started giving this vaccine. This is the HPV virus is the most common viral infection of the reproductive tract, and it can be one of the risk factors for cervical cancer. And there are about 132,000 women in the age here who are infected with cervical cancer, and 74,000 of them die. And some of this mortality and morbidity can be prevented by the use of HPV vaccine. So quadrivalent HPV vaccine are now available. They are about 95% to 100% efficacious against carcinoma in situ and 98% efficacious against genital warts. So routine vaccination of females at 9 to 12 years of age and catch-up vaccination for females between 13 to 26 years is recommended, and have mild side effects. Then measles, mumps, rubella vaccine provide protection against the congenital rubella syndrome, which is a big public health problem in India, wherein 40 to 45% women in childbearing age are susceptible to rubella. So, and over 2 lakh babies are born with birth defect because of rubella infection. It accounts for 10 to 15% of pediatric pathogens. 10 to 15% of children with congenital anomalies have lab evidence of CRS. So, and also it prevents outbreaks reported among adults in developed countries, and morbidity and sequelae due to mumps. So it's a live attenuated vaccine, very highly efficacious, 2 doses by 28 days. Can be given to students in post-secondary education institutions, women who could become pregnant later, like 3 months before pregnancy, and international travelers, risk exposure to these infections, household contacts of immunocompromised. So then another vaccine which is to be offered to adults is the typhoid vaccine. So there are 3 types: scaled, live, and capsule polysaccharide vaccine, which can be given to children as well. So we have generated some evidence of typhoid burden in India, and we are part of a national typhoid surveillance network nationally, which is funded by CMC Vellore. They have set up a surveillance for typhoid, and what we found that in the tier 2 hospital, which are secondary care hospitals, the incidence of typhoid was very high, about 156.9 per 100,000 person years in Chandigarh, which is an urban area as compared to the rural areas. So, and also we found that if we give a typhoid vaccine, especially in urban area, it is cost effective. So as compared to rural areas. Then another vaccine which can be offered to adults is the chickenpox, varicella vaccine. So this will prevent the morbidity due to post-herpetic neuralgia and especially herpes zoster. So rational is prevention of active infection, prevention of spread, and prevention of herpes zoster. So live attenuated varicella vaccine to be given to 19 to 35 years, more than 50 years zoster recombinant vaccine, and more than 60 years zoster live vaccine can be given. It is 100% efficacious, and 2 doses subcutaneously 4 to 8 weeks. Better is to give zoster recombinant vaccine. So adults without evidence of immunity to varicella, there is no evidence of receipt of 2 doses, and or there is a lack of history of varicella, lack of lab evidence, Then there is no previous vaccination, then 2 doses of varicella. If there is to be given, if there is a history of previously taken 1 dose of vaccination, then 1 dose of varicella vaccine has to be given. Then other vaccine is adult DTaP or tetanus, diphtheria, cerebral producers vaccine, or TD vaccine. So TD vaccine is already given in the national immunization schedule that should be continued. So if the already the person is immunized, then repeat dose, single dose can be, booster can be given at 10 years of age. Hepatitis A vaccine, another vaccine which can be offered to adults. So it is an inactivated vaccine for children 2 to 18 years, 0, 1, and 6 months, or 6 to 12 months, 3 doses, and more than 18 years, 2 doses are to be given. It is contraindicated in pregnancy. So it is recommended for all adults wishing to attain immunity, travelers, injection or non-injection illegal drug users, homosexual men, chronic liver disease patients, adults with blood clotting factor disorders, adults with an occupational risk infection. So it will prevent morbidity due to hepatitis A vaccine. Then meningococcal vaccine, because it was found there was a outbreak in Delhi which has been reported. So bacterial polysaccharide vaccine having ACYW135. It prevents meningitis A infection that can cause severe brain damage. So single dose can be given. Also recommended to military personnel, healthcare workers, and travelers going to Makkah, Hajj pilgrims. Efficacy of it has an efficacy of 90%. And Ghana and Sudan were the first 2 countries to include this vaccine in their routine immunization in 2016. The vaccine can be given to high-risk groups only, and especially those suffering with sickle cell disease, leukemia, HIV infection, and who have had a splenectomy. Single dose if they have not been previously received this vaccine. Cholera only recommended in academics and travelers. Inactivated vaccine, single dose subcutaneous or intramuscular is given. Japanese encephalitis, especially in endemic areas, to be given, recommended in travelers. So 3 doses to be given, 0, 7, and 30 days, and booster is required at 3 years. Polio vaccine IPV, recommended for travelers to endemic area, adults who have had a primary series of OPV or IPV. A booster dose of IPV is to be given. So 2 doses, 4 to 6 weeks apart, 3rd dose at 6 months. So especially in immunocompromised individuals where OPV cannot be given, IPV should be given. For healthcare professionals, hepatitis B, influenza, measles, mumps and rubella, varicella, Tdap, and meningococcal vaccines are recommended. These are some of the barriers of adult immunization in India. So, and what are the next steps? So, first barrier is the lack of surveillance. So, this is, we do not have exact data on various diseases, but we see there is a high morbidity and mortality. So, routine surveillance is required, and to have an estimate of the vaccine preventable disease burden in this population. There is lack of national guidelines, lack of coordinated adult immunization programs. So some of the associations are giving their own recommendation, but nothing at the national level. Lack of recording systems, missed opportunities for vaccination, especially when somebody is visiting the clinics. So there the physicians can advise that if they can afford it, they can get the vaccine there and then. Then some of these vaccines are expensive also, so may not be affordable. So for this, next steps could be that pilot studies to collect data on adult vaccine preventable disease should be carried out, or multidisciplinary consensus to develop national guidelines should be formulated. Also, to introduce a coordinated adult immunization program, which is uniformly implemented throughout the country. Incorporate vaccination into regular checkups, and more affordable brands for adults can be advocated. Also, lack of provider recommendations. So even the healthcare professionals are not aware of various options which can be provided to the to the patients. Treatment taking precedence over prevention. So most of the time, even the patients might not be willing, or the healthcare professionals might not be interested to give the vaccines, and they are more comfortable in treating the illness. Lack of knowledge or recognition of the benefits or efficacy or safety data. So that is education, awareness of the healthcare providers needs to be done to actually make them aware of various safety and efficacy issue of the vaccine preventable diseases or vaccination for adults. Then for vaccine, there's a lot of vaccine hesitancy also to among the adults. We have seen it with COVID-19 pandemic that initially they were concerned about the safety, about the efficacy of these vaccines. So education of the healthcare professionals and educating the community about the benefits of adult vaccines for them. Also, we need to promote life course immunization and substantiate the real value of vaccination at individual and societal levels. So these are, this is taken from Dash et al. Paper where they have recommended, where they've identified these barriers and suggested ways that how we can deal with adult immunization program in India. So with this, I would like to thank you, and queries are welcome.
Thank you, Dr. Madhu Gupta. It was a nice coverage. You have covered completely on the potential disease that can be included in the adult vaccination, and also the opportunities available, the special groups which can be considered for this vaccination, and also the strategies under which this can be done, and the challenges which we expect in doing this adult vaccination. A complete coverage on the adult vaccination. Thank you very much. Now I like to introduce Dr. Rakesh Agarwal, Director, JIPMER Puducherry, experienced in liver diseases, infectious disease epidemiology and vaccinations. Over to you, sir.
Gentlemen, good afternoon. I am very grateful to the organizers of the IPHA Conference 2021 for asking me to be with you and talk to you about COVID-19 vaccine. Please give me a few seconds to share my screen. Thank you. I have been asked to speak to you on 3 things about these today: the approaches to develop COVID-19 vaccines, the regulatory process for these vaccines, and the impact that these have had. And I'm going to talk to you about these. First of all, how have the vaccines been developed? The conventional approach to developing vaccine against any disease is to use the entire pathogen. This can be an attenuated virus. In the case of SARS coronavirus, this is still being developed, and Codagenics is a US company that is working on it. The method is to culture the virus through repeated cell culture passages that leads to induction of mutations, and the pathogen turns less virulent, less pathogenic. The advantage of these vaccines is that because the virus, attenuated though it is, multiplies within the body of the host and therefore generates a robust immune response, and therefore these vaccines usually need only 1 or a few doses. But they are difficult to develop. For some pathogens, these are never possible, and they carry the risk of activation of the attenuated pathogen in case of people who are immunosuppressed, and that can lead to adverse events. The second way we can use a whole pathogen is to culture the pathogen in vitro and then render it non-infectious using a physical or chemical treatment. This means that the pathogen must be culturable, which SARS coronavirus 2 is, Such vaccines are safer because the pathogen cannot multiply in the host, and the vaccine strain cannot multiply in the host. But because of that, the immune response is weaker, and very often boosters are required. Several vaccines have been developed for COVID-19 using this approach. Covaxin is one of them, and then there are 2 vaccines in China. The third approach is to use a part of the pathogen, a part of the virus, antibodies to which or immune response to which is protective. For SARS coronavirus, we know that immune response against the spike protein on the surface of the virus is protective. Therefore, people have used proteins corresponding to the entire spike protein or a part of it known as the receptor binding domain. The proteins are not as immunogenic as the whole virus, and therefore these need to be combined with adjuvants, and such vaccines need multiple doses. An example of this is the Novavax vaccine, which Serum Institute of India is also going to produce and is likely to become available very soon. Biological E is also working on such a vaccine. The protein, instead of being expressed as itself, if one takes all the proteins in a virus that form the capsid, it can lead to expression of the viral particle. So it's a multimer polymer which contains multiple molecules of the viral protein. Because these are large structures, immune response is better, but they are more difficult to make. There are 2 companies that have developed such vaccines, and these are in early human trials. What is really novel about vaccines for SARS coronavirus 2 infection is the development of nucleic acid-based vaccines. Till today, there was no DNA or RNA-based vaccine for humans available for any disease. The principle is that if we can send the viral DNA inside the nucleus of a host cell, this will produce mRNA, or for that matter, we could send mRNA in the cytoplasm, and either way that mRNA that is there can lead to production of viral protein, which will go out of the cell and can elicit an immune response against the virus. The problem is DNA does not easily enter the cells. In vitro, we use a procedure called electroporation, a small electric current. But if we inject a large amount, even then, especially with a gene gun, the amount of some amount of DNA does reach the nucleus and can produce the protein. The problem with mRNA is that this is inherently unstable. We have found a way around that. We can enclose this within lipid nanoparticles, and then this mRNA can be protected from the things that inactivate it, and these nanoparticles fuse with the cell membrane and help to deliver the mRNA within the cell. So mRNA vaccines are Pfizer and Moderna. These are extensively being used around the world. A DNA vaccine for the first time has been developed by an Indian company, Zydus, called Zykos-D, and it will be soon available. The next strategy, which has been extensively used, is a viral vector-based strategy. So what is done is that the gene for SARS coronavirus S protein has been placed inside a virus. In this case, let us say we take a human or chimpanzee adenovirus. In this, one essential protein is removed so that the adenovirus can by itself not multiply. Instead of that, a gene of SARS coronavirus 2 has been placed. When this is injected into a person, this is taken up by the antigen presenting cells, and this here produces a protein, and that leads to immune response. The advantage is that this is a novel way of delivering DNA inside the human body, but and the protein inside a human body, and it is very effective. This was first used in 2019 for developing a vaccine against Ebola. However, the problem is that such vaccines often need multiple doses. And the second thing is, if the person who's getting the vaccine already has antibodies against that particular virus, which is being used as a carrier, then the effectiveness may be less. One can also place the gene of interest in a replicating viral vector, which is an attenuated virus, such as we can take a pox virus, and then because these multiply, these elicit a stronger immune response. For the non-replicating viral vector, we have several vaccines. We have the AstraZeneca Serum Institute, what we call as Covishield in India, the Sputnik vaccine, and the Janssen vaccine. Replicating viral vectors have not yet reached the market. Once a vaccine is developed, how is the regulatory process? Regulators look at two things. Firstly, they look at manufacturing process. Does it follow good manufacturing practices by the current standards? Are there methods available to assay the quantity in a product and whether the manufacturing process has consistency? Secondly, they look at clinical aspects. Is it safe? Does it induce immune response? That is it immunogenic? Does it protect against infection, against disease, against death? And finally, they also look at whether these are present in a particular subject group, different ages, different sex groups, and situations such as pregnancy, the comorbidities, what is the duration of protection, and are there any contraindications, such as, for instance, live vaccines will be contraindicated in people who are immunosuppressed. Typically, a vaccine used to undergo studies first in small animals, then in larger animals, specific animal model, followed by a phase 1 study in a small number of humans to look for any major toxicity, then a phase 2 study to look for immunogenicity and if possible protection, and then a larger phase 3 study where several thousand people are involved, and this is to look at the protection or efficacy. And then it would be approved, and then one would go to mass vaccination. The process used to take 10 to 15 years. In case of SARS coronavirus 2 vaccines, this has been done within a year. And a part of it is because we have something called Emergency Use Authorization, or EUA. What is this EUA? This is a mechanism that has been developed by regulators to facilitate the availability of drugs, devices, and vaccines very quickly during public health emergencies, such as the current COVID-19 pandemic. Thus, under this scheme, regulatory agencies such as US FDA allow the use of medical products that are otherwise unapproved and for which evidence is not yet available to formally approve them, or approve medical products that are approved for something else for another use for which sufficient data is still not available. This is done when there is an emergency situation, there is a serious or life-threatening disease or condition, and several criteria have been met, including that there is no other adequate, approved, and suitable alternative. This is a temporary measure. This can be revoked anytime, and as more information becomes available, or if the emergency is gone. So US FDA in advance laid down the criteria for approval of vaccines for COVID-19. They wanted a minimum efficacy of 50% compared to a placebo, with 95% confidence intervals having a lower bound of more than 30%. They also wanted safety and efficacy data for more than 2 months for at least half the subjects in the clinical trial. The safety data had to be for more than 3,000 phase 3 trial vaccine recipients. And they also wanted sufficient number of severe COVID-19 cases in the trial so that they could assess whether there was enhanced disease because of the vaccine. Of course, they also looked at the manufacturing considerations. If on all this analysis, the vaccine appeared to be much more beneficial than carrying the risk, then such a vaccine would receive EUA. The World Health Organization has a similar process, except that it is called emergency use listing instead of emergency use authorization. And this is particularly useful to countries which do not have a stringent regulatory authority like USA, and for that matter, India have. Have the vaccines made a difference? What difference could we expect from the vaccines? Of course, we expected them to prevent infection. We would expect them to reduce disease, total number of symptomatic cases, as also, or possibly more importantly, cases with severe disease, disease needing hospitalization, ICU care, oxygen, and complex treatments. We, of course, expected to reduce deaths. We expected it to reduce the load on healthcare services, which were getting overwhelmed. It would be great if the vaccine could also reduce transmission by reducing the amount of replication that happens within the body of a person who's infected, or the amount that is excreted from the respiratory surfaces. It would be great if this if a vaccine could lead to eradication of COVID infection from a population, the entire world, or a subpopulation, for instance, a continent, a country, a district, or any other subpopulation. Again, one could hope that the vaccines would also, by reducing transmission, by reducing the multiplication of the virus, will prevent new variants from developing. The initial data on impact came from Israel, because that was the country that started immunizing very early in the last 10 days of December, and they also immunized a large proportion of their population. By the time they had immunized about 60 to 70% of their population, the wave was waning, the number of cases was drastically coming down, and they were able to take away the non-pharmacological measures that they had instituted. However, there is some increase recently, and let's go into that. This is a very nice picture that showed what happened from day 1 to day 50, as we go from above to below, in the second wave of COVID in UK and in the third wave in the same country. In this picture in red for the second wave, on the left we see the number of cases of infection per 100,000 population that were identified on different days. And here on the right, we have the number of deaths per 10 million population on the same days. We can see that the disease is increasing and proportionately the deaths are increasing. But when we come to third wave, by which time a large proportion of the population had been immunized, especially the elderly, we can see that from day 1 to 50, the number of cases increased. Similar numbers, 3.3, 3.4, 33, 33.6, but there was hardly any increase in the number of deaths, showing us that though the infection was not entirely prevented, those who were infected were much less likely to require hospitalization, ICU care, or to die. These are data from the US published earlier this year from 13 regions of the US where the vaccination and disease databases are linked. We can see that from late April to July, the number of cases have varied over time. The initial part is the disease because of the initial virus, the legacy virus. And then in July, we can see increase in cases because of the Delta variant. The black line shows the number of cases age-adjusted incidence per 100,000 population among the unvaccinated people. By comparison, the blue line shows the rate in the vaccinated population, and we can see that the rate is about 1/10. So there is a 90% reduction in cases with vaccination. The same is true for hospitalization as well as for death. In fact, the reduction for death is more marked than that for cases. More interestingly, as the Delta variant came in, there was an increase of cases in the unvaccinated. There was an increase also in the vaccinated, but this increase was relatively muted. So the vaccine does prevent against the Delta strain also. Even though the total number of cases increased in the Delta peak, but the number of hospitalizations and deaths did not. Therefore, it shows that the vaccination protected people against severe disease and deaths, even with the Delta variant. How about India? These are data that are in medRxiv from JIPMER, and it shows that when we looked at in a case control study, compared to unvaccinated people, people who had received 1 or 2 doses had protection of 49% or 54% against infection. of about 60% against symptomatic disease and of 95% for moderately severe disease. Extremely impressive and shows the role of vaccines and their impact. The impact of vaccine depends on several factors. Time does not allow me to go into each of these factors, but I strongly encourage you to read this paper published in August 2001 in Nature Reviews Immunology, which provides a lot of useful information on factors that influence effectiveness of COVID-19 vaccines. These are related to individual factors, these are population level factors, these are factors related to the virus, etc. So, what did we expect and what did we see? The vaccines do prevent infections and symptomatic disease. They are even more effective in preventing severe disease, hospitalization, and deaths. They have definitely reduced the load on healthcare services in the UK. This time in the third wave, there is no pressure for hospital beds. They reduce transmission, firstly, by reducing the number of infections per se. And secondly, there are some data to show that those who are infected excrete a smaller amount of virus and for a shorter duration. Will they be able to eradicate infection from the human population? That's extremely unlikely. We already are at a stage where the virus is a part of our medicine and medical system. We cannot reach that. Will it prevent the advent of new variants? We have very little data, but possibly that should happen, because if we reduce the number of infections, if the virus multiplication is less, then the number of variants developing would also be less. Of course, all is not hunky-dory. There are questions. Does virus protect against variants? I have shown you some data that it protects, though the efficacy is lower, but it does protect against serious disease and death. Will we need additional doses when new variants come in? We don't know. Possibly yes, possibly no. What is the duration of protection, and do we need additional doses in those who have been vaccinated? We know for sure that after initial vaccination, antibody levels decline over time. Some people get breakthrough infections. Additional doses have been shown to be useful in people who are immunodeficient and those who are very elderly, that is, those who are above the age of 80 or 75. But is it needed in everybody? You and me? Jury is still out. As of now, we don't have data to say that we need to give them boosters. Also, we have no data on the safety of such additional boosters. So I think we need to wait, and we would become clear about this as time goes along. With that, let me thank you for your patient listening. Thank you.
Thank you, sir. You'll be wondering how the chairperson changed because Dr. Selva Vinayagam had to leave for an urgent meeting. So I'm Sitanshu. I'm coming. We'll take the session forward from here. So the next presenter for today's session, today's plenary in Immunization 2.0 targeting adults is Dr. Narendra Kumar Arora. Sir is the Executive Director of INCLAIN, New Delhi. I started my career under Arora sir when I joined India CLAIN for some period of time. A meticulous worker and a great leader with extensive involvement in policy making, program planning, implementation, and evaluation of public health programs at both national and international level. A lot of fellowship and significant contribution towards public health, and in his field of pediatrics, he is a fellow of IAP, Indian Academy of Pediatrics, IPHA, ICMR, TSSF, Dr. NL Sarma Oration, KGMU, Lucknow, 12th KC Chaudhary Lifetime Achievement Award, Kerala University of Health Sciences Oration. So many accolades, and he has got 200 publications in national and foreign journals to his credit. It's a great honor and pleasure to invite Arora sir to deliver his talk on how to overcome vaccine hesitancy among adults. Thank you so much, sir, for accepting our invitation. I know how busy you are in this time, running from one meeting to the other. Sometimes they said that physical meeting was bad, but now with this online meeting, I know how busy you are with simultaneously maybe having 2 meetings and other things. So thank you so much for accepting our invitation and address our delegates who have 1,500 delegates who have joined us online. Thank you so much for your time, sir.
Thank you very much, Sitanshu. I'm truly honored with this invitation, and I thank IPHA for giving me this opportunity. I will share some of the data, both international and national data, that to what extent vaccine acceptance has been there, and then what is the way forward, how to move forward. So can I have my slides? Yeah.
Would you like to share your slides, sir?
Yes, yes. Can you see my slides?
Yes, sir, we can see your slides.
Okay, thank you. So
you can make it full screen.
Yes, I will do that. So Madhu has already shown this graph. The question is, and the challenge has been all these years, that although there have been many candidate, I would say, adult vaccines, but it has really not taken off for various reasons. Economics is an important component, but there have been other reasons as well. And although even in high income countries where influenza is part of the adult immunization or elderly immunization, even in the best place, the coverage is around 50%. So it is important that adult immunization has to be handled with different gloves vis-a-vis child immunization. There are differences, and globally people were really not certain what kind of issues will be bothering for adult immunization. So again, this has been talked about the issues. The key issue is the need for adult immunization, or showing the evidence that immunization in adults would be useful. So far, even as more data emerges, for example, influenza vaccine, the benefit seems to be more in children, younger children and women, rather than elderly. I mean, in terms of now priority, SAGE has kept children, pregnant women, and then elderly for prevention of serious respiratory complications with influenza. So, and this is primarily because the issues of surveillance, talking about estimating the true benefit of a vaccine is coming, and relative issues has been at the forefront. So this, I'm sure most of the audience must have seen. SAGE had established a working group on vaccine hesitancy. And this was particularly important in the context that as we move from 2010-20 to 2030, that means the current decade, it is emerging that even in those areas where vaccine hesitancy was not known, people are really worried about it. And in fact, out of the top medical challenges, WHO has identified vaccine hesitancy and resistance as a key component. And broadly, hesitancy or demand issues are kept with these 3 C's: complacency, confidence, and convenience. And one of the key component is the confidence issue, that confidence in the vaccine, confidence in the health system which becomes a critical factor. Early last year itself, with the onset of pandemic, it became gradually important that if something transformative has to come, it is basically vaccines. So this is May-April 2020, when not only in US, but other European countries, high-income countries, people started talking about, on one side, rapid development of vaccine, but on the other side, the issues of vaccine hesitancy and anti-vaccine people became active and started spreading misinformation or rumors. So now all of us would agree that social media is a very important source of our information, and systematic IT-based studies are being done for various social media platforms. And this study showed that while in the high income group, the issues related to refusal and doubts were very high. This is USA. This is UK. On the other hand, if I come to India, doubts was not so much. Refusal and doubts. Primarily, they were either neutral or accepted the vaccine. And this has been one of the hallmark of our country. Even China has a very similar kind of it, that refusals and doubters are very few. Mostly, either they are neutral, but mostly they are accepted. And in the high income environment, people usually have all these conspiracy theories and lack of confidence in the vaccines. And one of this time, it was how vaccine could be generated within such a short period, and the issues of safety, obviously. This is again another study, global study, which was done across 10 low and middle income countries with a large number. And clearly, there is a higher willingness to accept vaccine among low and middle income countries, around 80%, while it is only 2/3, or in fact, around 50% in some of the other studies. And mostly concerns are about side effects. And the issue of, if you look at India, that as age advanced, as education was more, the risk of hesitancy increased. But overall, it was less, no major gender differences. Another important component is health providers are an important leader and in fact determine the community acceptance part. And what I wanted to say, that age, usually if somebody, age and sex was not making difference, but education, the more educated one was, the risk of hesitancy and challenges of convincing a person increased in India, and which may not be seen in some of the high income. They have baseline issues of vaccine hesitancy, but in a low and middle income country, the more educated one is, the risk of hesitancy was higher. And so it generally shows the greener is the color, the more is the issue of vaccine acceptance. Lighter green is less. So there are shade differences between China and India, but overall, as compared to most parts of the world, this yellow indicates resistance and red is the highest degree. Again, this is another study done in India, which shows that 80% accepted and the resistance was only 9%. So consistently, even when I showed you the first, when it is global study or local studies, not more than 10-15% of Indians have difficulty in accepting the vaccine. What are the factors for accepting the vaccines and for refusing the vaccines? This is again Indian study, and the reasons for refusing the vaccine is concern about unforeseen effect of vaccine or fear of unknown, not realizing not accepting COVID as an important issue and vaccine, the value of vaccine, cost to some extent, which we know that it is not a factor, and no perceived risk of COVID infection. So these are actually are complementary, and together they were forming about 1/3 of the people. And mistrust in authority. This lack of trust is a consistent issue across the world. The more evolved is the society, in fact, it may look counterintuitive. Mistrust in the health system and the governance is higher in high-income countries. So just you look at the reverse, and then vaccine acceptance is acceptable. So I would basically draw your attention that majority of the time in India, whatever reports are available, people are not able to explain why they don't want to have the vaccine. But the important, they say, डर लगता है. किस चीज का डर लगता है? They are not able to articulate. So there's this persistent and deep-rooted feeling of fear of unknown. But this is also in a very small proportion, particularly those who have additional comorbidities. Again, we see another study from India which shows that 85% were ready to get vaccinated. Another issue was that a large proportion are ready to pay also. And and you must know that initially when government had allowed the private sector to charge and with some flexibility, the private sector was able to deliver almost 15 or 17% of the vaccine. But as soon as the guidelines became strict, today they are delivering only 5-6% because the free vaccine is available at most places without difficulty. And this fear of side effect, authenticity, trust, and significantly associated with age. This is important in a sense that some of the people who are, as they grow up, the confidence in the vaccine, and probably it is related to their presence of comorbidities. Sources of information to make the decision about vaccination is also important. And reliable sources are always appreciated. Reliable means health professional, government sources, documents, or similarly, if there are kind of interaction between people who are in the know of things. So credibility of the individual was an important component and is an important component. Social media, yes, but over the time, something interesting has happened. And because this in India, the social media scanning is going on, it appears that the reliance on critical issues on social media is gradually declining. People have started understanding the fake dimension, the rumor dimension, the misinformation dimension of social media is being now better perceived, although not completely, but these are positive trends. Simultaneously, I'm sure you are aware that social media now automatically, particularly Facebook has done, they remove the post which are likely to be blatantly wrong, spread wrong information. They are either put under, there is a red flag put on the post, or they are removed. And here it is again important that we should be looking at the component, and which is very important. One is that people who are at well placed, if they are getting vaccinated, the others follow them. But the role of medical professionals is very important. We have seen how initial 4 to 6 weeks, when medical professionals were showing reluctance, and most of them did not have a specific reason. It was again there was an old movie called Bobby, and there was a song Pehle Tum, and the same philosophy came up during the early part of this year when immunization was being offered first to the frontline workers and the health professionals. They would wait others to take the vaccine before they would accept. So this whole issue of going in for vaccine is multidimensional, and just a single talking in a unidirectional manner or in a focused manner is not going to help. Several factors work together. So a conceptual mode has also been published. This, I thought you can look at the this reference. This is an Indian reference. Some of you guys, if you are working on vaccine hesitancy, you would like to understand it as a starting point, you can use it. But rather than, I would strongly suggest that rather than being in a as a deductive manner, you should look at this but develop your own models, or what we call as inductive model making. Now, I want to give you an example how adult vaccine hesitancy can kill a program, and particularly if the program is not ready to take care of that. And this is a study from the background and the context is India itself. So if some of you remember, in 2009-10, H1N1 pandemic occurred, and then subsequently in, I think, 15-16, the swine flu epidemic occurred. And there are a lot of issues around that within Indian context. And the major focus of this vaccine hesitancy has been the health providers. So community, particularly the medical community, the whole issue became so complicated that ASHAs, ANMs, doctors refused. In fact, India imported 1 million doses, 10 lakh doses. Only 1 lakh or so could be used. Then Serum Institute manufactured another 1 million doses, 10 lakhs. They could use only 2 lakh doses. And then remaining 8 lakhs also had to be destroyed. ASHAs, ANMs, and doctors in Karnataka and Maharashtra, where the maximum impact of the epidemic was, were refusing to use any kind of vaccine because the word spread that it causes more damage than any benefit. And at that time, the country and the social mobilization machinery of the country were not experienced enough to handle this vaccine hesitancy. So this is just.
Sir, we have 5 more minutes, sir, to end.
I will finish in another 5 minutes. Yes.
Sir, thank you, sir.
So the community awareness and the issue that the particular disease is, how dangerous it can be, usually determines the acceptance of vaccine in adults. Uptake of influenza vaccination, again, it is part of the program in Maharashtra, but there is poor uptake. And the important point which has emerged is that if the doctor advised, if the gynecologist advised, the women were ready to take. But if somebody else advised, they were not. And that issue of the credibility of prescriber or advisor is very important. And again, given a choice, this is a more recent study published in 2021, which shows that even in pregnant women, India is among the foremost countries where acceptance to vaccine is very high, provided it is given from a credible source. And this is what has happened in India. This is a global effect, that vaccine, there has been initial few weeks and months where vaccination acceptance declined, and then now it has picked up. And initial period, there were vaccine hesitancy. This is a global data, but I would say that our vaccine uptake started in May, much higher. There were issues of vaccine hesitancy till that time. So in conclusion, that multiple surveys have demonstrated an overall positive sentiment towards vaccination. The sentiments have to be addressed in the context in which individuals are staying: geographical, socio-demographic, vaccine-specific issues, trust, supply side. And this COVID pandemic has to be seen that it's a unique opportunity to strengthen health system and develop a mandate for adult immunization. What has been done is that a social mobilization campaign was prepared on right in September, October 2020 in the country. And proactively, the issues of vaccine hesitancy were addressed. And this whole campaign has been built on the experience of last 2 decades of experience from polio and routine immunization. A multidimensional approach has been taken, and social media scanning and tracking has been started much earlier. And debunking, demystifying issues is a very specific and targeted approach. So one does not allow the problem to escalate. And integrated technology savvy and responsive program has been built as part of the continuum of care. And initially, a lot of people were really worried about acceptance of the vaccine in rural area. But fortunately, today, almost 2/3 of the vaccine doses every day are given in rural area as well as remote areas. So what is the way forward? The way forward is that there cannot be any complacency. The way program is taking proactively, working before the problem occurs, a response has to be prepared. Otherwise, savdhani hati, durghatana ghati. There can be resistance. And as we are moving, because as of today, about 70% of adult population have received at least 1 dose. So as we will move further, we may have difficulty. And this sustained vigilance is possible if we keep our ears on the ground, keep an eye on every person, and with an open mind and heart, we look at the larger picture to see if there is something going wrong, we take a proactive action. Thank you very much for the opportunity.
Thank you so much, sir. It was really wonderful to get that perspective of why some people take vaccine. And this vaccine hesitancy concept is not at all very local. It is throughout various parts of this country and also across borders. So interesting, and thank you, Dr. Madhu, for giving that insight about adult vaccination and what diseases to target. Sir, in the interest of time, we will not take any questions right now. We'll move into the next session. But I know that the two of you, in fact, Dr. Rakesh, also three of you were such eminent speakers in the field of immunization and vaccination. And we are very thankful to three of you for joining us and address our delegates. We are very, very grateful to you. Thank you, sir. Thank you so much.
Thank you. Thank you so much.
So that concludes the plenary 9 on immunization to targeting adults. Now we move on to the plenary 11, that is on cancer control towards impact. So in this plenary, may I request, yes, Dr. Cherian, thank you, and Dr. Prashant to switch on your video, please. And all the speakers and panelists, like if they have joined, Dr. Atul, I can see is joined, Dr. Gayatri. I saw she joined some time back. Yes, so nice to see Dr. Gayatri followed after a long period of time. And I don't see Dr. Shalini joining there, but we'll wait and see. So this panel on cancer control towards impact is a very interesting and very important panel for this forum, where about 1,500 public health delegates have registered for this, and we need to build capacity and educate and sensitize our young public health mind that cancer is a problem and all of us should work together for its prevention. And the most important thing before we start working on a particular area is to realize that it's a problem and something can be done out of it. So I still remember Dr. Cherian's talk that the journey of 1,000 miles starts with a single step. So probably this is the step that we have started taking in the field of cancer control by providing a platform in the national conference. Every time we should have this type of session for our young minds so that they are sensitized to this. So without any further delay, let me introduce Dr. Cherian. Sir is the first chairperson of this particular plenary. Can I have Sir's CV, please? It's a pleasure always to work with Dr. Cherian. So much to learn from a man with such varied experience on NCDs, and it's not NCD alone. Whenever you talk to Sir, he gives you, he throws challenges at you, and you try to take up those challenges and try to do something about that. And this, thank you so much, sir, for all those guidance, all those support that you have extended in my career, and in particular to the Iphacon. A lot of discussion has happened with you. Probably you are the faculty who have contributed more in the conceptual stage and also in the implementation stage. And now here you are in the as a chairperson of a session. I don't think that Dr. Cherian Varghese needs introduction to this forum, but to complete the formalities, let me introduce Dr. Cherian Varghese, coordinator for management of NCD in World Health Organization, WHO member since 2001 at country level, regional and global level. I had the good fortune of working with Sir for 2 years in WHO country office from 2000. During that period of 2008, he has got PhD in cancer epidemiology, key role in clinical oncology and epidemiology in India, cancer research in UK, 70 articles in the field of NCDs. But this is a very modest introduction to sir. I know sir has got many more things to offer. If you Google his name, you will find so many publications and so many contributions, so many papers, reports, and guidelines to his credit. Over to you, sir. Thank you so much for joining us from Geneva, and thank you so much. Over to you. Now the floor is yours, sir.
Thank you, Siddhanshu, and congratulations to the IPHA organizers for taking cancer control as one of the themes. As Siddhanshu mentioned, as populations age, as our communicable diseases go down, we are in that classical epidemiological transition. In fact, I was just part of a paper which just published in Cancer Reviews with IARC, where we looked at the leading mortality in 20 high-income countries where cancer is the top cause of mortality now, not cardiovascular disease anymore, which means that this is the shape of things to come. Middle income countries will follow suit, and then low income countries. So we have to be prepared. So with that, I think I'm very pleased to have Dr. Prashant Ganeshan, Head of Medical Oncology, CHIPMAR, who is actually a leading figure in India in cancer, who is co-chairing with me today. So without much ado, as we are running a bit late, I would like to introduce Dr. Ganeshan and may request him to speak. He's the additional professor of medical oncology in JIPMER. He was the best DM student, which always excites me as an academician. I'm very pleased to see how people have excelled in many of these areas, including developing guidelines and all related areas. So maybe I'll request Dr. Ganeshan to give his remarks first. Dr. Ganeshan, you have the screen, as we say. Thank you.
Thank you very much, Dr. Chirian. It's a pleasure and it's an honor to be in such an elite company. Thank you very much, sir, for your kind introduction. I must also thank Dr. Siddhanshu for giving me an opportunity to be part of this group. I'm not primarily an epidemiologist, purely a clinician. Of course, we're all interested to know what is happening in the field of NCD prevention and cancer control, because ultimately it affects all of us. And as Dr. Chirian mentioned, we are entering an era where we're going to see more and more cancer patients, and the population is getting older. And so these are all challenges which is going to affect all of us at some point in time. Coming to my talk today. So my brief is to cover the advances in cancer management. So purely from a clinical perspective, I'm not going to spend a lot of time on this. I'm just going to highlight what has been brewing in the field of cancer management, just to give you a kind of snapshot on what's been going on in this area, so that you know where we are headed in terms of cancer treatment. So as you all know, conventional therapy of cancer, the local forms of therapy and the systemic therapy, which is primarily chemotherapy. In local treatment of tumors, we use surgery or radiation to burn these tumors. So there is advances in these fields too, but what has been remarkable in the last couple of decades is what has happened in the fields of systemic therapy of cancer. So we have targeted therapy, immunotherapy, and now we have cellular therapy, where we kind of modulate, genetically adjust the immune cells and make them hit the cancer cells. So coming to the targeted therapy, which probably took off sometime in early 2000, and one of the what do you call as the picture boy of cancer targeted therapy was this molecule called imatinib, which was a treatment for chronic myeloid leukemia. So at that time, in 2000, when imatinib was introduced, chronic myeloid leukemia had a median survival of 3 to 5 years, and most patients were dead by 5 years. So this molecule was really a game changer. It targeted a protein called BCR-ABL, which is known to be activated in patients with chronic myeloid leukemia. So in a sense, this was a very scientifically designed and developed molecule. And it had a huge impact, because since that time it was launched in 2000, 2001, even now we have patients been taking it for the last 20 years. And this has really achieved what was originally a pipe dream of converting cancer into something like a chronic disease. So this really excited people, and then from that point, the real the science and the implementation of this targeted therapy took off. Coming to something more difficult to treat than chronic myeloid leukemia, but much more common. In fact, the commonest cancer in males across the world and also in India is the non-small cell lung cancer. So, and fortunately for non-small cell lung cancer, almost 70 to 80% of our patients present with really advanced stage where neither surgery or radiation is feasible. So what did we do 2 or 3 decades before? The only treatment that was available was some kind of a cytotoxic chemotherapy. And unfortunately, all this did was give 3 to 4 months of advantage over not doing anything. And it was almost unheard of for a patient with advanced small cell lung cancer to live beyond 2 years. And of course, these treatments came with high toxicity, neutropenia, fever, infection, nausea, vomiting, a lot of quality of life issues for an improvement in survival by probably a few weeks. If you see the x-axis of these curves here, these are usually in terms of weeks at that point of time. What changed was the coming up of, the coming of age, I should say, of molecular biology. So as people knew how to understand the genetic makeup of cancers, as the whole genome was sequenced in early 2000, and the cancer genomes were one of the first ones to be targeted for entire genome sequencing. We understood all these genes which are mutated in cancers, how they're different from normal genes, and in each individual cancer, which are the genes which are activated. And then you found out the proteins which come out of this, and then you start developing molecules to target these various proteins. So this is showing a cartoon of the various genes which could be mutated in lung cancer. So it's very exciting because you understand all these things, but at the same time, it's quite humbling because you understand that cancer is not, it's not like a, single gene disease like chronic myeloid leukemia. In a single cell, actually, you could have a bunch of these interacting with each other. It's really a very complex process, but it does still afford us some targets to hit it. So what happened was that non-small cell lung cancer, which was a single disease in probably 1980s, later you knew with a lot of immunohistochemistry and things like that, you could understand there is small cells, there is squamous, there is adenocarcinoma. But what happened with the genomics is that adenocarcinoma is not one disease. You have ALK positive, you have EGFR positive, you have PIK3CA mutated one, you have RAS mutated, a whole bunch of non-small cell lung cancers are there. And now we are also learning to treat each of these differently. And as you can see, this cartoon shows the various drugs which are available to target each of these mutations in lung cancer. So the whole complexity has increased a lot, but at the same time, it has improved the survival of patients. So this is something which we have to accept, that this has indeed made an impact in the treatment of the patients. It's not just something of a genetic curiosity. So this is showing a simple EGFR targeted drug that is erlotinib. When you compare to what we used to use before, that is just chemotherapy in EGFR mutated lung cancer. So again, these targeted therapies don't work for all the lung cancer. So you have to pick out those who have a target available or the EGFR mutation available. What you can see here, when you treat them, the survival really improves. So you can see that from weeks, now we are talking in terms of months. Similar Kaplan-Meier curve here showing something called
Prashant sir?
Yes.
Sorry to interrupt you, but I believe that your screen sharing has not been enabled.
Okay, so you could not see my screen still. I'm really sorry.
No, not so far.
Now you can see?
Yes.
So what I'm showing here, okay, I'm really sorry about that. So what you can see here is this cartoon on the survival in non-small cell lung cancer with the use of targeted drugs. So quizartinib is another example of a targeted drug. This is again improved the survival from weeks to months. What is the very new kid on the block is this immune therapy of cancers. So we traditionally knew that the immune system does try its best to fight off cancer cells because they look different from the normal cell to some extent. But the cancer cell is quite smart, and it has its own way of blocking the immune responses. So these blocks are called the checkpoints, which are developed by the cancers, and the various molecules which have been identified to be involved with this. One of them is this molecule called the PD-1 and the PD-L1 interaction. So these tumor cells will express these proteins called the PD-1, and they will block the immune responses and prevent the immune system from eating up the cancer cells. As simple as that. So what technology has enabled us to do is to develop antibodies which will block either the PD-1 or the PD ligand on the effector immunity cells. And these molecules are called checkpoint inhibitors. And what they have achieved is quite dramatic in the last 1 decade or so. So some of these cancers, when you don't have mutations, when you don't have targets, I told you lung cancer had a median survival of about a year at the best. What it has done is to push up the survival of these cancers by almost like 3 times or 4 times. Now you're talking in terms of years. So this is metastatic lung cancer. And you can see at the end of 4 years, if almost like nearly 50% of the patients are still alive in this trial. So this is quite dramatic. So what was unheard that people will survive beyond 2 years, as now like almost half of them can expect to survive 3 to 4 years with advanced lung cancer. So the impact has been significant. And of course, the burgeoning number of molecules which are approved in the last decade tells you that this is a field which is a really, really exciting field. The number of molecules are increasing day by day. So I just showed you an example of lung cancer, that you can pick any cancer and the impact has been there. Some of them more, some of them less, but in every cancer, we are now seeing the impact of either targeted treatments or immune therapies. And some of them you are improving the cure percentages, and some of them you are increasing the median survival. So the impact is there everywhere. However, there is a caveat to this. What has now happened is that now when we treat cancer, each disease is now multiple diseases. So previously we had lung cancer or breast cancer. Now we have this type of lung cancer, this type of breast cancer, 100 types of lymphomas if you go by the latest WHO classification, like 15, 20 different types of lung cancers. So it is quite complex. It's becoming more and more difficult for a single oncologist or a single small unit to really treat these tumors effectively. More investigations, more complex investigations, you're becoming hugely dependent on very complex labs. Of course, the cost is bound to go up. And of course, the cost of treatment with all these fancy drugs is extremely, extremely high. And it's becoming more and more challenging to do certain types of research, especially in terms of the outcome with whatever therapies that we are giving, especially in low-income countries or middle-income countries, because what we do now is not standard of care after 2 years. So to keep up with the research is another huge challenge. So who benefits from all these advances? I'm just trying to put together, this is my own perspective, this is not from any literature, from what I have treated in the last 15 years or so that I've been in the field. So what used to cost about 5,000 rupees for the workup of a patient with a newly diagnosed myeloma, you can easily spend about 50,000 rupees now on a standard workup. I won't even call these are fancy tests, just to identify where these patients fit in terms of the whole host of drugs available. Just to understand that, you'll have to spend nearly 50,000 rupees. And the cost of therapy for the first 2 years, if you want to use the best possible treatments for these patients, these kind of immunotherapies, it can put you back by 35 lakhs or 50 lakhs of some of these newer fancy molecules, which was, what we used to do in the early part of 2005, 2010. It was in probably in few tens of thousands of rupees, runs into many lakhs. Has it improved the survival? Yes, it has. It has been quite significant in some of these cancers. I'm showing very extreme examples, but yes, it has improved. But as I said, there is a price to pay. Not all these patients benefit, so you need to identify the right patient. So the impact is there, but it is there for some of them. And the challenge of getting all these drugs. In a setup like Egyptmore, where we predominantly cater to extremely poor people in the society, I would have probably used immune therapies to less than 1% of the patients that I'm treating. So is it really getting to all the people at this point of time? Where do you place all these things in a country like India? This is a really big challenge, and these are questions that we need to answer in the coming years. This is an important and vital area for research. The utility of these newer treatments, at what price point do we really consider them useful for India? We need to really work on these things. Of course, the challenges of the patients are only mounting. in terms of the travel costs, the treatment costs, of course, the lost wages, the home care, other. So these are all the additional burden of the treatment and then the palliation. So it's not getting easier for the patients or the, physicians in a sense. But at the same time, yes, you have to ask.
If you could just wind it up in
Yeah,
another.
right. Yeah, a minute over. Yeah. So this is where we are. Even in the Western countries, this is a very expensive business at this point in time. So let me just wind up. So there is a huge strides in cancer research. We have understood the biology, the newer drugs, but it has led to significant gains in survival for a proportion of patients. But we really need to work on the public health impact and the cost. That's what I would leave in terms of the advances in cancer treatment at this point of time. Thank you very much once more, Dr. Sudhanshu and the entire team from IPHA for giving me this opportunity. Thank you.
Thank you, Dr. Ganeshan, for bringing out those interesting developments, which I think in the last few years have changed the landscape. I will briefly take you through a comprehensive cancer control program, the rationale, elements, and desired outcomes. But we have three eminent speakers to cover the cancer continuum from prevention, screening, right up to palliative care, and you have just now heard the treatment part. So that in a way covers the cancer control continuum. There are a lot of challenges in cancer control, as now, at least, as Dr. Ganeshan said, it is going to be a disease which is like any other disease that you take treatment, you're fine with it. But that was not the case, and that is not the case in many parts of the world, and including in rural areas in our country, where cancer is still equated to death, including in Bollywood movies. If somebody has to be removed, they will be shown as having some cancer. We have to have very effective treatment. Many of these effectives that Dr. Ganeshan has said has to become accessible, affordable, and available to the people who need it most. And then the expense has to be considered. Specialization is needed, as he has said, in many areas. And the real burden of cancer, Atul will tell you how it is changing now. So just to sort of give you the context, we have 1.3 million cancers expected, and 64% of them are dying. That is not good news, but the good news is that tobacco-related cancers still contribute almost 1/3. So there is a huge potential for prevention, even without any of the gene therapy. You can actually have good policies, reduce 1/3 of cancers, because tobacco is responsible for almost 1/3 of cancers in India. Breast and cervical cancers contribute to about 15%. Out of that, cervical cancer is about 5%, which can be prevented by HPV vaccines. And then about 20% of cancer. So almost half the cancers are actually very much in the scope of IPHA, if I want to put it that way, in terms of prevention. So what is needed is a national cancer control plan, because no country will have enough money to do everything in cancer. So in simple words, it is to do more with less, or it is actually to optimize what we have. And as we heard, it needs the full care continuum of prevention, screening, early diagnosis, treatment, palliative care, and survivorship care within the context of the health system in the country. There is no doubt that tobacco is the most important prevention element to be looked at. Alcohol is increasing, obesity is increasing, which will lead to high incidence of colon cancer and breast cancer, as we know from high-income countries. Infection-related cancers are still high in India, like HPV, hepatitis B, and H. pylori. So we have another window of opportunity there. Environmental risk factors, we have to seriously look at that. So what do we need? Policies, legislation, regulation, and taxation, which I would think should be the new mantra of public health, which is different from awareness, participation. They are needed. They are the enablers for making policies, legislation, regulation, and taxation happen. Screening is one of the most misunderstood terms, because people usually don't look at the millions of people to be screened to get cancers diagnosed. And sometimes even good early diagnosis program, this simple slide on the right side, on the right panel shows that from 1950 to 1980 almost, the reduction in breast cancer mortality has been substantial in the US, just because of early diagnosis and improvement in diagnosis and treatment without delay. After introduction of mammography screening and adjuvant therapy, the reduction has not been that dramatic. And also there's a big difference between screening asymptomatic people and looking at people with signs and symptoms, which should be known as early diagnosis. The population-based screening program of India, the coverage as shown in this picture is extremely low. NFHS 5 shows that the ever undergone screening is only less than 10% in all these cancers. That means which we really need to sort of relook at the whole thing. Again, this is a classic diagram, which is to say that if you start with about 1 million people, million women, you will only end up with 200, 300 cancers. But the health system has to look after the remaining people with whatever that is needed. And that is a huge ask, which is not easy. And again, even in the best of countries, you look at this is cervical cancer screening in England. From 1971 to 1987, the coverage was not good. It was about 30-40%. Ours is less than 10%, keep in mind. And with 30 to 40% coverage, the incidence of cervical cancer was hovering around 16 per 100,000. In 1987, they improved the coverage massively to 90%, and look at how the incidence has gone down. So there's a lot of work that needs to be done when we talk about screening. This is the same example from Finland, which is over 60 years of experience now. And finally, this has been very clearly shown that early stage is the most important thing. And delay is death. It is not cancer alone which is causing death, because this is the average journey. I was thinking of a person who gets suspicious symptoms of cancer going to different places. So some sort of a structured cancer continuum is important. Management of cancer needs all these key elements, especially financial protection and social and family support, which I think in the rural parts of India is still far from satisfactory. Gayatri will talk us through the palliative care, which is actually a human right. I think no person should die with severe pain and cancer. And again, that will be explained in detail. How do we know things work? First of all, we have to see cancers in early stages. The tobacco-related cancers should have a shifting pattern, augmentation in diagnostic and therapeutic facilities. There can be indicators for prevention, for early detection, but finally, one has to ensure we developed the cancer control strategy for Kerala, where we actually decided with the government. The government is now implementing this at each level, right from PHC to Taluk headquarters hospital to district hospital to oncology unit in medical college to comprehensive cancer center. What are the elements of cancer services that are needed for the population, and how these places have to be equipped with equipment and personnel for that? So cancer control is a journey. We have to set priorities. We have to choose wisely when we set priorities. It has to be informed by science, adequate human resources, good registry programs. And it's a long road, it's a tough road, but it is worth going. And we will hear from the panelists today on that. So I'll stop sharing my screen and maybe call on Atul. Dr. Atul Buduk is the professor of Center for Cancer Epidemiology at Tata Memorial Hospital. Do we have the CV of Atul? Yes. I think Atul is giving the, okay, Atul, yes. He's the professor of at ACTREC. He was my my colleague and student also. No, not my student, actually. He was doing PhD at the same time I was doing PhD in Finland. I was so impressed with the way Atul has expanded cancer registries in India. So there is no better way than to listen to Atul. So maybe over to Atul's presentation. Stuti, can you play that, please?
Yes.
Good afternoon. I'm myself Dr. Atul Buduk. I'm working as a professor in epidemiology at Center for Cancer Epidemiology, Tata Memorial Center, Mumbai. In today's virtual national conference of Indian Public Health Association 2021, I'm going to present the topic, population-based cancer registry, what is the current status? Cancer registries are the central nervous system, the eyes and ears of cancer control. What is cancer registry? Cancer registries have been defined as organized system for the collection of storage, analysis, and interpretation of data on person with cancer, usually covering a hospital or a population from a defined geographical area. Indian Cancer Society Mumbai has established the first cancer registry in the country in 1963, and which is the second in Asia. And from 1963, Mumbai Cancer Registry provides the incidence rate, mortality, trends, and different research papers. And it is going on, is more than 50 years old cancer registry. This is the first cancer registry in India. The National Cancer Registry Program, Indian Council of Medical Research, with the help of different regional cancer centers, has started 36 population-based cancer registries, and there are 236 hospital-based cancer registries. The National Cancer Registry Program, Indian Council of Medical Research, regularly publish the reports of the cancer registry. A Tata Memorial Center, Mumbai, has started the 10 population-based cancer registry. So there are 4 hospital-based cancer registry and 5 special purpose cancer registry. Government of India has asked us to establish different cancer centers at different places in Punjab, Visakhapatnam, in Bihar, and in Sangrur in Punjab state. So before starting the hospital, we start the population-based cancer registry, and we have also special purpose cancer registry. And the Cancer Institute Chennai, Tamil Nadu, they have entire population-based cancer registry covering the Tamil Nadu state. So near about less than 15% population has been covered under the population-based cancer registry. These are the different population-based cancer registry existing in the country, and it represents the almost all over India. Only few states doesn't have the cancer registry. So North India, the registries like Varanasi, Muzaffarpur, Punjab, they are covering 28 million population. South India, including Tamil Nadu, there is a registry in Bangalore, Trivandrum, and this South Indian registry has covered 95 million population. East India, 9.3 million population. Calcutta has good PBCR. West India, the Mumbai, Pune, Aurangabad, Barshi has 30 million population. Bhopal and other registries has covered 6 million population. Northeast India, the Mizoram, Kamrup has covered 13 million population. It's a good representation of the population has been covered under the population-based cancer. What are the leading cancer sites in different parts of India? In male in North India, lung, mouth, prostate is the predominant sites. In South India, lung, prostate, mouth. East India, lung, prostate, mouths, they are the leading sites. West India, mouth, tongue, and esophagus. Central India, mouth, lung, esophagus. And North India, esophagus, stomach, and lung. So you can observe the lung and mouth cancer is very common. Esophagus is also common. And it is tobacco-related cancers. Leading cancer sites in female, you can see all the places. Breast is the leading site. Breast, cervix, these are the leading sites in females. And you can see in Northeast India, the stomach cancer seems to be in the predominant site, but breast is very common in all over India. Breast cancer is predominant, followed by cervix cancer. And in North India, you can see the gallbladder cancer is very common in North India, that is Ganga belt. So there are need of population-based cancer registry in several parts of the India, that is particularly Jammu and Kashmir, Himachal Pradesh, Uttarakhand, Haryana, Rajasthan, Chhattisgarh, Orissa, Jharkhand. There is need of population-based cancer registry in this state. As per the National Cancer Registry Program, Globocan, and several cancer registries under TMC, this is the all-site cancer burden published by regular reports by NCRP as well as Tata Memorial Center. And what we observe, the India rate is by Globocan is around 96 per 100,000, and you can see the rural rates are lower as compared to urban rates. These are all-site male. The Northeast registry has highest rate, 269 per 100,000, and the Barshi rural and Usmanabad Bid rural has the lowest rate. For female, it is similar. The female rate is around 100 per 100,000 in India. And we see the rural rate, it is low, around 50 per 100,000, but all the urban registries rates are high. Similarly, like male in female, Northeast India is showing highest incidence. These are the Globocan rates estimated based on the cancer registry data. Globocan is a software which produces regularly the burden of cancer all over the country. Almost all countries projection has been given in this Globocan software. How this projection has been made? The cancer registry submit data to IRC, and based on the population sample, the IRC estimate the global burden and as well as burden of specific country. So population in India, we cover 138 crores in 2020, and the leading cancer sites in male is lip, oral cavity, lung, stomach, colorectal, esophagus, and overall around 650,000 cases in a year. And in female, breast, cervix, ovary, lip, oral cavity, colorectums are the predominant cancer site. And all site females is around 680,000, and the rate is around 100 per 100,000. And this is the graphical presentation, and you can see the breast cancer is coming up very high. Breast cancer is coming up very high, followed by cervix utera. But you can see in male, lip, oral cavity, followed by lung is the leading site. How cancer registries plays important role in cancer control. See, population-based cancer registry data will be utilized to know the burden of cancer and pattern in the specific region. See, before starting a NCRP program, only Bombay registry was representing the entire country, and we didn't know what is the rate in rural area. So Barshi registry started in 1987, and first time we got to know the rural rates are lower than the urban rates, and the pattern is completely different in different parts of India. So that is the output given by the population-based cancer registry. There are several hospital-based cancer registries. They have been used for the administrative purpose. Also, several case control study has been conducted using the hospital-based cancer registry data. And the PBCR is useful to know whether cancer is increasing or not. Really, now you can see the NCRP report and the several publications. We can see the breast cancer is increasing, cervix cancer is going down, prostate cancer is also increasing. And these types of information we'll get to know from the population-based cancer registry, because every year they publish the total cancer rate, incidence rate, mortality rate, as well as the site-specific incidence and mortality. The fourth is cancer registration is the way to develop the infrastructure. Because what are the cancer registries in the urban population? They are the byproduct of the available infrastructure, like Mumbai, Bangalore, Chennai. Infrastructure is already available, and we just collect the data. But if you establish a registry where the infrastructure is not available, we can submit the report to the government that most of the cancer patients travel outside the state or neighboring districts, and there is a need of cancer center here. Like in Sangrur, Punjab, we started the registry in 2013, and there was almost all the patients traveled to nearby center called Bikaner or the nearby district Patiala or Bhatindia, and we recommended the government, the local minister, that there is need of cancer center, and government of Punjab has agreed to provide the facility for the infrastructure, and the cancer center has been established. This is how the cancer registry is the way to develop the infrastructure. And the fifth important point is the cancer registry provides you the survival data. The survivalist shows the effect of cancer care services in the population. How many patients are surviving? Is 30% people are surviving? 50% people are surviving? Whether the treatment facility is good? Whether people are taking the treatment? So it gives you the effect of cancer care services in the population. And the important role cancer registry plays is it monitors the cancer screening program. There are several publications from cancer registries from India. Several research articles on cancer burden, pattern, trend, survival are published from the registry data. So cancer statistics, the National Cancer Registry Program has published this very good, interesting paper, Cancer Statistics 2020, report from National Cancer Registry Program in India. And Mumbai Cancer Registry regularly publish the trends and prediction of cancer incidence cases. IRC has requested all the cancer registry to submit the data to their survival analysis paper. Several cancer registries from India has submitted data to IRC, and this is very good publications by IRC and Indian scientists. There is a good article on the cancer registry that registries are not only a tool for data collection, they are for actions. This is a fantastic paper published by Amiya Bhatia from Harvard School, Public Health School in International Journal of Cancer. So cancer registry has played important role in monitoring the randomized control trial of cervix, breast and oral cancers. As you know, India has published very good results on the randomized control trial of cervix, that is whether visual examination of acetic acid is useful, clinical breast examination is useful, which test is better for diagnosing the cervix cancer and precancerous lesion like VIA, HPV or cytology, as well as the Trivandrum group has published the data on how oral visual examination is effective in preventing the oral cancer deaths. And all this randomized control trial, more than 5 lakhs people has been participated, and all the results has been published in good journal, and it has shown that VIA is very effective, HPV test is very effective, clinical breast examination above age of 50 is very effective, and oral visual examination is very effective. But in this randomized control screening trial, the population-based cancer registry has provided incidence and mortality data to this trial. Like Trivandrum PBCR has provided data on oral cancer to this trial. The Individual Cancer Registry has provided cervix cancer data, incidence and mortality. Barchi Registry has provided data on cervix cancer incidence and mortality for the Osmanabad randomized control trial. The Mumbai Cancer Registry data was taken to match the cancer incidence and mortality cases of cervix and breast cancer. So Cancer Registry has played an important role in screening program. So what are the challenges faced by the Cancer Registry? The main challenge is the lack of trained human resources, non-cooperation from the leading cancer centers, hospital. Most of the private hospitals, including the government centers, also refuse to share the data to the Cancer Registry. They put a lot of hurdles. Poorly maintained medical records in all the government hospitals. Inadequate death registration system. Death records are not properly collected. No cause of death has been mentioned. There are funding issues to the Cancer Registry and staff sustainability. Who can start the Cancer Registry? Cancer Registry is required, is an important public health program. And who can start the Cancer Registry? Government medical colleges, cancer center can start the Cancer Registry. The pathologist, leading consultant can lead the registry. A population covered should be maximum 2 million. Registry should be established at the cancer center. Approximately the budget is 25 lakhs per annum have to be allocated to run the Cancer Registry. And Cancer Registry training is available at Tata Center through the IRC Regional Hub, Mumbai. And we provide training. We also provide technical support in Canrage 5, and it is totally free. We don't charge anything. And we help in continuous monitoring the registry data quality control. We assist them in preparation of the Cancer Registry report. We have supporting Indian registry as well as the neighboring country also approached to us to support the Cancer Registry. There are useful resources, and the researcher, the public health researchers can regularly follow these resources. The National Cancer Registry Program website regularly publish the report on population-based cancer registry as well as on the hospital-based cancer registry. The Tata Center, we regularly publish the cancer registry reports of the cancer incidence in 5 continents. International Agency for Research on Cancer regularly publish every 5 years the cancer incidence in 5 continents. The Indian registry data regularly they publish in this volume. What is the message from my lecture is these cancer registries are the foundation of cancer control program, and it is required to monitor the cancer control activity. I am grateful to all the organizers of the Indian Public Health Association meeting, virtual meeting 2021. I am thankful to Dr. Cherin Varghese for inviting me in this meeting to give the lecture. on the cancer registration in India. Thank you very much. Happy to take your questions. Thank you.
Thank you, Professor Buduk. I think that is a well explained presentation covering every aspect of a cancer registry, from how to set it up, what are the types of registries, and what do we get out of that. And I'm impressed by the number of cancer registries that have come up in India, because India being so heterogeneous, we need local data. So in the interest of time, we will continue with the presentations, and I'm very pleased to have the next presentation by Dr. Shalini Singh. Dr. Shalini Singh is the director of the National Institute of Cancer Prevention and Research of the Indian Council of Medical Research in New Delhi. So maybe Stuti, we can, the center is also the WHO Global Knowledge Hub on smokeless tobacco. Dr. Singh has done extensive work in cancer prevention with good publications, as you know. So maybe without much ado, maybe we'll just get into the presentation, which I believe is recorded. So Stuti, can you please play that? Thank you.
Yes, sir. We'll now move on to the next presentation by Dr. Shalini.
Greetings from the National Institute of Cancer Prevention and Research, Noida. I've been asked to speak on the current status and challenges of screening for oral, breast, and cervical cancer in India. As we all know that cancer is an important public health threat to the country, with nearly 8 to 9 lakh cases of cancer occurring every year. And at any given point in time, there are more than 27 lakh cases of cancer. The oral and lung cancers in the males and the cervical and the breast cancers in females account for more than 50% of the cancer deaths in the country. And nearly 40% of the cancers in the country are related to tobacco use. The country established the National Cancer Control Program in the year 1975, but at that point, the focus was on equipping premier cancer institutes and hospitals with machines for treatment of cancer, like the cobalt machines. In 1984, stress was laid on primary prevention and early detection, and only in the 1990s, the District Cancer Control Program was started in some districts, and these focused on the primary prevention, secondary prevention, as well as tertiary prevention. It's only in the year 2010, the combined approach for NCTs as well as cancers was launched as a national program called the NPCDCS program. It's very important to understand what is screening in a cancer program. Screening is defined as a systematic application of a test or an inquiry to identify individuals at sufficient risk of a specific disorder, in this case cancer, to warrant further investigation or direct preventive action among persons who have not sought medical attention for that disorder. So screening should be done in healthy, at-risk individuals to detect early signs and symptoms of cancer or precancerous condition. And it should always be linked to effective treatment for having a successful screening program. The screening uptake refers to the proportion of persons eligible to be screened within a population who have both been invited for screening and who have received an adequate screening during a specified period. In 2016, the government launched this operational framework for management of common cancers. And the document specifies that cancer control is a part of a comprehensive strategy for prevention and control of NCTs, and also population-level health promotion and disease prevention. It also emphasizes that the providers need to be sensitized at every level on the necessity of screening for cancers opportunistically, and also the importance of regular follow-up, both at the facility level and the community level, must be emphasized. The different methods and the follow-up strategy in the program has been shown in this slide, and it indicates that once in 5 years screening is recommended for oral, cervical, and breast cancer in population aged 30 years and above and up to 65 years in case of cervical cancer. Using the oral visual examination for oral cancer, visual inspection with acetic acid for cervical cancer, and clinical breast examination for breast cancer. And in case there is something which is detected during screening, they are to be referred to a higher center. So the different kinds of human resources which are required for screening at different levels have been shown in this slide. At the PHC level, from the A&M to staff nurse to medical officer, anybody can do the screening. At the CHC level, we have the surgeon or the gynecologist or the dentist who can also be involved in the screening. And also, once screened, they should have facility for doing ultrasound or for referring for biopsy or treatment like cryotherapy and colposcopy in case of cervical lesions. At the district hospital level, there should also be a pathologist who can detect the abnormal lesions which are seen in biopsy. There should also be facility for cryotherapy, colposcopy, and LEAP for cervical cancer cases, and ultrasound for abnormalities detected in the breast. However, at the ground level, all these facilities are not available, and there's all a constant impetus to provide these facilities by the government. The study published in 2008 has analyzed the coverage of cervical cancer screening in 57 countries. And what this figure indicates is that a comparison between Brazil, China, Germany, and India for cervical cancer screening. The bars in the green show effective coverage, which means that the women have undergone pap smear within the last 3 years, but the bars with blue are indicative of crude coverage, which show that these women have undergone a pelvic examination, not necessarily screening. And what it shows is that there are a lot of inequalities, wealth-related inequalities between the women who have been given effective coverage versus crude coverage, even in the developed countries. In India, since the coverage is very low, there's not much of difference between the richest, which is 6%, and the poorest, which is 4%. So we have to go a long way. And certainly the results of the NFHS4, especially with regard to cervical cancer screening, are encouraging. And this study, which is in the age group of 30 to 49 years, based on the NFHS4 data, shows that 1 in 10 women were screened for breast cancer and 1 in 3 were screened for cervical cancer. Again, we are talking about the crude coverage because of the questions, the kind of questions that were asked in the NFHS4. And of course, this varied by the geographic region, the levels of education, the household wealth, and the place of residence. Also important was that women who were actually high risk and for cancers were not without any risk factors. So those living in poor socioeconomic condition, who were illiterate, who were contraceptive users, tobacco users, had high parity and poor dietary habits, were less likely to be screened. Cervical cancer and the breast cancer screening based on the NFHS4 data. And that screening in Kerala and parts of Maharashtra is much higher than the rest of the country. And also that screening for breast cancer as well as cervical cancer is much lower in the eastern part of the country. Now this data is from the Global Health Observatory repository of the WHO. And this indicates the coverage of National Cervical Cancer Screening Program. It indicates that in 2015, the coverage was less than 10%, but has risen to 70% or more in the year 2017. So we are keenly awaiting the results of NFHS5, which will then also shed some light on the coverage for cancer screening. NCRP data from the year 2012-2019 indicates the proportion of cases which are detected in different stages of cancer, and it indicates that we still have a very high percentage, nearly 60% of cancer which are being detected at a late stage. And here there is some scope of showing good results if cancer screening is effective. There's another study of 2010 from the Mumbai registry, which shows that nearly 70% of patients with cervical cancer are detected in stages 3 and 4, and nearly 20% of them die within the first year of diagnosis. So again, the results of cancer screening should be reflective on the stages of cancer at detection. This slide shows that there has been a significant increase in the incidence of breast cancer across all the population-based registries in India, except in Nagpur. And there has been a significant decline in the incidence rates of cervical cancer in 10 registries, but not in Dibrugarh and Pune. But this could also be a reflection of the increased coverage of screening. Same goes for head and neck cancers. Oral cancer is specifically not given in this one. What are the challenges in tests that we face during screening? We've seen that oral visual examination, VIA, and clinical breast examination all depend upon the training and the skills of the healthcare provider. And examinations such as self-breast examination have a low adherence because they are user-based. Also, what we need is that the screen positives need to be followed up or referred to a higher center for a confirmatory test by a specialist. And this results of the confirmatory test may not be available on the same day, which increases the number of visits. So screen and treat is often not possible. And also that the confirmatory tests are expensive. And then even if the confirmatory test is negative, these patients have to be under periodic follow-up. And this includes patient counseling as an important part of the screening. Also, we have to note that screen negatives have to be followed up every 5 years because of the kind of tests that we are using. And then only the detection rate will be better. There are certain challenges in the program for screening. In the health system, there's lack of awareness among the health staff themselves. They think that it is an additional burden over their routine work, and that screening tests are mostly available at higher centers. They have a high cost of running the programs, and there are implementation challenges as well. Then there's a lack of organized health system setup, and they're poorly managed referrals and follow-up. From the patient's perspective, there are a lot of psychosocial elements there. There's fear, there's hesitancy, there's stigma, there are myths related to screening, there's lack of awareness, they think that the procedure is painful, then they have lack of time, privacy is also an issue. A lot of financial constraints, and they feel that in case cancer is detected, they may not be able to take up the next step for treatment. There's sometimes lack of family support as well as also the accessibility to treatment facilities. The presence of male health workers also at times deters them to go for screening. They also at times, especially in the cases of women, they neglect their own health and also forget to follow up. This figure shows that we have a lack of healthcare workers, skilled healthcare workers in the health system, and these definitely need to be ramped up if we are to have any successful screening program. The other challenges in screening are of those of the measurement of screening. So for that, it is important that screening activity and registry should be established in a well-defined area. The age group should be included as per disease prevalence and not just convenience. And in case over time, the trends show that different age groups are involved, so screening should be extended to those age groups. or high-risk groups. There should be proper documentation of the screened population. There should be identification of performance indicators and quality indicators for screening. And also these programs should be monitored and assessed periodically. To improve the tests programs and maximize impact of screening, two important pillars are there. One is the effective education program for screening, and then second is the effective treatment availability. Besides that, we should use tests which require minimum user skills. They should be less invasive so that the beneficiaries can use them themselves, just like the HPV DNA self-sampling is going on. Then the test should not miss out on the positives. It should detect disease early on, and it should be cost effective to the governments so that they include them in the screening programs. There's also need to understand the multi-level context in which these organized screening programs are implemented, which includes the demand side and the supply side. And these are the education, the knowledge, the attitudes, and the beneficiaries should understand that these screening programs are for their benefit, and therefore they should take them up regularly and follow them up regularly. From the supply side, a lot of budget and time should be devoted to screening, because it will save them from disease which is detected in the late stage, save them from unnecessary expenditure for treating diseases which are in the late stage and actually the patient never gets cured. So there should be importance given to insurance reimbursement for screening as well. And a lot of media resources should be used to inform the public about the risk factor and the early symptoms and the importance of screening. ASHAs, ANMs, and the frontline workers should be taught and should be motivated to actually bring the at-risk individuals for screening. And they should focus on screening, especially of the high-risk groups. So this is the summary slide, which indicates that for monitoring and assessing screening programs for cancers, what are the essential components? And we've spoken about all these factors, the minimum data elements, the performance and the quality indicators, what are the contextual influences, and what are the oversight standards. So this is the summary slide. Thank you for all your attention.
Thank you very much, Dr. Singh. We started a bit late, so we have a bit more time, but as you have heard, screening is not a small thing. It is not a convenience, it's not a fashion. If a country can screen population for cancer with its impact, with the coverage of 70% or more, that means the country's health system is really, really mature, and it has taken all those considerations that Dr. Singh has just mentioned. Let me now move into the next presentation by Dr. Gayatri Palat. Dr. Gayatri has again pioneered palliative care in MNG Cancer Institute, also in Hyderabad. I have worked with Dr. Gayatri many years back in my career. She is currently a consultant and was instrumental in establishing the Department of Palliative Medicine at the MNG Institute of Oncology. Palliative care is critical. At every advancement of cancer is fine, but still people will need good quality of care, pain relief and palliative care. And there is no one better than Gayatri to speak to that. So maybe over to Gayatri. Is Gayatri going to present, or is it recordings to this? So please proceed. Thanks.
I can present, but I'm unable to share the screen. Yeah.
Yeah. If you're presenting, Gayatri, that will be good, but also keep in mind that we are a bit stretched on time. Thank you.
Yeah, so I'll keep it short. So very good evening to all of you. So very quickly moving on to palliative care spectrum of comprehensive cancer care. So whenever we talk about palliative care,
Gayatri, can you make the slides a screen show, a slide show, that so that the full slide is visible?
Is it not? I thought it's slideshow.
No, it is.
No, ma'am, not at present.
Okay. Just a minute. So while I'm trying to do this, in order to save time.
Yeah.
Yeah.
Okay, proceed anyway, proceed.
Yeah. So whenever we talk about palliative care, there are certain questions asked. What is the meaning of palliative care? What are the current status of palliative care in India? And what are the challenges in terms of service delivery in palliative care? I just want to draw on to the statistics shared by Dr. Cherian, where he spoke about the cancer figure. And I just want to highlight how, like in number of new cases, out of number of new cases, 64% are not curable, they're dying. And among those patients, when you look at the pain part of it, 55% of patients, irrespective of stage of their illnesses, they experience pain. And in the end stage advanced cancer patients, almost 2/3 of patients, they experience severe pain. Such is the prevalence of pain in patients with cancer. And that
Shalini, sorry, the slides are not moving.
Is it moving?
I'm not able to see it. Studi, are you able to see the slides?
No, ma'am. No, sir, they're not. Would you like us to check from our side?
Yes, sir, please do that.
Okay.
So, and like, I'm sorry we couldn't see the slides, but I just want to say that how cancer and pain is so synonymous. It's such a common sequence happening in patients with cancer. Yeah.
If you could just give me a minute, I'll start the sharing from my side.
Sorry. Yeah, can we go to slide number 4? Okay, maybe it's a recorded thing. Can we take away the narration part of it maybe? Or shall we just play the recorded slide? Sorry, if that is the case, please.
Ma'am, we can do it either way. If you would like us to mute the audio and just go ahead with the slide projection, we can do that as well.
Yeah.
Okay, Studi, show it as slideshow and let Gayatri speak.
Yes, sir. We are just working on that.
Yeah.
Yeah. So what I want to highlight is that how cancer brings such tremendous physical, emotional, social, and financial strain on individuals and families. Next slide. And if you look at the slide where, and when you try to define palliative care, I've taken this WHO World Health Organization definition of palliative care. Palliative care is an approach that improves the quality of life of patients and their families facing problems associated with life-threatening illnesses through prevention and relief of suffering. And when you talk about suffering, it's not just physical, but also physical, psychosocial, and spiritual. So it's all about suffering and relief of suffering. And it should be irrespective of whether the cancer patient is getting cured or not getting cured. Next slide. If you look at the global distribution, how palliative care is developed in different parts of the world, if you see the dark blue part of the map, those are the places where it is very well integrated into health system. Suppose if you have a patient who's diagnosed with cancer and he has got severe pain or some complex symptom issues, automatically he'll be referred to palliative care. So it goes hand in hand with all the curative attempts at cure towards cure of the cancer. But if you look at the map of India, it's little light blue in color, which shows that it is still very patchy. It's not very evenly distributed. Next slide. just to give a kind of an indication about how palliative care is how much it is developed in India, if you see those red dots, they just kind of indicates like where different palliative care programs are existing. And if you very noticeably, if you see, it's the clusters of red dots in the state of Kerala. In Kerala, there are decades, three or four decades of lot of effort, and which has resulted in such extensive community-based palliative care program happening in this part of the country. Often when you talk about palliative care, it's very synonymously mentioned with Kerala for this reason, and that's the reason you see so much of clusters. But of last 10 years, we have developed palliative care in other parts of the states. In many other states, it has evolved. If you look at what are the challenges which we face, if you talk about the challenges, the World Health Organization, can we go back? It's going quite fast. I think what you have to do is go up and remove the narration part of it. And then you're just going forward. I'm sorry about that. Yeah. If you want to set up a palliative care, the WHO recommends you have to look at all the three aspects of triangle: the drug availability, education, and the policy, a policy which is implemented. And when you talk about challenges, you have challenges in all the three aspects today in our country. The reason that it's not so well developed, even though we have such high prevalence of people suffering with advanced cancer. Next slide. Next slide. If you look at the opioid availability part of it, but the policy part of it, palliative care was mentioned in National Cancer Control Program way back in 1991. But still, even if you look at today's picture, most cancer hospitals, whether you're talking about public or private, they don't have any comprehensive palliative care program. State, health is a state subject. Most state does not have any palliative care policy, and except for maybe 3 states, like state of Kerala, Tamil Nadu, and Maharashtra, majority of states, they don't have any formal palliative care policy. Next slide. Should talk about drug availability. We all know that patients with cancer experience severe pain, and the WHO recommendation is that you have to use oral morphine, which remains a mainstay of treatment. But India's paradox is such that we legally cultivate opium and export to the rest of the world for their medical use. But in our own country, less than 3% of needy, they have any access to morphine, and which is, we can say we are among the lowest countries with lowest per capita consumption of medical use of opioids. And that is the paradox. And I think it stems from the total ignorance and resistance to use of opioids among health professionals and also in the community. If you look at the training part of palliative care, again, World Health Organization, long time back, they recommended that all healthcare workers at every level of care, we should have some basic training in dealing with communication, pain and symptom control, psychosocial care of patients and family, decision-making, ethics, and end-of-life care. But most of us today in this, many generations of doctors have passed out, not at all learning any of these aspects of care. And that results in a total lack of understanding of how to deal with patients who are dying. If you see, only recently that we have now formal communication or pain-related modules introduced in our undergraduate and postgraduate curriculum in India. Whereas in the Western part of the world, it's very much part of their postgraduate and undergraduate training program that you learn pain, you learn communication. I want to mention here, in spite of all these challenges which I mentioned, some of the milestones which we have achieved in last few years. In 2011, then the Medical Council of India recognized palliative medicine as a broad specialty. We have today MD in palliative medicine in many centers in India, 3 or 4 centers today we have MD in palliative medicine. This year, 2021, we have got now DNP in palliative medicine. So I think that's a very significant milestone. So we have more specialists now passing out. Another significant milestone is that Government of India bringing out national program for palliative care, just like many other national program, with a very dedicated funding kept aside for the states to use it in their districts to develop district-based program. Next. And other two milestones, which other one important milestone is about how the Government of India has amended the Narcotic Drug and Psychotropic Substance Act. The purpose of this amendment was to make medical use of opioids more easy to procure and easy to use, which was so difficult otherwise in terms of regulations. So now this has become more relaxed and the centers can, states can make use of this opportunity to make opioids available in the respective state. So I think these are the three very important milestones which we have achieved in the last 1 decade. Next slide. So a few more questions often asked about is community-based palliative care. Often it's very synonymously mentioned with the state of Kerala. And so the whole question about why do we need a community to get involved in palliative care, how to sustain the service program, because in India, most palliative care programs has evolved by the civil societies, not by the public health system. That's where often the question is asked about the sustainability. So why community-based palliative care? Next slide. We know that most of our patients are with advanced disease and they need care for the rest of their life, 24 hours a day for the rest of their life. Next slide. And apart from the physical problem, which is one part of their suffering, the suffering is not just physical. Suffering is a lot more beyond physical, non-medical, financial, social, psychological, loss of role, and spiritual. And that's the reason so much is talked about community playing a very significant role in addressing these issues, because the health workers have so much they can do to take care of these problems. Next slide. And when you talk about community, we talk about community volunteers, how they become the backbone of this whole movement of community-based palliative care. Why? Because community volunteers, they are the people who come from the community where the patients belong to. So these people, they really understand and they respond to the needs and realities of the patients. That's the reason we talk about community and community volunteers playing that critical role in the non-medical aspect of giving support to the patient and the families. Next slide. And also, the volunteers, they play a very critical role in fostering the relationship between the patient and the family and the institution, because often they feel so lost, they don't know where to go, what to do, how to make use of the machinery in the public health system. And these people, they play a very important role in fostering this relationship. How to sustain? Another question asked about is how to sustain. I would say public health approach is the only way we can improve the accessibility, so population-based approach, and sustain the whole movement. Because we're talking about a huge population. And most of these patients, remember that once they become advanced, they're in their homes, in the villages. They're not in the cities. So we have to take this public health approach. And I want to give an example of a state other than Kerala where this has worked, and it is shown a way forward to take a similar approach. Next slide. This is the state of Telangana, where I'm working right now with the government of Telangana, and how they have developed this as a model. Next slide. What they have done is they have developed a secondary level referral system in every district, a 8 to 10 bed secondary level, where they have dedicated staff of doctors, nurses, physiotherapists, and counselors trained in palliative care, and they're capable of taking care of complex needs of these patients. And they also have opioid medications available in every district. So imagine a state of Telangana with 33 districts, a new state, 33 districts, all 33 districts, they have at least one very properly developed secondary level palliative care center developed. And this center is connected by home care to reach out to these patients in the community. With the help of massive training program, which they did for the health workers in health and wellness centers, PHCs, and other community health workers, what they have achieved is that these health workers are highly sensitized to palliative care. So they recognize the patients in the homes, in the villages, and have a proper mechanism for referral back to these centers. So the patients, even in the most remote villages, they have access to palliative care. Next slide. These are some pictures of some of the beautiful centers which has come up in the districts and providing palliative care to these patients. Next slide. What has worked in this program is that government with its machinery, it could provide the infrastructure. NHM has come with its funding. But what has worked is really this very beautiful relationship with the government formed with the local NGO, Pain Relief and Palliative Care Society. And because government didn't know the know-how at that point of time, they took help of this NGO for the staff, training, recruitment, monitoring, mentorship, and quality assurance. So this is a very nice working relationship of the government with the civil society. Next slide. And what is the way forward for all of us to think about, which has worked in India, and there's a way to look at it. Next slide. Is I would like to talk about this pyramid of care. Yes, all cancer centers, if you look at the top of the pyramid, all cancer centers should have a specialist level of palliative care. All health workers, doctors, nurses, and pharmacists, today's World Pharmacist Day, all of us should have basic training, what we call it as palliative care approach to dealing with these kind of end-stage cancer patients. So when the patient need very specialized care, they go to the tertiary hospital. Otherwise, wherever they are, nearest to their homes, they should get care. And broad universal care and support should be provided in the community by networking with the community health support. And that should be the care. So by this means, the patient moving up or down, they get some kind of care and support. Next slide. And finally, you have, because we don't have enough resources in a public health system most of the time. And these gaps can be filled up by these kind of partnership and networking. We have to partner with each other. We have to partner with various societies, international collaboration for bringing in their expertise, CSR activities, NGOs, and of course, the community volunteers, which plays very critical role in this whole filling up of gaps and helping, providing that holistic care to the patients and their family. Thank you.
Thank you, Gayatri, and for bringing out the total concept of palliative care and how to organize. And I'm very impressed by the progress made in Telangana, because we always had a very small example from Kerala, but I think this is really substantial, and I'm sure you have a major role in making that happen. So at this stage, we are a bit tight on time. So Stuti, are there any questions to the panelists that has come in the chat?
So there's just one question that I see here from Dr. Bari. She asks if should India introduce HPV vaccination in the national immunization schedule?
Okay, that's a very loaded question. I think you all heard Dr. N.K. Arora speaking just before this session about adult vaccination. And this is not exactly adult vaccination, but global experience shows that HPV vaccination is the way to move forward. Currently, our rates are not very high, but there is a paper which says that if England does not have cervical cancer screening, their rates would be almost like 30 per 100,000. That is much more than sub-Saharan Africa. So the cervical cancer is a particular disease where maybe an initial decline because of improvement in living standards and other things would have happened. But I think given the opportunity now, we should really bring, especially with India's vaccine making capacity, to start HPV vaccination. And I think Sikkim is already doing that. So maybe other states can think about that. Anything else?
I think there's also one question.
There's also one, yes, sir.
Yeah, latest guidelines on cervical cancer screening recommends HPV testing. Is this going to replace VIA in India?
Okay, so we have now the global strategy to eliminate cervical cancer as a public health problem. So it's not eradication, but elimination. So in the elimination is to reach a goal of 4 per 100,000 as the incidence. And there are targets set for 2030. That means 70% of eligible women should be screened. And the latest cervical cancer screening guidelines, as Dr. Baridalin has pointed out, clearly states that it should be a high performance test. That means HPV testing. Now, HPV testing can certainly be introduced. You look at the speed with which even the rural part of India is now able to do COVID test. We have nucleic acid based testing in HIV and in TB everywhere. So I think it's only a question of time that we can shift. But I think VAA is okay, but it has not really performed well in terms of detecting, as Shalini Singh has also pointed out. I think we should really start and try and improve that. Maybe Dr. Ganesh, you have a comment on that?
No, I think it's an important area for research, but I think, like you pointed out, there are significant challenges in a country like ours for scaling up something like this in terms of mass screening or something like that. So it's important to screen, or I don't know whether I really feel that vaccine strategy, like you indicated, may be a better way to go rather than trying to get a mass screening program going in India. That may be easier because your probably a target population is more well defined. So that may work better. And as you say, we can leverage our vaccine capabilities, especially since the COVID has come. So my personal feeling is that may be a better way to go, but it's definitely something to be addressed.
And also, Dr. Atul, maybe cancer registry areas are well positioned to start such screening programs because with it's a defined population, we have the information on cancer, we can identify the trends. So do you think some of the cancer registries that you are helping to set up in different parts of the country, and in your slide also you said that they are much more than just data collection populations. So what's your comment on introducing screening programs within cancer registry areas?
So what I observe in working in randomized control trial, when randomized control trial results turns into program mode, there are a lot of challenges. So organizing cancer screening program is difficult. So I recommend we should start early detection services. That is, we should educate the population, provide easy access to diagnosis, and the important part, the treatment completion. If you see the registry data, 50% patient doesn't complete the treatment. And the cancer registry, the population is well defined, they are close to the hospitals, and these hospitals and cancer registry together can start the early detection services rather than screening.
That is good. That is the way to start, but we can also start looking at implementation research and everything, and depending on, as you rightly said, depending on the capacity of the infrastructure in terms of diagnosis and treatment, one can actually add on components to that. Good. Are there other questions or comments?
No, sir, I don't see any other questions in the chat box.
Thank you, Stuti. We are almost out of time. I think it has been an excellent session. Thanks to IPHA, and my call to IPHA is that the members of IPHA or the public health leaders should be able to see the dynamics that is happening out there in terms of the disease spectrum, cancer, its management, its continuum, prevention up to palliative care, and try and take more leadership role in this. I thank the organizers and pass on to Dr. Ganeshan for final words. Thank you.
Thank you very much, sir. As you mentioned, it was a fantastic learning experience, very excellent talks from all the speakers, and I think it was a good interaction. So in the interest of time, I think I will not say anything more, and I'll hand over to Dr. Sudhanshu for the final closure.
Thank you, chairpersons, and thank you all the panelists for that excellent deliberation and throwing some lights on how to move forward in this particular problem. We're dealing with cervical cancer for a long period of time, and we need to do something about it. That's what is the first step. We realize that this is a problem, and we should take channelize our energy and area of focus into this direction. So thank you. We'll try to see how things can be moved from this particular panel discussion. The learning from this discussion, we'll try to see how implementation research projects in a small scale can be started. The early detection is the way to move forward, but some demonstration project of screening, how screening is effective, that can also be tried in different parts of the country, and Pondicherry probably is a place where it is well suited to start experimenting and get some ideas on this particular. So with that, we conclude this session, the plenary number 11 for the 65th IPHACon 2021. I thank everyone, each one of you who have contributed and sparing your valuable time for this learning exercise. Thank you so much. We close the plenary now.
Thank you.
Thank you.
Good evening. We will start the next session. It is Careers in Public Health. It will be taken up by Dr. Harshitman Mahabatra. He is an epidemiologist and a social scientist. He has an experience of working in focused research and policy translation. And he has taken a lot of networks where it has been funded by DBT and Wellcome Trust. So the screen is yours, sir.
Thank you, Dr. Prem. But before we hand over to Archisman, I must tell that Archisman is a young, budding public health, not budding anymore. He has also established himself, and it is really, really a pleasure to have Archisman on this stage. Archisman is my junior in my college and a very bright person. So thank you, Archisman, for accepting our invitation to talk and discuss about this issue of career in public health. Your website on Great Council was very helpful for people or schools of public health where MPH programs, MD community medicine programs are there. So the question that many people ask is, after doing this course, what next? So probably you are going to answer that question, throw some lights on that particular aspect. And I'm so thankful to you for doing this for us, and I'm sure that the young public health professionals, the 1,500 delegates who have registered for this conference, will be benefited from your expertise and from your from your experience. So over to you, Archisman. Thank you so much once again.
Thank you, Sitanshu sir, for that kind introduction, and always grateful for the guidance that I continue to receive from you. I would not have been in community medicine had it not been for you, sir. Like when I was going for counseling, I still remember that date when you spared time to meet me and clear all my confusion. So thank you so much. And also thank you for this opportunity to talk today. I thank Dr. Prem Kumar for introducing me. I have a dear colleague, my old-time friend, Dr. Mohan Bairwa, who is a faculty in Center for Community Medicine, All India Institute of Medical Sciences. Even if we met during our, we didn't meet during our residency, but I always knew of him, like we belong to the same MBBS batch. So, and I reached out to him and he has kindly agreed to co-moderate this session with me.
Yeah, so before you start, Archisman, we are sorry that we are half an hour late in the session. We kept you waiting because before the cancer, the session on the cancer control was very interesting. And so please take the floor. You will be allotted the same amount of time because we don't have any other thing after this. So please feel free to moderate. You need not hurry. That's the message that I wanted to give. And welcome, Mohan. Mohan is a collaborator now. So thank you, Mohan, for joining this.
Thank you, sir. Thank you, sir.
Right, so good evening, everyone. I'm Archisman Mahapatra, talking to you from Noida. I belong to Odisha, so this bit of personal introduction should serve as an impetus to make it as non-formal a conversation as possible. We understand that this is going to be a discussion, a deliberation on careers and job opportunities after MPH or PhD, public health, or MD community medicine and all those allied subjects. So let's make it as interactive as possible. Mohan, any opening remarks?
Yeah, I think as you have already said that we try to keep it as much as possible. It has to be open session, and most of the time we try to devote on the questions and the comments from the participants because ultimately career in the public health session belong to the persons who would like to have a career in the public health. So I think we can move forward from now.
Right. So Dr. Prem, you would be with us, no? Helping out with the questions from the audience, and like how do we get those questions on the chat window? Okay, I guess.
Yes, Prem will do that. Prem will do that.
Prem will do that. Okay, fine. So the way we have designed this is we have some recorded videos from people who are managing MPH courses or have had a good career start to themselves after completing their degrees. And then some people who have gone a bit ahead like they have moved out of Odisha, out of India, and maybe have moved across countries. So right from starting from a very, what do you say, indigenous background, have gone to different places and made it big. After we play those videos, like those will give you some kind of learnings from their careers, from their approach to their professional life. We have a panel. And in that panel, we have invited members, and we shall introduce them. They are again from different disciplines. And that will be again interactive. We shall take up some questions from you. One thing that we realized is on the panel, we do not have any women colleagues. So if any one of you would like to volunteer and talk in between, just feel free, because at times career trajectories do vary for men and women. Right, so I again go back to Prem and thank him for floating the Google form. So what we did is we designed a simple, very simple Google form, and we shared it with the participants. And I shall share my screen to give a glimpse of what all type of questions came up as we floated the form. So you'll see here, we had 155 responses, and mostly they were like job opportunities, MSF and other similar philanthropic organization engagement, education, career opportunities, career growth, and of course, specialization, different degrees, and how they could go into international organizations, options in statistics, similar kind, like mostly they were related to 3-4 streams. One was about further education, and then it was also about initial job breaks and the likes. Mohan, I shared a word cloud with you. Would you like to reflect a bit on that?
Yeah, I've seen the word cloud, and before directly going on to the word cloud, I would like to say here that a set of competencies, or not competencies, basically a set of skills are required for all the public health professionals, and I felt that you wrote in the Google Forms, and that is also come through the Google Cloud. I realized that you must understand that the skills those are required, you must know what are the skills are required. So broadly, if you go for the interview for any kind of the job, the first skill that is required, there is a communication skill. And communication skill is not limited to only your speaking and writing skills. You should be able to understand the core values of the organization. You should be able to understand your co-workers. You should be able to understand that what is required for the specific discipline you are going. After that, you also need to understand that communication skill, you need to have a set of the interpersonal skills, because ultimately public health is a diverse field, and that is reflecting for this word cloud, that you see that the word is sector here, research here, medicine here, you see government, private, international, national, education, assessment. So a lot of things are there. So after that, after these two skills, the next compulsory skill that is required for the public health professional, that is the leadership skills, because ultimately either you need to work in the team, or either you need to lead a team. So for the both job, either you want to work in a team and you want to work under the leader, or you want to lead the project or the establishment or the team, you need to have a leadership skills. So those you need to learn while you are completing your degree. You should try to understand while talking with your peers, while talking with your colleagues, your seniors, your juniors. So you need to develop. After that, I would suggest that in the end I will talk about technical skills and the systems thinking skills. So these are the last part. It is the must, but it is the last. if you have a good amount of the technical skills, good amount of the system thinking skills, but to utilize that you need to have a communication skills, interpersonal skills and leadership skills. That is the primary need of the public health jobs. So that's what I was able to understand reading your questions and reading through the Google Cloud. So I think Archit, we can go now to the next part. We can show some video.
Yeah, we can jump into the videos. We have one nice video coming from Dr. Anil Villimale, who is our colleague from JSS Mysore, and he is the MPH course coordinator. Now, what we understand is our audience comprises of people from different disciplines. Even if his advice is mostly for MPH people, still then we can relate to that. So we'll play that video for you, and then we'll move between videos and discussions. And feel free to chip in, add your questions on the chat window. We shall take all of that. And of course, anything you want to share, because we floated the form, about 25 people said that they would like to come live on the session and talk. If that is not possible, at least type in the chat window. Okay, so let's watch this video, and then we can take up more as we go ahead with that.
Hi all, today I'm going to speak to you about what are the expectations of an MPH graduate. To speak to you about this, it is all driven by the kind of work that we are going to do in the future. So what are the different types of jobs an MPH graduate does? I can classify this according to 5 or 6 categories. One of them would be the government jobs. Many of the states have already implemented the public health cadre. So according to those public health cadre system, whatever contractual jobs or even the permanent jobs are available, we are going to fit ourselves there. Other than this, the National Health Mission has many programs in which the program officer or the project coordinator jobs are available. These are also one of the places where we are going to fit. And the next job is your non-governmental organizations. The non-governmental organizations can be classified broadly into 2 types. One is the local NGOs, which you can find in Niti Darpan website. Every district wise, whatever lists are available of the NGOs are available in Niti Darpan website. In Karnataka, we have Swami Vivekananda Youth Movement. Then we have Karnataka Health Promotion Trust. We have Deshpande Foundation. We have Institute of Public Health. We have Karuna Trust, so on and so forth. So there are many other organizations. Even in Maharashtra, there is Search NGO. There is Anandvan, like that. Many of these organizations are grouped under the development project, not only health. Okay. So that is about the local NGOs. Other than the local NGOs, there are international NGOs like WHO, UNICEF, Bill and Melinda Gates Foundation, PATH, then John Snow, so on and so forth. Other than this, we have corporate social responsibilities, CSRs. So every organization or every industry has to dedicate 2% of their annual profit for the development related projects. So many of these big companies have opened their own foundation, like you can see the Reliance Foundation, Tata Trust. So these kind of places also we have opportunities. Okay, and the other type of job is the research. We have Indian Council of Medical Research offering many kind of junior research fellow options and many project coordinator jobs also. Then we have also jobs in pharmaceutical companies for clinical trials, and many outsourced companies are also doing clinical trials. There also we can we do fit in. And as far as I know, the last one is the academics. Now there are around 100 to 105 Masters of Public Health colleges in India, and many of the faculty positions are required in those colleges. So that is also one place where Masters of Public Health students can. So now coming back to the question, so what is expected out of a Masters of Public Health student? So he has to fit in all of these places. What are those common things that he has to have, and what are the specific things he should have? So the way I would actually handle this is, first I would suggest everybody to go and create your profile in one of those topmost job websites. I'm not endorsing anybody, but still, navenetjobsindia.org, impactpool.org, indeed.co.in, who.iit, unicef.org. If you create your profiles in these websites, you will get to know what are those qualifications that and what are those skill sets that they are actually demanding. And to summarize the skills, many of the organizations require you to have program management and organization skills. Okay, so this can be actually your leadership skill, communication skill, and the technical part also. So, for example, if you are being hired for a tuberculosis-related project or a HIV-related project, people would expect you to know the technical aspect of it. Okay, but majority would be assessed depending upon how you can handle yourself, how you can handle a team. Because the first and foremost level at which you will be working is at the district level positions. So you have to handle larger teams. You have to have your advocacy skills to get things done. So those leadership and management skills and communication skills are at the core of a PPH graduate, along with these technical skills. Then now you can broadly classify yourself. Either you want to go towards the organization and management or towards research, primarily towards research. If you want to go towards research, then you need to have at least 2 publications within this 2 years of MPH. And also you should have, you should know how to create proposals, write for grants, and manage the budget and finances of these grants. Okay. And then every organization expects you to know the data analysis. And the commonest thing that they expect is not SPSS, because SPSS costs you 1 to 3 lakhs. If you are in an academic institution, you can get it for free. Otherwise, if you go to WHO website, they expect you to know R or Stata, okay, these kind of softwares. So it's better, even if it is difficult, it's better to always get into R software to know that coding. And also you can use R interfaces and actually get the analysis done. Writing is one of the integral parts of MPH graduate. You will be writing a lot of reports, a lot of articles. You will be communicating to larger audience. So you need to be a good writer. And you need to have these good communication skills to address the larger audience, to make an impact, to represent your organization, to advocate, and to make policy level decisions. You need to communicate, and the training skills that you should have. So these are some of the main and summarized or the core skills that an MPH graduate should have, which I could summarize in this 5 minutes that I was given. And I thank the organizers for giving me an opportunity to address all of you. Thank you.
So that was Anil. Thank you, Anil. Took out time to record a video for us. And as Anil narrated the different skills, we shall see later on, if these skills that comes from a teacher, a mentor of MPH students stands validated as we talk to different people who have been able to carve a path for themselves. We are gradually getting our members for the plenary. I see that Dr. Tapas and Dr. Pranav have already joined. Before we formally get started with the plenary after a couple of videos, Mohan, can we just request them to introduce themselves? And maybe they can also add to whatever discussions would come. Mohan, unmute yourself, please.
Yeah. So before moving to the next session, I would request, I think we can start by introducing themselves from here alone.
Yes.
I don't think we need to take a time here.
Yes. So we have Dr. Pranav Chatterjee. Pranav, could you please switch on your video and then introduce yourself? Don't be modest, because giving a good introduction will help people understand the context.
Sure. Hi, good morning, good afternoon, good evening, everybody. My name is Pranav Chatterjee. I did my MBBS from Medical College, Kolkata, and then my MD Community Medicine at the University College of Medical Sciences in New Delhi. After that, I worked with the Public Health Foundation of India for a few years. Then where I had the pleasure of working with another of our panelists, Abhimanyu. After that, I moved to the Indian Council of Medical Research, where I worked first with the National Institute of Cholera and Enteric Diseases for about 2.5 years. And then I moved to the headquarters in Delhi, where I worked for another couple of years. Last year, I moved to Baltimore to join Johns Hopkins Bloomberg School of Public Health, where I'm currently working as a PhD researcher. I'm in my second year of PhD training, and I'm also working on several public health research projects here. It's good to be here. I hope I can bring some value to the discussions. Thank you.
Thanks, Pranam. Of course, you'll add value. We know. Don't switch off your video. Like, just stay there. What's the problem? Yes, just hang on. I could see Abhimanyu has already switched on his video. Abhimanyu, your introduction, please.
Hi. Am I audible?
Yes.
Yeah. Hi. A very good evening to everybody, and really thank you so much for having me and giving me a chance to just speak and share my experience. I'm Abhimanyu, and you will also come across one of my recorded video in this session, I believe. Basically, I am a biologist by training and have a master's degree in public health management. And thereafter, I worked for almost 7 years with Public Health Foundation of India and had a 2 years tenure with the Inclaim. And I was working with Dr. Harchesman there. And we were working together, me and Dr. Pranav at Public Health Foundation of India on a project based on the concept of One Health. And thereafter, I moved to Brussels. I got an opportunity to work under program evaluations and capacity building initiative by International Diabetes Federations. And most of the projects are in Sub-Saharan Africa, like Kenya, Ghana, Nigeria, and we are expanding it to further different countries in Africa. And we are basically targeting capacity building initiatives for physicians as well as for diabetes educators. So my role is limited to evaluation of these capacity building programs and looking into the small inquiries for patient-centered care in these settings, and also to evaluate these programs or their impact. So this is my brief profile. Thank you everyone.
Thanks, Abhimanyu. Thanks. You are the connecting link. Thank you, Pranav and Abhimanyu. You both are being based outside, have spare time. I do not know what zones. Pranav's eyes look a bit swollen. He's just caught up, it seems. And Abhimanyu, it's midday for you, I guess.
Yeah, it's coming.
Right. So we have Dr. Tapas. Tapas, your video and introduction.
Hello. A very good afternoon from Geneva. Hope you all are doing well. I'll introduce myself. I'm Dr. Tapas Sadashivan Nair. I did my MBBS from JIPMER Pondicherry. So in a way, this is a virtual home for me today. Subsequently, I did my MD in community medicine from Maulana Azad Medical College, where I was basically Pranab's batchmate. So we know each other well since those days. Since after my PG, I had joined as an assistant professor in a private medical college in Kerala. I loved the experience, but I realized that academics was not my cup of tea. And that is what sparked my interest in going into public health per se. I had joined as a surveillance medical officer, worked in Uttar Pradesh for almost a year. And then I joined the Ministry of Health and Family Welfare in the Immunization Technical Support Unit, where I worked for 2 years supporting the Universal Immunization Program. Later, I joined JPIGO, India Country Office, where I worked as the Monitoring, Evaluation and Research Officer for various projects. That really helped me broaden my expertise because I had an opportunity to work in projects in various domains of public health, right from maternal newborn child health to health system strengthening to comprehensive primary health care to even COVID-19 response. And since March, I have been working at the WHO Geneva as a technical officer for the Health Workforce Department. It's a pleasure for me to be here with such distinguished luminaries, and I hope to share my thoughts, my journey, my insights, and help guide the next generation like I was guided by my seniors, my mentors, and my faculty members. Thank you.
Thanks, Tapas. That sort of like we are short of one more panelist, Dr. Sriram, and he shall join in shortly. He's in another meeting. So to introduce him in absentia, he's the lead of scientific communications at Eli Lilly, and that's a leading pharma organization, and he has a team that keeps working on different research projects and produces good research papers. So that team employs MPH students. He himself is not a, yeah, I think Sriram has joined. Sriram, hi. Yeah, please unmute, yeah.
Yeah, sorry, Archishman, I was in the other workshop and the session was going on.
Right, we'll request you to introduce yourself, Sriram.
Hi, everybody. My name is Sriram Govindan. I'm currently a team lead for real-world evidence and patient-reported outcomes publications writers. I've been a publications writer for nearly 6-7 years now. Now I don't write documents. I do more of peer reviewing and managing people. But when I started off in Eli Lilly and Company in 2016, I was a publications writer in the neuroscience domain. And I was writing critical publications for some of our pivotal molecules. And before that, I was a writer in Novartis for 1.5 years. And before that, I actually had a stint in R&D, again in Novartis, UK. I was in respiratory diseases research. And before that, I finished my PhD in 2010. It was in calcium signaling. It was more of cellular pharmacology, it was not on the clinical side of things. So I would say really the last 6-7 years I've moved from the preclinical domain to the clinical domain, and now I have really focused on real world evidence and patient reported outcome work. So thank you, Vachisman, for inviting me here, and it's a pleasure to be with all of you today.
Yeah, thanks, Sriram. Thanks for joining in. So that completes our panel for this discussion. Mohan, I think everyone knows you. Still then, I'll take this opportunity to introduce a bit about you. Mohan is a faculty in All India Institute of Medical Sciences, New Delhi, in the Center for Community Medicine. And he previously was with IIHMR Jaipur as a faculty, and he was coordinating the MPH course there. So he has been like sort of a senior teacher, mentor to many people in public health, both MPH and MD. So the purpose of having all of us together is that the audience would appreciate that people have been like, there is no consistent career track. So people have switched gears, switched careers, have had flavors from different types of things, and now are doing fairly well. So before we reflect into the skills, I have one video coming from Kaushik, and then we can deliberate a bit on what other skills may be needed.
Hi everyone, my name is Dr. Kaushik Sarkar. I'm the interim country director of an international non-profit, Malaria No More. Starting October, I will be leading our Global Center for Malaria and Climate Solutions as the Scientific Director and Chief Innovation Officer at Malaria No More. I'm a community medicine professional by training, and my work focuses on the field of digital transformation, innovations, and application of artificial intelligence in global health. Community medicine is a special branch of medicine that looks at the population at large, in contrary to the individualistic care focused under internal medicine. The scope of work in this discipline is diverse, essentially because of the interdisciplinarity of the subject. Individuals trained in this subject can choose to work in various niche areas, which include but are not limited to policy and advocacy, health security, public health practice, program implementation, strategy and partnerships, research, innovations, and teaching. One can even choose to work in overlapping areas depending on his or her experiences across different domains. I started my journey as a program monitor, gradually indulging in program strategies, planning, and implementation. While working in that space, I got exposure to digital health, health analytics, implementation research, and various other related areas. The experience gave me the opportunity to quickly move into a technical position, which includes research, program implementation, planning, etc. But it also gave me the opportunity to engage in policy advocacy, communications, and eventually innovations. The key to succeed in this domain is a combination of three elements. One, continuous upskilling towards a specific direction 2, working in the field and working hard. And 3, building a strong network of peers and seniors, and also with the professionals in other disciplines. Since community medicine does not have any specific specialization opportunity, unlike medicine and surgery, one must find the cross-disciplinary skills to be able to move up the ladder. For example, you can become a digital health specialist if you build your skills and gain experience in health analytics, health informatics, and in other quantitative fields. Similarly, advancing the degree and skills in epidemiology can enable one to move in health security, health intelligence, and similar domains. One can even move to for-profit sector if he develops cross-cutting credentials in management and/or business. Secondly, I talked about working in the field. So the bedside clinic for a community medicine specialist is field practice. A community medicine specialist must start his or her career working at the field level. The level of exposure can vary, but understanding the community environment in which they live and the system that provides them the services are essential to excel in any role. The networking also varies as one continues to gain experience and move up the ladder. But it is essential to have relevant peer network who can support in providing exposure, opportunities, or knowledge at the least. There are various industries that recruit community medicine or broadly public health experts. It can include public sector like health programs as program manager, monitor, in hospitals as managers, infection and hospital safety practitioners, or even preventive medicine practitioners, pharma in research, health projects, real-world evidence, donors in strategy and business roles, technology organizations as health technology experts, and others apart from teaching industry. Staying in one industry and diversifying experiences have both their pros and cons. But one thing is important: gaining a unique expertise in a specific niche. The niche is for what you want to be known for, and it can be a disease thought leadership, an application, a skill set, or even a subject area. I always recommend 3 I's to build community medicine care. 1, interdisciplinarity, 2, integration, and 3, innovation. There are opportunities to apply these 3 in any domain of work of community medicine. Interdisciplinarity is the application of multidisciplinary tools, techniques, etc. in your domain or discipline. For example, you can apply principles and methods of economics in public health measurement and monitoring. Integration is bringing synergy across strategy, business, portfolios, or even in implementation. It exists at every level. For example, you can integrate the functioning of analytics, monitoring, and program divisions. You can integrate research concepts, methods, applications, and can even translate interventions and experiments between domains or subject areas. Innovation is bringing a new idea in a particular field. It often requires design thinking and change management. So understanding design thinking and change management are essential. It can be a small change, as small as the routine movement of stock between different health facilities, or a big change like a policy change. But change is important in a way where the newness exists and applied efficiently and practically. I thank Dr. Archishman Mahapatra for this opportunity provided to me. And my final message is that no field in medicine gives you more opportunity to work than the field of community medicine. One must cash in with the scope of diversifying to be successful in this domain. Thank you.
So that was Kaushik, who gave a very strong message for people in community medicine. This is an open question, like Pranav, Tapas, Sriram. You guys have been working both with those with medical background as well as those not directly trained in medicine, but in public health. What kind of things you value as team leads? Sriram, I'll go to you first. Like you have a...
Yeah, sure. Archishman, can you repeat the last question?
Yeah.
Value as what?
As a team lead, like you lead a team, right?
Yeah.
So
Yeah.
What do you value?
Yeah. So the writers in my team, they are folks who are, of course, conceptually very good, but they are also very good professionals in terms of agility and flexibility, right? In accommodating things into their work schedules. And they have very good communication skills. They have good project management skills as well. So ability to write well and communicate orally well is also a very good requisite. And I cannot really, stress the importance of that. It's all great that we are all conceptually good, but if we cannot communicate those concepts well into writing or when we speak, that's not going to actually carry much weightage, right? We also have to write papers on treatment patterns and real world evidence substantially. So that's a good part of our workload. If folks want to get into the HEOR and the real world evidence field in corporate sector, they really have to understand how the claims databases work. It's just not important to have strong understanding of epidemiology and public health concepts. It's also important to understand how a systematic literature review is done, what are meta-analysis, what does the evidence pyramid look like, and in the other workshop, just when we looked at medical writing, right? How to write papers really well, how to convey the information in a succinct and clear manner. This I think can be a valuable asset or attribute for anybody who's in academia as well, because they have to publish a lot if they want to pursue research, right? So you can either go into academia or you can come into the industry. If you have those core writing skills and good oral communication skills, of course, the project management and people management stuff that comes later on. But I would say the bedrock really is ability to communicate and connect with people. Yeah.
Thank you, Sriram. For someone who wants to take up a career in research, Pranav, Tapas, you would like to add in here? You may also there is one question also. What is the scope of or opportunities for higher education post MPH outside India, like Canada in particular, and how one should go about? So Pranav would like to take that question and then also reflect on how to stitch a career in public health from community medicine or directly specializing in public health.
Sure, that's an interesting question. Thank you for directing it to me. So after your MPH, what kind of higher education are you looking for? Are you looking for focused training, for example, an SCM in epidemiology? Are you looking for a wider training or more in-depth training, such as a PhD in a specific area? That will dictate what kind of opportunities are open for you. So the first step would be to figure out what kind of training you need. The next step would be to figure out what institute and which mentor within that institute would be a good match for you. This is specifically important if you are applying for a PhD or a longer term program where your niche is going to be created for you for the rest of your career. So that's also important. The third step would be to strategize. What are your strengths? Are you going to be a good competitive candidate for that program? If not, how can you improve? The easiest way to make yourself more attractive as a candidate is to publish and work on research projects. There's nothing that is more valuable than real life work experience, and the currency of experience in our field, at least in academia, is peer-reviewed publications. So if you feel like you have an opportunity to apply with adequate number of publications and research experience behind you, go for it. If not, maybe take a year, because MPH programs can get a little heavy academically, giving fewer opportunities to publish and work in intense research projects. Maybe take a year, build up your portfolio of research projects, profile of research publications, look for people in different organizations who you can work with. See, there are opportunities that you can be part of. Use platforms like the one that is being offered here through this conference to connect with people, to connect with your contemporaries across different countries and cross-learn. I think the way my career has emerged has been very unstructured. I didn't plan so many things. It just sort of organically took me from one step to the next. So I feel I may not be the best person to advise on the strategizing step, but it would always be good to keep weighing your options and seeing if you are stacking up against the competition and how you can make yourself more attractive to the institute organization that you're aiming to be a part of. Just some initial thoughts. Yeah.
Right. So suppose I'm doing my MPH and I'm just completing it and I want to get into some international course. What I could take back from your brief talk, Pranav, is that you want me to just hold back a bit, do some recce, like understand where I'm actually headed, and then identify the right mentor, the right environment, the right ecosystem, and then go for it. Like not just jump into any course, right? Okay. Yeah, you'd like to add anything?
Yeah, it's just that it's like a lifetime commitment. So make sure you're getting into something that works for you.
Yes, I see that connecting link between what you said and what Sriram was also mentioning, because the skills are really refined ones. You don't get that in 2 years' time or 3 years' time. You tend to evolve. Right. So Tapas, Abhimanyu, yes.
Yeah, I just want to add like a very, very short point and out of my experience while working in a European region. So whenever you are choosing, like for Canada, it's fine. But in Canada, we also have an English speaking and a Quebec region. I think it's French. I'm not sure. I think it's French speaking. So similarly, we have in Europe, like there are so many, over 30 countries in the European region, and everybody speaks different language. So if you are somebody who is interested in clinical statistics or clinical trial related statistics, then it's fine. But if you're somebody who is from a community medicine background and want to specialize in, let's say, medical anthropology or something like in which you need to interact with the local community, even in clinical trials, like you have to visit hospitals and doing patient monitoring and all these forms. So there is some practical aspect to that. Like, for example, I'm working in Netherlands, in Belgium, in France. So most of the people in France and Belgium, they speak French. Here it's Dutch. If you go to Germany, it's German. If you go to South and Austria, northern part, so there are different languages. So like I would suggest to go to a English speaking country if you want to specialize in things like medical anthropology or whatever which needs community or patient interaction, because it theoretically it sounds feasible to learn a new language, but it's very difficult. It's not easy, and it's not about learning at an A1 level or A2 level. You need to have a expertise of a native. So your resume will be on the table, but it will not be prioritized if they find somebody who is having a little bit low, not exactly low. For example, you are doing a PhD. If they found somebody who is master's but who is a local native who speaks languages, they will invest more time in them to train them rather than recruiting you. So these are some practical aspects. So desk jobs, not exactly desk jobs, but like designing studies, epidemiology, statistics, all these things you can manage in any part of the world if you do your advanced training. But community engagement and community processes are difficult. So that's something I would like to add.
Thanks, Abhimanyu. So now cryptic messages, or maybe they're being simplified. I'll just take up some points there. From the videos we did, like they were like pointers, like 1, 2, 3, 4. What now we are getting it is that Sriram said that you need to have refined, evolved skills. Pranav said that give yourself some time like know yourself adequately before you choose a career. And now Abhimanyu is pitching for understanding the context and acquiring context relevant skills, and that too of higher levels, maybe knowing the language where you want to go to. Tapas, you are someone who moved from down south, trained in the north, went back as a faculty down south, then into a development organization, now to Geneva. Like tortuous journey. What are the learnings?
I would like to take a shot at that first question. Even though I have not worked as a team lead, I can tell you what are the skills which I appreciate from a colleague, from a senior colleague or a junior colleague. One thing, since I work mainly at the ministry and at NGOs which focus on program implementation, one thing we really value is field experience. It's always, even while selecting candidates as a program officer, as a technical officer, even as a research officer, we look at the depth of field experience. It does not need to be intense, but some amount of field experience is always good to ensure that the person is centered. The person is talking to the grassroots. He or she is not just, having some concepts which may not be relevant for public health. So field experience is something which we really prefer. Another thing which we really like is, and this is something which comes from experience. This is not something which we can look right at the hiring phase, but we look during the probation. We try to see what sort of personality, what sort of nature is the person. Is the person a team player? Is the person willing to collaborate, willing to support? If the team is going through a crunch time, is the person willing to pull his weight? Those are things which we value in colleagues, especially those who are willing to help other colleagues in crisis. Those people are irreplaceable in any team. Another thing which we value is on-the-job learning. Though our curriculum is very good, it is not comprehensive. It may not be suited to certain jobs. So there are certain skills which a candidate may not have at the time he is joining a certain organization. For example, after joining WHO, I have had to learn DHIS2, I have had to learn Power BI, I have had to learn Stata, because these three skills are essential here. Earlier I was using SPSS. So they said, even during my interview, they said, oh, that's great, but we all work on Stata and we expect you to work on Stata. So on-the-job learning is very critical. And candidates who are willing to put in that extra mile to show that, yes, they can gel with the team, they can get on with the on-the-job learning, are always valued over the candidates who are not flexible. Another ability which I admire from colleagues is those who are able to adapt. This is again something which Sriram talked about earlier. It's about agility. It's about adapting to changing circumstances. Public health is always evolving, especially where you have wherever you're doing active implementation of programs or some research studies. Depending on the circumstances, things can always change. So we need people who are quick to adapt. The biggest example is COVID. Everyone had to adapt because of COVID, the program implementation strategies, the research methodologies. So it's all about trying to staying updated, knowing what's happening in the field, what others are doing, staying updated with the best practices across the world, and adapting and adjusting and pivoting as and when required. Thank you. That's all from my side. Thank you.
Thank you, Tapas. Things are now becoming more and more clear, hard skills and soft skills. You talked about agility, like being a good team player, a colleague who has your back in crisis situations and also adapts well. So good inputs. Mohan, you have trained both, like you have trained MDs, you have trained MPA students. Like what has been your overall philosophy?
Yeah, so thank you, Dr. Archie. So this is a nice question, and I think this is much relevant to all the freshers who are trying to explore the jobs and opportunities in the field, various diverse fields. So as our panelists discussed and we deliberated on there are a lot of job opportunities are there that may be range from the government, non-government, private sector, education, research. All opportunities are available for everyone, and it is not necessary to be you have to be from a very specific field. It is not necessary that if you want to adopt a job, then you need a MD. If you want to go into some kind of the public health job, then you need to do MPH. You can come from the any background and you can go in the any kind of the job. But there are some baseline that needs to be required by the everyone, that I felt through my career as a I have given interviews, I went for the job, and I am providing jobs as well. So I have seen the both kind of the scenarios, and in the both perspective I have seen that there are basic skills which needs to be required from the initiation. For example, what you have learned some numbers of the skills from your technical area or your niche area, but if you do not have a good skills in terms of for example, I would say communication skill. So communication skill is very important if you want to excel in your niche area. Second, communication skill is not limited to just I have said that writing and talking. It's about communicating to other, engaging with the people. It's about your cross cultural competence, because you need to work with the diverse kind of the people, because our panelist already explained that public health is a diverse field. You need to work with the different kind of the people, you need to work with the different people from the different fields. So for that you need to have a good communication skill in the diverse range of the communication skills. As you can say that interpersonal skills are also required to have a good communication skills. Second, when we talk about specifically your hard skills or your technical skills, so things starts from the very basic things. You can say when you are going for the interview, they will ask about the publications. This is one thing which ask from you always. So a publication, while writing a publication, you have to learn many things. You need to learn about referencing, you need to learn about writing context, you need to develop your strategic thinking from cause to effect in terms of the epidemiology, or you can say that exposure to outcome. So these kind of the terminologies you should be able to speak, you should be able to connect with the people, you should be able to engage with the context. Then simply there are many small things like using appropriate punctuations, using appropriate grammar, that is very important. When you come to the interview nowadays, we realize that we need to give some exercise. At least we can ask candidate to write an email and explain that what he wants from us and why he want to join us. So we used to see in that way that what kind of the emails you can write, how can you explain yourself, how kind of the competence you have, how you start your email, how you end your email. So all these kind of the competencies are required for the freshers. What Pranab has said, Sriram has said, Abhimanyu has said, those are the skills, those are needed when you further excel into the field. But when you are looking for the job, some basic things are the necessity, and that you need to work a lot on that. These are the simple, but you don't realize that when you are looking for the career in the public health, you need to work with the diverse fields, diverse people, diverse communities. So you should be able to engage with all of them, as well as in the next part I can tell you that you can identify your skills in the three terms. One is hard skills, one is soft skills, and one is nowadays you can call it online skills. You should be able to know that what kind of the online skills, that is not only limited to the statistical softwares, but you should be able to use MS Office, you should be able to use internet, you should be able to use other kind of the things which is required while using the internet. Definitely when you talk about the systematic review, meta-analysis, literature review, then these skills would be paramount, that whether you are able to use computer skills or the internet skills perfectly. So I think the freshers would be struggling with the entering into the job when they will need a set of the communication skills, set of internet skills, set of hard skills, and then they need to identify that they should be able to well versed with the one or more statistical software that they can call it as a part of online skills or the internet skills or online skills, whatever they would say, but they should be able to do that. And second, while developing such kind of the skills, especially internet, there are a lot of open source softwares, open source opportunities are available. They can utilize them, they can develop them, and they can engage with the people who has done something, who has developed this kind of the skills, so they can learn. So networking is again important aspect that they need to identify it while doing through. So these kind of the challenges we are facing when the persons coming either from the community medicine background, either they are coming from MPH background, or they are coming from other MBA or other medical anthropology, any kind of the discipline they are coming. So we need to we have to look for these basic skills. So while developing your niche area, all the I request all the aspirants, those looking for the job, they need to work on these hard skills, soft skills, and online skills. I think this is enough for now, and we can move to the next part.
Yes, Mohan, thank you. You actually talked about skills that are not, like suddenly it looks a bit overwhelming for me as well. Like how does one acquire all of that in 2 years MPH or 3 years MD, or say even 4 or 5 years of PhD? A lot of learning on the way, right from your schooling years, how much exposed you were to technology, to equipment, what kind of an ecosystem you had. So, but for youngsters, for the audience, I think we are now identifying certain core areas. Like if you don't know how to operate a computer, you would not know how to handle a software. So you need to cover that mile on your own. And language, even if I would not endorse that you need to be very clear with your English, very proficient, but at least when we say that you need to be able to communicate, that means you need to be able to say things which others understand the way you want them to understand, right? So in whichever language you use. So those are certain things. We have one more video. That was from Abhimanyu. I was not expecting that we could have him for today's session live, but he has also joined. I'll play that video, and then we'll come back for some more discussion on internships and all.
Hi, good morning, everyone. This is Abhimanyu Chauhan, and I am working with International Diabetes Federation at their Brussels office. I'm basically a biologist, and after that I did my Health Service Research Management Master's degree. And since almost 12 years, I'm working in this field, and my specialization is basically on mixed method research, and all that by learning by doing. I don't have a PhD or a specialized master in that. So I have a little bit of advice for new graduates, fresh graduates, or those who are in their final year of public health degree, whether it's MPH or it's MD. I would like to take you back through the times when our parents, they were doing a bachelor's degree, and that was quite sufficient to go into the field and the work. But then time changed. Most of our seniors, we did, or ourselves, we did specializations in various fields. Let's take an example of public health. We specialize in biostatistics, econometrics, and qualitative research, medical anthropology, many more options. But now there's a change. People are more moving into super specialization. That's because that's the demand of the hour. So I would suggest everybody to be in the field for 2-3 hours. You don't have to take any decisions so quickly. So after graduating, just choose a broad area of interest which excites you. Don't be so particular, because it's difficult. If you don't have an experience, it's difficult to understand what all options are there in the field. So once you graduate, join somewhere, just try to learn things around how, what are the priorities in the particular area. For example, if you work in India or in a particular state, try to understand about the priorities for health research or implementation research. And then in 2-3 years, try to figure out what actually interests you. So for example, if you talk about specialization, a normal specialization, it's biostatistics, let's say. So within biostatistics, people are developing themselves a specialist, for example, dealing with big data, dealing with big prevalence surveys, burden estimations, statistics behind that. So that is one of the super specialization of biostatistics. Similarly, we do have statistical genetics, like understanding the genetic basis of the disease, the protein structure predictors, something like that. So similarly, we have super specializations in health economics, clinical epidemiology, even mixed method is coming up as a specialization. So I would suggest the future of public health is very bright, but try to pick some sort of super specialization for yourself so that we'll try start approaching you. Because these days, what I have seen in the market, people are like very particular about your publication in particular field, which is very specialized, and then only they approach you for some assignment. So other than this, I would also like to share to develop some expertise in management. For example, in the recent years, I also was part of some recruitment procedures, and I've also appeared in many interviews. People always try to understand, like, other than your science part, what you are bringing on table in management. Because sooner or later, in 10 years and 15 years of career, you will not be able to give so much time to your science part than as compared to the management part. So you have to work as a PIE, a senior investigator. You have to look after the administration, management. So that is something which you should develop from now onwards. I won't ask you to go for a full-time MBA. You can't keep doing that. So try to have some good certifications, like from Project Management Institute. It's a very reputed PMP program. So you can enroll in that. You can study for it. You can clear that examination, be certified project management specialist in addition to your science specialty. That is very important. And one thing, I just don't want to deviate from the topic. Two things I would like to share that will have a very long-term effect. Public health, and like most of the other field, is all about networking. Don't spoil your relationship for petty issues. So relationships are very important. That is one thing. So petty issues, like, okay, I understand it. You feel depressed when you don't get your deserving credits on a paper. You should be a first author, but then you're landing up being a third author. But believe me, that's not a very big price to keep your relationships on, and try to have a little bit of let go attitude, at least in the early phase of your life. That is one thing. Second is try to connect people. Yeah, you heard it right. Obviously, you will connect with people, but also try to connect people. For example, let's say you are not clinical, you are an epidemiologist, and you have a biostatistician. You have a friend from economics background. Try to connect them. So that will bring opportunities to you. When a biostatistician and economist connect, they will surely need an epidemiologist. So that will open a horizon for you. So these are a little bit of advices from my side, from my short stint in public health. Good luck. Thank you.
So I have an opportunity to thank live for a recorded video. Thank you, Abhimanyu. Words of wisdom. Now, this again brings us to the next layer of discussions. I just completed my MPH. I just completed my MD. How do I land my first job? Like these days, it's becoming more and more tough, even after PhD and all. Just to loop in Sriram to make it more relatable to him, right? So how do I land my first job? So that means, is there an opportunity to network professionally while being a student? Is there an opportunity to do some internships so that we have some hands-on real-world experience and managing references like word of mouth or written reference letters. There was a question Mohan pointed out just now. So we can take up all of that in this session. And then there are 1 or 2 questions for Pranav. I think Pranav. Hi, Pranav sir. How did you land? How did you get into Johns Hopkins? Okay. So that's a direct question for you. And then there is one more from that was from Emmanuel to you, Pranav. And then from Aparna, there is one question. Hi, sir. Could you elaborate on different sectors and about CSR? I think anyone, Mohan or Sriram, anyone would like to take all of that. So 5, 6 questions, the context for the next round of discussions. Landing your first job, internships, references, getting into Johns Hopkins, and then different sectors and CSR. Yes. Abhimanyu, let's start with you. Internships. Should they be paid or unpaid?
Why is that even a question? It should always be paid.
It should be paid.
Who should pay? The intern?
It should be paid.
Oh, no. The intern should pay. The intern should get an internship salary.
Yeah, even Manrega pays you. So that's a good starting point to like it's a evidence that interns also deserves at least some payment.
Right,
we are not
so
quantifying it, but there should be some little bit of motivation. At least organization should support with auto fare, some 5 rupees per kilometer, maybe something like that, some sort of support which can motivate them. So basically, all internship I did, I never got paid, but there's no problems. So the payment in terms of monetary benefits, I think in my internship, I got whatever work I did, I got all of them published, and in couple of them I was first author, and I also co-author or in some order in each of them publication. But it's you who has to push for it. Like maybe at senior level, their priority is not to publish, and in implementation projects like you work for, maybe I'm not sure if it's UNICEF or something, even they publish. But in most of the organization, like where publication is actually not a criteria to as an output for completion of the project, there you have to push. So that is one sort of incentive which you can look for. If they're not paying you, even if they are paying you, you should still go for publications, and because this is something which you will mention extra than your normal experience. Like for example, somebody, there are 10 people joined with you, let's say, so in 2010, and if they pass out in 2012, then everybody will have same 2 years of experience. How your resume will be different from them? Try to publish, try to present in conferences. So that's what I did. So in earlier days, I was like, to be very frank, I also fell into trap of the predatory journals. So I published a couple of papers, good data, but I published in predatory journal. I was happy till the time I got to know that what a predatory journal is. But that was a nice experience. So in early days, it's good to publish in couple of predatory journals, because that's a very small price to know about these things, so that you will not make that mistake in the future. So that's how I started, and I had no preference, to be very frank. When I graduated, public health market was not at that much of boom, so I had no preference that I belong to another part of India. I want to remain close to my parents. So I got a small opportunity with the PHFI Bhubaneswar. It was a post of training associate. I was interested in research, but I joined. Then I keep approaching Dr. Archesman knows this story. It was almost 10 years back. I used to approach all the senior faculty members, just include me in some or the other study. I don't know anything, but I will collect data. I will go out and fill the forms. So if you fill the forms, if you fill the data in Excel sheet, then only you will get to know how to analyze data. If you don't know the difference between the different file formats, you have to start from somewhere, basically. So if you keep approaching senior people, you help out, you will do internships, monetary or non-monetary, you will get a kickstart, and it will give you a lot of experience. Now, I was not aware about what is medical anthropology, what is the different field in statistics, what is big data. I got to learn all these what we call free jobs in early phase of life. So try to do internships, make your connections, work for free for some time, work over weekends. That's the only possible way to highlight your resume and to develop your skills. That all I will say. So I did it for 2-3 years. Then it's been almost 10 years, and I'm happy whatever I did and what I am doing right now.
Right. So Abhimanyu's journey, I know him, like it's been 10 years, and that's the reason I had Abhimanyu for today's session also, so that stories are relatable. The thing is that it's not about like when you're aspiring to have a successful career, when you're starting out, things look very lucrative there. But to reach there, the journey has been really tough. Nobody shares their story in that much details. So and we aspire to get into some position from this position. It doesn't happen overnight. It takes a lot of effort, especially in contexts like India, where you need to work for stretched hours, really prove yourself every other time, your commitment, your integrity, everything. So that's a lived experience, a lot of hard work. So you want to move from here to here, but you are competing here at this level with your peers. So how does your resume stand out in comparison to others? Before we get into Johns Hopkins, let's go to Tapas. Tapas, reference management, is it a word of mouth thing or is it a written thing? How do you collect references? Is it like embarrassing to request for references?
From personal experience, it is not embarrassing. Approach your seniors, approach your faculty members. I mean, they're always there to help you. I mean, that's the whole point of having this alumni network and leveraging this alumni network. Whichever school we study from, whichever institute we study from, we will have lots of seniors who are in very high positions. For example, when I passed out from my MD, I had seniors from JIPMER and from AMC who were in very, very high positions in National Center for Disease Control, in the RNTCP program, in NACO, in IDSP, and in NGOs like Union, UNDP. So those were my inspirations. And I always, I mean, I took their references, but I always used to talk to them also. I used to keep in touch with them, be it through WhatsApp, be it through phone calls, just trying to understand their experiences. Ultimately, we need to find our journey, but we can look at other seniors and other experiences and see what's convenient for us, what's not convenient for us. So that's one very important thing. I never did an internship, so I can't comment about internships. But at JPIGO, I was fortunate enough to mentor some interns. And I've realized that your internship is very critical, because that opportunity is your first opportunity with an organization. And as they always say, first impression is a best impression. There is a very high chance of interns being selected back into the same organization for positions if they do well. And that is something which I've seen from experience. So for all MPs where the internship is a mandatory part of the curriculum, it's a very good thing. Again, I would say, talk to your seniors, talk to your faculty members. They have a lot of exposure. They know a lot of organizations. They can personally recommend. So in my case, a senior of mine recommended that, okay, I have this junior, please facilitate an internship in JPIGO. And that's how it works. When I talked to the HR department, they said, sure, why not? Because in India, no internship is paid. That's the sad reality of it. Even UN organizations have just started paid internships last year or the year before that. Till then, even UN organizations did not have paid internships, which is amazing. I mean, people used to pay for the airfare, for the travel, for the accommodation in Geneva, just for that internship. So even in India, I think even to this day, organizations do not give paid internships. So that's a very big barrier for students who may not be so affluent. For example, if the student is coming from the south all the way to Delhi and has to stay in Delhi, I mean, you know, the accommodation charges in Delhi, the cost of living expenses, it's a major barrier. But I think having an internship in a prestigious organization is very good for a person's career. I mean, at least from personal experience, based on the interns whom I've seen, it's really helped them a lot. And because the person who mentors them or the person who supervises them usually becomes their reference for their next position, and is in a position to recommend those names for positions. So yeah, thank you.
Yes, even I'm also learning this. Nobody told us, but this advice goes not just for the MPH students or the MD residents, but also to the faculty mentors. Like if you want your students to be placed, you can help them find internships. So you definitely have your colleagues, you definitely have your friends, and they are well set. And if they could put in a word of mouth, word of reference, someone's career may just shape up. Sriram, how has your journey been? Like you must have had your own set of challenges, and now last time when we spoke, you were also open to having interns at your place. So what kind of learnings?
Yeah, so we call the fresher jobs as interns in our company. So people who have graduated, that is, who have just now finished their masters or PhDs, or who are just about writing their PhD thesis, they actually can apply for internships in our company. And to Tapas's earlier comment, maybe we are the only organization that pay interns, and the salary is pretty decent. I would say, can't reveal the amount, but it's quite lucrative. So we have 3 interns in my team right now. A couple of master students, both are from Vellore, and they are actually MTech students, right? So we select them based on the writing skills and communication skills. The hope is that if they're really good at writing, then they can get into the writing part of the job. If they are good at project management and stakeholder management, they can do all the operations kind of work. And if they can actually do good QC, then they can get into the QC role of the organization. So ours is a fairly big team. So we need several roles to really move the entire machine, right? And then folks who come with the MPH background, I think they can become writers even after 6 months or 1 year, if their writing skills are good, if they're able to partner with the senior members in the team to write abstracts, posters, and then obviously the job requirement is that they talk to our global partners in Indianapolis, understand what the data is, and then develop these publications, that is abstract posters and manuscripts. As I said, most of the publications are on treatment patterns, SLRs, meta-analysis, those kind of things. Coming back to my own career, I've had a very unconventional career. So I was more interested in R&D, in preclinical R&D early on. But when you are in research, you write well, because you have to write well. You have to thrive. If you have to thrive, you have to write well, right? Because I was writing well, then I thought, okay, let me get into pharma, because that will give a very big bird's eye view of things, how things are going. And I was always curious. I think that the word curious really applies to me even today, from my undergraduate days to now. I'm always curious to know what is the next drug that's in the market that's going to be the blockbuster. What is the game changer in the world right now? And if people stop being curious, I think all the fun is gone, if you ask me. And I always look for junior associates and interns who are curious, because that curiosity can take them to very high level of all the soft skills, all the things that we have gathered so far in the careers, right? That comes as a natural course of action if you're curious. So I would say, to the earlier point, I think from one of the panelists, it's also important that you spend time to realize what you want to do, even if it means that you spend 1 extra year not earning money. That's fine. But I think that first job that you get, or the first internship that you get, that's going to be the game changer, because that's going to really map out the entire life for you, because it's all sequential. It's all through networks, and it's all by chance. So I think you really have to listen to your heart and see where your passion and enthusiasm is. For me, when I was in my undergraduate, I used to really dream about being in a pharma company, you know, and being technical. My friends, they actually did MBAs. Several of them did MBAs, and they went into management. But I wanted to stay technical, and I wanted to work for a pharma company. So you could say partly my dream is fulfilled. I don't know, where these dreams will stop, but I think it's important to just follow that particular passion. Because I had that passion, I chose pharmacology as a subject area and PhD. And later on, that PhD took me into pharma industry itself, where I did my postdoc. And then, I was planning to come back to India to do preclinical work, but I'm happy where I am right now because I still feel intellectually stimulated with whatever I'm doing. It's still technical work, right? So that's my advice.
Right. So that gives some industry perspective, and being driven by passion and being a bit futuristic, having a vision, like being updated. You said curious, updated, but then that gives some vision into the future. So right. So there was this question about what different sectors and CSR opportunities. Would you be able to talk on this, Sriram, or shall we?
What do you mean by CSR opportunities at this one?
No, the question is something like this. Hi, sir. Could you elaborate on different sectors about CSR? So,
corporate social responsibility.
Yeah.
Okay. Yeah. So I think I have been in the CSR committee of Eli Lilly 2-3 years back, and in large companies, ours is not really large in the Indian context. We are large in the global context. So for Indian companies, they have a mandate to spend a certain amount of money on CSR. So I think it's about 5% of your profit or something like that. So these big companies in India like Tata, Reliance, Infosys, all these companies, they have the corporate social responsibility department. And I think even Biocon has one, called as a Biocon Foundation. So these guys, especially folks like Biocon and all these pharma companies, they tend to focus on relevant here. So these guys really want to educate folks. They want to understand what the treatment paradigm is like for a particular population. So that is my take on it at this one.
Right. Thanks, Sriram. Abhimanyu, you also have some experience with CSR, right? Not exactly.
Not exactly. Yeah.
Yes. Okay.
So,
yeah.
One thing, I think there is this Tata Institute of Social Justice, right? I've seen several of those folks getting into CSR. If somebody is interested in that area, they may want to investigate further there.
Yeah. So corporate social responsibility is that companies must spend 2% of their profit in giving back to the communities. And those are mostly service-oriented projects, which have very tangible outputs. Like you can count the number of toilets you built or the number of schools you made. So, and hospitals and OPDs. So you want to manage that kind of project. Of course, there is a lot of scope for people to get into it, especially those who are service-oriented. There is another domain of, you want to say something, Sriram?
Yeah, one more thing, Archman. So not on CSR specifically. I also want to highlight that if these folks want to enter the industry, there are several companies who actually are into RWE research, real world evidence research, and they ideally look for MPH candidates, and that includes Novartis in Hyderabad. They have a very large group. I think probably 5,000, 6,000 people, and I don't know how big the RWE group is. Sanofi also has, GSK in Bangalore has, Sanofi is in Hyderabad, and GSK is in Bangalore, and Pfizer is in Chennai. So all these companies, they are actively recruiting. There is a talent surge right now in India at this month. We do not have enough talent in India for the jobs we have in these global centers. So I would encourage folks to really look up for job opportunities by going into these companies' web portals. And if they know contacts, they can go through LinkedIn profiles, connect with people, and one thing will lead to another. I think if they want to really get into corporate, they can be quite intentional about it and get into it, and the salary is also decent enough to start off.
So friends who are watching us, we usually do not talk about corporate employment with pharma industry. So here these things have come up, and Sriram is someone who gives internships, and he has more friends. So we can connect and get more guidance on that. Can explore those opportunities. Another thing is insurance sector. That again is a big employer, and can explore. Okay, so we got CSR projects and some. Let's get into some academics. Pranab, like your turn. Like, how do I get into a premier college for a PhD?
Yeah, so that's a very difficult question to answer, to be honest, because I hope this is not sounding disingenuous, but I don't think there's a fixed formula for success as such, and it varies from person to person, institute to institute, profile to profile. We all have our strengths, our experiential learnings, and our weaknesses, and getting into a premier institute is basically a play of these along with a healthy dose of luck, good fortune. So I would recommend that, yes, getting into a good program is, of course, very important. But at the same time, if you don't, that's like not the end of the road. A lot of people have done amazing stuff without actually going to a Johns Hopkins or Harvard Med School. So I think the work is important. And if you're doing the work, these things happen along the way. And secondly, coming to the question of how does one land up at Johns Hopkins or a good institute? Like I said earlier, working in your field, getting publications, getting hands-on research experience or project management experience, both are quite important. And then actually having a vision. Why do you want to do this program? If it's a master's, why do you want to get into this master's program? Your personal statement or essay becomes very important, because that's the sort of first point of identification for you with the program that you're applying to. Knowing the deadlines is very important. If you apply after the closure of deadlines, you are most likely not going to be considered. So that's also important. You need to know the administrative processes. What are the steps? You need to get them done on time. For us, another big challenge is getting our degrees verified. I know there was a candidate last year who was extremely well qualified, but the World Educational Society, WES, which is a Canadian organization which gives us an equivalence for our degrees in terms of GPA in the US or North American system, they could not verify his degree on time. And because he did not have degree verification, his application did not go through. He was shortlisted for the programs, and then he was informed that his application is not going through because they're incomplete. So get things done on time. It would be the worst to be unselected because of such administrative reasons. And finally, it has to be a very sincere effort. It has to be something that comes organically from the work that you have done. For example, if you are somebody who's worked for the past 3 years in aging, and suddenly you apply in infectious diseases, that might not be the best match, but it has to be strategic from that point of view. But at the same time, it seems from the outside that all these big places are, unachievable and hard to get into. But I think if you have the right kind of message in your personal statement, if you have the right kind of work experience, and you have the right kind of profile, it's possible. In fact, if I'm not mistaken, the master's acceptance rates at Harvard School and Hopkins are quite high. So if you have a decent application and if you have a decent profile, at least at the master's level, it's quite likely you'll get accepted. The issue remains getting funding for your position. That's a different ball game. That's a different ball game altogether. So yeah.
Right. So this particular round of discussions we had before we play the next couple of videos has been quite actionable. Mohan, would you like to summarize or stitch them together as we move on to the next videos?
Yeah. So, friends, as you have listened to our speakers, panelists on the various aspects from CSR to research to education. So, I think you need to develop a perspective that what you need to do and why you need to do. As there is a saying that if you do a job which you love, then probably you may never to do a job. So, I think you need to develop that kind of the perspective, you need to find that kind of the job and you need to work hard for that. And work hard means simply on the very first day you know that what kind of the skills would be required to get that job. So, if you work for that and you work hard to get that job, and if you get such kind of the job, then probably you will get a good satisfaction and ultimately you will get a good excel in your career. That is a simple fundamental thing while you move forward in your career. As speakers have mentioned about the various fields, there is a CSR is a opportunity, but I would suggest that CSR is not a only option that you look for, but you need to look at a wider perspective while searching for the job. Research is one thing, but research would help you to establish in any kind of the field, because while you learn something for the research, you will learn a lot of the things. You will learn how to write, you will learn how to express, and most importantly that I would love that you will develop a logical thinking or strategic thinking. So, if you able to develop strategic thinking, you would be able to develop a strategic approach in your actions, then I think it would be very much easy for you to get a good job, and you need to find a way for yourself when you move forward. I think this is the message our speakers provided to learners, and after that I would suggest the learners that participant or those who are watching this session, that the different kind of the questions were there. One question or the two kind of the questions were there, that what kind of opportunities and challenges are available after MD and MPH. These two different kind of the questions, but as I have said earlier, similar kind of the challenges for the both, because you have got degree, you have got education, but to work in the field, you work in a project, to work in a system or program, you need to have a set of the skills, and those skills would not be limited to your technical skills. So, always prefer that your other skills are important and you should not lose a track. So, technical in alignment with the technical skills, you should always think about the networking, you think about the networking with peers, friends in the industry, your teachers. You would be able to guide you to get a good directions. You need to, when you stuck somewhere, there has to be someone which can help you, and that could be your peers, your mentors, and most importantly your teachers. So, I think this is the way. So, let us move forward. Archie.
Yes, thanks Mohan for wrapping up this particular round of discussions. We have some questions. One was, could you please elaborate a bit more about predatory journals? Now, predatory publishing, as Abhimanyu said, he fell in the trap. Pranab said that you should avoid that trap. That's a blemish on your CV. And then people want to know. Anyone would like to comment on that, Sriram, or I can talk a bit about it, but yeah, anyone? Sriram, Pranav, you'd like to elaborate?
Sure, Architman. I think you are the expert in the previous workshop, but nevertheless, I will attempt. There are several ways to identify predatory journals. One is, they will definitely ask you for money, and the acceptance will be too fast to believe. Uh, you may submit the journal to the journal today, and then on Wednesday they will say it's accepted, and it will appear as if peer reviewers done in 2 days, which is completely unrealistic. And the journal will sound very similar to another high-profile journal. One I had, in my career was called as the Journal of Bioavailability and Bioequivalence. And the professor who was writing with me, he fell for it because he was looking for a journal that covered that particular topic, and it was just too good to be true. You know, um, I looked at the publishing house, and I knew that this publishing house was predatory, so it was easy to spot. But Archisman has some couple of suggestions, some websites that we can use. Ideally, it should the website itself will look very rudimentary, or it could be very glossy. It will not look academic. The website will be poorly done. The login page will be, there won't be any login page. You just have to send it to an email address, you just have to click buttons and things will move forward. And they will ask a very high fee to publish it. That means that the journal actually exists to make money. There is no other purpose for it. So Archisman, over to you.
Yes, predatory publishing is in vogue, especially since there is a mad race to publish, and they just give you a quick turnaround time, and you don't get any meaningful peer review done around that. You send your paper, next day you get an acceptance, it's published, and then you go and talk to some learned person. That person will trash your paper. That's the fate. Pranav, you said that you should not get a publication of predatory journal blemishes your CV. Why do you say so?
Yeah, so because there's no point to that publication. Honestly, it shows that as a researcher, you don't even have the ability to spot which is a good journal versus not, which is like a very basic academic skill set. So if you can't actually identify if this is a good journal or not, then I don't trust you as a researcher, first. Secondly, I will always suspect, as somebody who's looking to work with or hire somebody who has published a whole bunch of articles in predatory journals or published vanity books with like vanity publishers, I'm not going to name names, I will feel like there's an element of intellectual corruption. I wouldn't say dishonesty, that's a very strong word. I would say intellectual duplicitousness, and that is something that should not be tolerated in academia, at least. So yeah, I don't think it's a good idea to, you're better off having one good publication in one journal rather than 20 publications in predatory journals. And just one thing to add to what Dr. Sriram was saying, a lot of open access journals charge article processing fees. So just because a journal is asking for money doesn't make it predatory.
Yeah.
In fact, the Nature group of journals recently launched open access fees, and they're $11,000 only. So yeah.
So is that refundable, or it just goes off like you send 11,000 with the book?
once it's accepted, you have to pay them 11,000.
Well, if you publish your findings in Nature, then any funding body will be happy to pay 11,000.
I don't know.
I don't think so. I don't agree with you, Abhimanyu. Nobody should be paying $11,000 in public.
Funding bodies like IDRC, they will for sure.
So perhaps that's the take-home message from you. Like till now, it was publish or perish. Now, Pranav is given an idea of publish and perish. So you publish, pay $11,000 and perish.
Predatory publish and perish.
Perish. Right. So before we move on to the next video.
And I think, Archis, I think it would be good here to explain to the audience, because maybe they do not know that how they should identify the predatory journal. They may not visit to the website like Baylist or somewhere. Maybe they do not know about these things. So there is a simple idea to identify a journal which you would like to publish from the very basic level. You need to identify go to any indexing website. For example, it may be PubMed, it may be Web of Science, Scopus. So at least whatever you able to get published, that should be indexed and that should have some scientific validity. So this is the basic step. If you are not able to explore how to know the predatory journal, whether how to decide about getting a good journal, then simple idea is that go to the indexing sites, and indexes direct you towards a reasonable journal to get publish your findings. Yeah. Yes, Abhiman. Sri Ram, please.
Yeah, Mohan, these predatory journals, they have actually predated PubMed also. So the journal I was talking about, it was on PubMed. It was indexed on PubMed. I think there are several other. So PubMed is not the criteria anymore. That's what we have found in the last 4 or 5 years. They have advanced even further than that.
Yeah, I said this because the general audience may not be able to track that, how to get that to that, whether decide that this is a predatory journal or not. So indexing could be a initial idea who is not aware about the processes. Yeah.
So the difference is a good journal, a predatory journal will not be indexed in Medline. It may deposit their articles in PubMed Central,
yeah,
but it will not be indexed on Medline. So looking up Medline would be a better alternative rather than just looking at PubMed Central for published articles.
Right. So it seems that for youngsters, like don't be like, it's good to be happy that you publish something, but don't be overexcited if you're going back and forth with predatory journals. Just stop, pause a bit, and review what publications you're making.
And even it would be good that those who trapped in these predatory journals, this is a good statement. This would be a good statement for the audience, that if you are able to publish 10 papers in predatory journals, and if you are able to publish only single paper in a good authentic journal, then that one paper have much value than those 10 publications. So these things should be kept in the mind while you are trying to find your journal or you are trying to publish any evidence or knowledge. Yeah.
Right. So before we move on to the next one, I want to read out this particular message from Sri Ram. When I was an undergrad, I was told Cambridge University is too high profile for me for PhD. I decided to pursue, nevertheless, and my application went through. Being brave and optimistic will help. So that's a good message. And we'll watch 2, 3. Yeah, Abhimanyu, yeah.
Ashish, just very briefly, I would like to add to this message and to whatever being shared by Dr. Pranav regarding getting into allied institution. So there is a significant difference between a master's application and a PhD application. So I would like to put it very straight, like master's application is more of a cash cow to all the universities, and it's quite in open for Australian institution, for US and for UK. So if you are applying for a master's program and if you can pay from pocket, the conversion rate is more than 50% and the acceptance rate is sometimes beyond 70%. And I am talking about Oxford, Cambridge and Harvard, Johns Hopkins. But for PhD, you need to align with the interest of your professor, with the department. You need to have a very strong GRE score, or not exactly GMAT, but your GRE score. So preparation for an allied institution for a doctoral program is much more. Maybe you need to have at least 3-4 publication in not exactly the same, but a similar sort of field before application. But for masters, you can prepare your application in 3 months and you can apply and you can get admission. So you have to be a lot more serious. For doing a 5 years PhD, you have to be serious 5 years prior to that application to be eligible to apply for that PhD. So that's a huge difference. So allied institution for masters and PhDs, it's a completely different story. Yeah, that's something I want to add.
Yeah, so it requires a bit of guidance and hand-holding. So reach out and prepare well in time. Of course, Mohan also emphasized on one point that accumulating degrees is not everything. It's about skills. And Tapas also mentioned that it's learning on the go. So you keep on learning as much as you could and you'll excel. So we have 2 videos. There was one question on international employability for MD community medicine people, which all countries they can go. And Pranav has answered a bit to it. Pranav would like to add to that before I play this video.
It's a very vague question because it varies from country to country. So depending on which country they are speaking of, the answer will vary widely. For example, you may not be able to get a job in the US, but you may definitely be able to get jobs in the Midwest, in the Middle East or in Australia, or even in some European countries, depending on your trajectories. And I think Tapas is very well positioned to answer this question better than any of us.
Tapas, the baton goes to you. Yeah.
Thank you for sharing. I mean, this question. I think it's a very interesting question. The first thing I would say is that I would echo Pranab's initial comment. And even that's the comment which Abhimanyu has made, which you yourself has said, Archisman. It's always good to have a goal, but I would not advise that any student should have this, that, okay, I want to work in WHO Geneva and that is it. A fixed goal is not easy to achieve. You have to be flexible. You have to go step by step. As you said, Archisman, a lot of people are stuck at one level. You are competing with your seniors, with your colleagues, with your juniors at that one level, and then you are trying to jump to that next level. So that takes time. So I would say, start working in the field, work at the district level, then work at the state level, then work at the national level. I mean, a step-by-step approach is what works from personal experience and from what I've seen in others as well. I think jumping directly to the international level is not possible for someone with an Indian education background. What I've seen is a lot of people, after doing their MD, they go abroad and do a foreign MPH. That helps to jumpstart their career in that international space. And international MPH makes you much more attractive to international organizations for positions at New York, Washington, Geneva, etc., so on and so forth. But a pure Indian degree may not be enough. The Indian degree plus a relevant amount of experience at the national level can help you, can help to catapult you to the international level. Yeah, thank you.
Thanks, Pranav and Tapas. Like spot on, practical suggestions. We have someone from the Middle East. We have a video there. 2 more videos, 3 quick videos, and then we'll wrap up the show in another half an hour, within another half an hour. Okay.
Good morning, good evening, everyone. First of all, I would like to thank my friend, Mr. Abhimanyu Singh Chauhan, for giving me this opportunity and this platform to discuss more about the different career options available in healthcare information technology field for young leaders. I know we have little time to discuss this, so I'll begin with my brief introduction. My name is Tanveer Alam. I am currently working in Tech Mahindra as a project lead and deployed as a digital transformation project manager in one of the hospitals in the Middle East region. So I did my graduation in medical imaging technology. Post that, I did my MHA in healthcare information technology from IHMR Delhi. During that time, it was really tough. It was kind of a gray area for all of us because we were really not sure who will be the organizations or who will be the companies will be coming for placements, and we really did not know where to go and where to apply. And obviously, we were the first batch who were pursuing the healthcare information technology. But fortunately, we all got placed within the timelines. I got placed in a healthcare IT firm based out of Pune, and I was there for around 3 years. We all know, and we all will agree, that every industry has different career options in both government as well as in private sector. But since I have been associated only with the private sector for around 10 years now, so I'll try to give and I'll try to help you with different options available in private sector in healthcare information technology field. So what I have experienced and what I've seen under this huge umbrella of healthcare, majorly we have 3 different options. First option is obviously the hospitals, or the, you can say, providers. We all know it's an era of digital transformation. And hospitals now, they are looking for solutions and they are looking for products, different technologies who can help their patients in enhancing their experience, who can help their caregivers in providing better care, which can help them in standardizing the processes, or you can say workflows, and obviously which can help them in providing better care to the patient. So first option is hospitals, because they are looking for people who has this blend experience of domain and technology, and who can help them in implementing and identifying these kind of products and these kind of solutions. For me, the second options is obviously the product companies. Product companies like Epic, Cerner. These are like EMR companies. Philips, CTS Tech, these are companies who are creating different products which can be used by the hospitals. And they look for people who have the domain knowledge, for example, nurses, doctors, people from lab, pharmacy, radiology, and who can work for them as business analysts to come up with different solution products, obviously, which will be used by the hospitals. So for me, the second option which we can look for is the product organizations. The third option which I would like to suggest is the consulting organizations, or you can say BPOs, like KPMG, Deloitte, Accenture, EY, PwC. Because now, other than consulting, now they have started providing services related to implementation, related to support, and now they are helping the hospital from scratch, and they are helping them in implementing these kind of products. So to conclude, I would like to suggest that majorly there are three options. One is hospitals, second one is the product organizations, and third one is the consulting or the BPOs. I know it was a very short discussion about the different career options which are available in market. But you can anytime reach out to me or to my friend Abhimanyu Singh Chauhan to discuss more about these options to make a good career in healthcare information technology. So thank you so much, and best of luck. Good morning, good evening.
Sorry. Thank you, Tanveer. Abhimanyu, he is a Commonwealth Fellow. He was a Commonwealth Fellow or something?
No, he's not the one. No.
Okay. Sorry, I got confused. I have one more video over there. Before I play this, Sriram wants to leave. Sriram, is that okay? Is that true?
Yes, Abhimanyu, I want to get to family duties. Right. As you get older, guys, this is also something you have to take care of apart from your career.
Work-life management. Right, Sriram, so thank you so much for joining in. I know that
everybody. Yeah, and it was a pleasure to talk to all the panelists as well as all the students assembled here. Thank you. Bye-bye.
Thank you, Sriram. Thank you.
Take care. Bye.
Bye. So what is happening now is we are traditionally trained to look into academia for job placements or INGOs. Now through this almost 2 hours of discussions that we had, we know that pharma industry is also actively seeking for MPH and MDs. We know that insurance sector is there. There are consultation firms, hospitals, product organizations, and of course, academia and all those routine things are already there. There are tech firms that Tanveer just talked about. And now we have this one from Shobit. He'll also talk of another career option that we can explore, another domain.
So just a brief background before we begin. So I have done, I'm a pharmacy graduate, and then I have done the healthcare management. And post that, I have worked in various domains like hospital, domain, a healthcare NGO domain, and now I'm working with Philips in their medical device sector. So I would like to brief, or maybe you can say just would like to throw some light on what are the options available for healthcare management professionals when it comes to the field of medical device. So medical device, if we talk about the journey of a medical device, it starts from innovation, and then it reaches to the market, and then from market it reaches to the customer. And in this entire chain, there are various avenues which healthcare management professional can explore and can really take it up as a career option. So if we broadly talk about, when we go to the research part, it is more of the technical area wherein the people with technical domain expertise are required. But still, parallel to that, there are some management related career opportunities available for healthcare management professionals. Like there are options for management of the releases of product in the market, which is the new product introduction, or the regulatory related domains wherein a healthcare management professional will be a right fit. And coming to the second phase, which is, I would say, in the market wherein the actually device is being sold, there are multiple options for healthcare management professionals. To begin with, for example, we have a marketing team in which the healthcare expertise is required. The background of healthcare will be very much useful. And other than that, we have healthcare strategists who actually look after how a device can be pitched, which market, which area to be actually captured, which specialty to enter. All those things are being part of the strategies, which is actually also one of the good field for healthcare professionals. And along with that, there is an option for regulatory affairs and the quality, which are very niche areas. And I would say there is a huge demand of regulatory affairs and quality management system professionals when it comes to medical devices. Medical devices follows ISO 13485, which is a very specific standard for medical devices. And this is something which you have to definitely, you can learn only as much as you do it. It's not something which you will read it and understand. So there are multiple courses available with the standard bodies who are actually training you for the certification of ISO 9000 and ISO 13485, wherein you will actually learn many quality related aspects which are required to be followed before releasing a medical device in the market, or even after releasing the medical device in the market. How do we handle the complaints? How do we handle the customer feedback? How do we handle the servicing? Everything is as per the global standard, which is ISO 13485. So there are multiple opportunities in which people like us, or healthcare management professional, takes a lead, go ahead and just try to improvise what is being done already in the markets. And there are multiple roles in which are customer facing, which are based on the back-end offices, and multiple roles for quality, marketing, supply chain, in which healthcare management professionals can really actually make their career in medical device also. So just one advice from my side, which I have experienced in my last 10 years, that never think that this particular field has a limited scope, or this particular field may not give me what exactly I wanted to do, because every field has immense scope if you have ability to learn and improve. If you want to grow, please get into any field and try to explore as much as possible, work with full dedication, and believe me, you will never stop. Thank you.
Thanks, Shobhit. So those were some videos. We have another 2-minute video on the analysis of the job dashboard, what kind of skills are being advertised for employment. But before we get in there, There was one question in the chat window. I don't know if people have seen. It's from Dr. Sheetal Rajan, and she, like Sheetal is a unigender name. I have a friend who is Sheetal, a man. Right. So the question is, hearing the panelists' trajectories. So this question is spot on, like point blank to all of you. I would like to ask them their take on career growth. They have switched jobs. Most projects in public health are time bound. How will they weigh their constant switch or moving vis-a-vis a stable job? Is it exciting that way?
I've tried to answer a little bit on the chat box for a lot. So I won't spend too much, belabor the points
I think, Pranav, you should talk because I'm not sure if the audience can see the chat.
Oh, okay. All right, that makes sense. So my point was that with people like Tapas and me, we have been fortunate to know each other for a decade now. We have changed multiple positions, right? And I think going from one job to another has not been about rosy roti or roti kapda makan, you know. It's been more about finding a job that, or finding a project that sort of built into our skill sets that added to our repertoire of knowledge and ability. So it's possible to have a career where you're changing your trajectory every few years, whilst you're still working within the same broader area. I've continued to work within infectious diseases, child health, vaccinology. Broadly speaking, although I've changed 1, 2, 3, 4, 5 institutes in the last 6, 7 years. So that sounds like a lot now when you say that out loud. But none of those shifts were because, oh, they're paying me more. I'm going to get, actually, when I shifted from one job to, when I shifted to ICMR, I took a huge pay cut. And people would be like, they could not understand why I was doing this. But ICMR gave me the opportunity to work as a principal investigator, which was an amazing opportunity to learn in leading a team, learn in figuring out how to write a proposal, raise money, do the administration of spending that money, figuring out which person is the best for the job, not just the science, but the science administration of it as well. And then when I moved to Hopkins, it gave me the chance to connect back with my academic roots again. So it has given me an opportunity to flit between jobs while still staying within the same broad area. There are amazing people who are doing wonderful work, and they have stayed in the same position for decades as well. So public health is unique in the sense it gives you the gamut of opportunities where you can spend decades in a single institute, dedicate your career to a single institute or a single topic, or you can find the next most exciting thing, next most exciting project and move on. Not advisable to make too frequent shifts. The shifts should make some sense. Just because somebody's offering you 10,000 rupees more, you should not make that shift. That should make sense to you, the narrative of your overall career. And I would recommend not to make a shift less than 2 years into a job, because in public health, it takes a few months for your job to get going. And even if you submit a paper, it takes 6 months to get published, right? So give it a couple of years at least. That's what I did anyways. So don't flit around too often, but if it's something exciting, take the opportunity. Or you can also have a safe job. You can join an ICMR institute, which is an incredible opportunity to lead your own team, be your own researcher, lead your own lab. And you can spend decades focusing on specific research areas, specific research questions. And that's also very important. So that's my 2 cents.
Thanks, Pranav. Thanks. Tapas, you'd like to add?
Sure. I agree. I mean, the question is very relevant for public health professionals because a lot of these organizations run on donor money, which is time bound. You may have a project for 3 years or 4 years, and after that, tata bye-bye. So how do we navigate that sort of a domain? I mean, it's very challenging. It can be pressurizing. most organizations do have a retainment policy because as around the time a project is ending, some other new project might be starting. So they usually do retain the staff. I mean, they offer that opportunity to the existing staff. They get the preference for joining the new project over a fresher from outside. But at the same time, it is a valid question because there are situations when organizations run out of money. The PHFI FCRA regulation was a fiasco. I mean, PHFI did not have money to pay people, and they had to say, sorry, we have to let you go. And a lot of people got dumped at that point of time. So that happens sometimes. I mean, that's a worst case scenario. I mean, hopefully that should not happen to other organizations. But yes, sometimes you have to be let go of. You have to find a new job. So I would always advise always look for jobs. I mean, that is my philosophy. Even when I was happy in a job, I was always looking for the next opportunity because I tend to get bored. To be very honest, once I cross 2 years in an organization, I tend to get bored. And I try to look for greener pastures in inverted commas. And I have also realized that you stay too long in an organization, you get stuck and you don't learn more. You shift organizations, you get exposed to different ways of thinking, different ways of working, different domains of public health. So you broaden your expertise as well. So I would advise shifting jobs is a good thing. I agree with Pranab, don't shift too frequently. That is a negative from a HR point of view when you are trying to apply for new jobs. But stay in a job for 2 to 3 years, and then if you get a good opportunity, jump. Do not wait till the project is ending before jumping. Do not wait till you're desperate. When you're doing well in a job, that is the right time to be on the lookout and being able to select a good job. A good job has multiple factors. One of my seniors used to call it the 4 Ps: position, place, paisa, and peers. So the position, the level of the job, the place, the location of the job, the peers, how is the environment at that organization. That is a very important factor which we really don't figure in our calculations usually. And then obviously the paisa. So all these 4 factors are important. You may be able to compromise on one factor, and if the other 3 factors are okay, you may be willing to work in a hardship location if you're getting good money, good job, great colleagues. You may be fine with that. Or the vice versa. You may be willing to work for a lower salary if you're working in a great organization, great colleagues, and your preferred location. So, but don't compromise on too many factors. Then you tend to get frustrated. So, what else was there? I mean, that is a really good question. It's a very big challenge in public health, especially for people who are in state level jobs. But the advice I can give you is try to jump into a national level job, because at the national level, you are able to navigate these positions much easier than you would at the state level. At the state level, there is a limitation in the job market, but at the national level, at Delhi, there are so many jobs which you can, jump into from one job to the other. As if you have established good relationships with the ministry in immunization, you can easily jump into the MNCH field or into the NCD field, because it's just about, they look at your work experience, they see your work at the national level, and they're happy with that. So I would say keep your goal as transitioning eventually to the national level. At the national level, your jobs are much more secure. A lot of organizations have staff positions at the national level. So once you are in those staff positions, then you don't really need to worry about the security of your job. And Pranab's suggestion is a very good point. ICMR has permanent positions. Similarly, NCDC has permanent public health specialist positions, which are very prestigious. And you will be managing a national program at the national level, and you will be representing India at various international forums. My seniors in RNTCP, they come to Geneva every year or every alternate year for some meeting or the other. So those are positions which you should aspire to, and they have the added advantage of being job secure, as well as the privilege and the responsibility of managing things at the national level for the ministry and for the government per se. Yeah, thank you.
Thank you, Tapas. Abhimanyu wants to add something. Yes.
Yeah, I will add just very briefly. I agree with Dr. Tapas and what Dr. Pranab just said. I just want to add there's a little bit of difference if you come with a 5 to 7 or 10 years of experience, or if you are a fresh graduate. So if you have, let's say, 5+ years of experience, then you are a fairly established public health professional in the field. But what point I want to make is mainly for the fresh graduates. I believe, and it's just my personal opinion, it's very important at what point, at what stage of the project you are actually entering. So if you are a fresh graduate, it's really important you enter a project when it initiates, and you should leave that project when it ends. It's challenging. It's many times it's challenging. It's very difficult to find a job immediately. You have to look maybe a year before, or maybe there is a gap of 3 months. But it's really important for a fresher, because then only you can understand like how a project funding comes in, how you recruit people, how many full-time positions you need, how many consultancies you need, how you contract with a national expert, how you contract with an international expert. How do you go for pilot testing? Like pilot testing is a new concept for many fresh graduates. What is the importance of what is the difference between purposive and convenient sampling? So how you write your operational manuals, and then how you collect data, and all these steps. So I believe a fresh graduate should go through this journey. It doesn't matter. It could be a small project, maybe a 1 year small, one single county prevalence survey or something, or maybe multi-states 5-year initiative. Just try to complete at least one cycle at the initial days of your career. Then you can switch anytime. There is no hard time bound stickers. You can put 6 months, maybe you can stay for 1.5 years, or maybe like ICMR, you can retire with 35 years of your service. So that's the only point I want to make. I just want to differentiate between a fresh graduate and established professional when it comes to switching jobs and moving ahead in the career. Yeah,
that's a good dimension, Abhimanyu. Thanks for adding it. And of course,
I just meant, sorry, just one more point. I forgot to mention this.
Shifting
jobs can be stressful for your family life. Especially if your spouse is also working, then it's a hard adjustment, especially if you're shifting from one location to the other. Case in point, I am sitting in Geneva. I'm sitting in a dormitory. I've come alone, and I honestly do not know when my wife will be able to shift, because she is working and she wants to study in India. So that is the sort of compromise that you should be able to do if you're shifting from Bhopal to Lucknow for a project. And if your wife has a steady job in Bhopal, you cannot ask your wife to shift with you to Lucknow. I mean, those are the things which you need to discuss with your family. You need to be sure that they are also comfortable with your professional choices, because your professional choices will affect their life as well. I mean, when you're single, it doesn't really matter. You can shift from one city to the other. It doesn't really matter. But once you have a family, you have to think about the effect on your spouse. You have to think about the effect on your children, their education. I mean, so many factors come into play. So that is one thing. As especially the older you grow, the more these factors may become more important than the job per se. I know people who have refused jobs in international locations because they felt that it would not help their family. It would not be productive for their family. So those are the sacrifices that people do make. I mean, that is one factor which you need to think always when you apply for new jobs. Yeah, thank you. And there was one question which I really liked, which I think, did we skip? There was a question from Sonal.
I was about to take that question. Yeah.
Oh, perfect. Please go ahead.
Yeah, the question is that if I'm from the Ayush background, and why can't I be trained as a leading public health professional? I don't think there is any reason why you can't be trained. Like, it's an open field, and I think that has been answered by Pranab. And I guess the entire panel would agree on that, right? So there are multiple avenues, and you are not limited by your graduate degree.
I'm not sure if I think there is a whole Ayush department at WHO also. I'm not sure.
Very true. Yeah. Very true. There is a traditional and complementary medicine department at WHO, and they prefer Ayush colleagues,
Exactly.
because it is their sphere of medicine. I mean, an MBBS doctor will not be able to work in the traditional and complementary medicine department. So at that department, we do have Ayurveda and homeopathy. We do have Ayurveda physicians and homeopaths, at least from my brief experience so far. I have seen them. So yes, that's a full-fledged department dedicated to the research in traditional and Ayurvedic in complementary medicine. They have recently even started a center in Delhi. They are working with the government of India to initiate that center. So that's a very productive field, and I definitely agree with her. Right now, there is no discrimination. Earlier, it is probable, I mean, it is possible that there was a preference for a medico over a non-medico, but at this point of time, I think there is no real reason for such a barrier. Dr. Samira Azma is a WHO director for data and intelligence, and she is a dentist from Bangalore. There is no preference for a medico or a PhD for her. I mean, she is a dentist, she is an MPH, she is reached at that high level. There are the lead consultant in the immunization division in India is a homeopath who has then done an MPH from TIS. So these things are not a barrier anymore.
And it also depends.
There are Master of Social Work colleagues in WHO Geneva. I mean, there is no discrimination at all. Each person has a very valid educational experience, a very valid experiential learning over the course of their career, and they can be at very high positions depending on their caliber.
And also, it also depends upon the requirement of the job. If you need a clinical domain knowledge, then you need to have a doctor in place. You can't recruit somebody else. So if you need somebody from health IT, digitization, transformation, WHO also recruits people from BTech IT background. So even they can say like medicine, only IT people are preferred for this position. So it depends what you are bringing in. So
Absolutely.
I don't think that's
absolutely. I completely agree.
Just to add to what Tapas was saying, I was nodding my head so vigorously it could have fallen off. Just to add to what you were saying, not just about Ayush, I think the thing that I have learned in the last year and a bit since I started working here is that public health is very medicalized in India. Even Ayush is a medical lead trained professional. So MBBS, MD, Ayush, BDS, these are all medically trained professionals. But there's a whole gamut of professionals beyond the medical field who can make positive contributions to the public health revolutions. And medicalizing or over-medicalizing the field could be detrimental to outcomes. Behavioral scientists, biologists like Abhimanyu, qualitative researchers, health tech people, they're as important, if not more, in certain areas, Disease modelers, these are people with PhD in mathematics. And they're coming out with some of the most robust ways of dealing with threats that we don't even know how to quantify. So public health has become very, very pluralistic. So if you are an Ayush graduate, you should not let that stop you. Or that's just in the mind, because once you're beyond that, once you're in the master's and postmaster's level, once you're in the field, what matters is your technical skills and what value you bring to the table. Abhimanyu and I had the privilege of working with an Ayush graduate who was simply incredible. And we didn't get a lot of time to work with her, but she was one of the best people I've worked with. So I think it's not just about Ayush. It can be social sciences, it can be economics, it can be mathematics. Who knows? We have biophysics professors, Professor Menon, who's come up with amazing models for COVID. So sky's the limit.
Yeah, between, I will not take the name, but the person Dr. Pranav just mentioned, she is now working with antimicrobial resistance in a project in Geneva.
Right, so it's never the final stop. You always keep improving. So even if it is a loss, or even if it feels that you don't have an opportunity right away, just be hopeful and something will work out. If you're really good, you'll definitely find a place. The world is too big, and especially for public health people. Now, I'd come back to Mohan to close the session in another 5 minutes. Before that, There is a 2-minute video. What we did is at Grid, we have been looking at different jobs for freshers, fresh pass outs in MDs, MPH, PhDs and all in the Indian market. And we have analyzed that. It's in the shape of a job dashboard, but whatever metadata is available, we have analyzed. And Divita is a colleague at Grid and she has made a video. It's a short 2-minute video, won't take long. Straight to the point.
Now, let's talk about the skills which are in demand. So, what we have done is we created a dashboard and we also acquired skills for every particular job. And it was segregated into hard skills and soft skills. So, what hard skills are in demand are, first of all, it's basic computer skills. So, basically, your MS Office, which include Word, Excel, PowerPoint. So these are the basic computer skills which the recruiters want that you should have, the people applying for the particular job should have. Then second is statistical software. So software like SPSS, Data, SAS, R, they're highly in demand. And also we also found out that other software like Python and like Power BI, so they were also quite in demand. Then we have qualitative data software, which were like NViso, Atlas.ti. So they were also quite in demand. Then publications. So many of the jobs also required, especially people from community medicine department. The jobs required to have publications for at least 2 to 3, and these were mainly for the research jobs or the faculty-based jobs. Next is languages. So there is one standard thing that there should be fluency in Hindi and English. So these all these jobs are created from India, from an Indian perspective. So the basic demand of these jobs were fluency in Hindi and English. But then, if any job is based out of any in a remote area or in somewhere in South India, then they expect the candidate to know the regional languages of that area. So that is one skill. You have to check the job description to know that if the job requires you to be fluent or basic knowledge of that particular language. Then of course, if this is extra, or you can say this other, that this is desirable, basically, that advanced training or diploma course in a particular in a particular field or whatever that job is asking for. This was about the hard skill. Now let's come to soft skills, which are highly in demand. So the very first kind of soft skill which was in demand was communication skills. So both in the form of verbal and written communication. So almost all the jobs are expecting the candidate to have good communication skills for obvious reasons. Then interpersonal skills. Then creative thinking, or ability to create new ideas, innovative ideas, problem-solving nature, leadership quality, and should be self-motivated. So all these soft skills were in demand. I hope this was helpful. Thank you.
So what started? You talk to wise men, you get all the nuggets of wisdom. We started anecdotally, and this is evidence-backed. So this is, we abstracted the job descriptions and did an analysis. And broadly, these are the skills that employers are advertising for. And sort of validation of all that we discussed. Going to Mohan to sum up and close the session. To you, Mohan.
Yeah, thank you, Archie's, and thank you, panelists Pranab, Tapas, and Abhimanyu.
Sriram.
So I think this, Sriram,
yeah.
This would have been a wonderful discussion, and I hope the audience would have benefited of it, and it would be useful for them when they move forward. So simply, if I conclude in a few sentences, because we are running out of the time, it's already about 7:30. So if I will talk to the Sital, So it's not only Sital actually. This question would be of the many young professionals. So there are two contradictory answers came. Pranab and Tapas said that for the mid-career professionals or early to mid-career professionals, it's easy to switch the job, but they have families. And Abhimanyu says that it's easy for the young professional to switch the job, but they should not switch the job. So what is the way for them? So it's simple. My answer is simple, that young professionals should have patience, because when you are young, you are getting initial jobs, you are learning more, contributing less. And when you are moving towards the mid-career, you are learning less, contributing more. So that is why they have more opportunity to switch, and when you are young, you are less opportunity to switch. So simple answer is that you need to have patience and you will find the way, because the answer, specific answer would be customized to the each person, and ultimately when you have heard these our learned experts and the professionals, you can use this wisdom while you decide and move forward. And regarding Ayush practitioners, it's already said by Tapas and Pranab and Abhimanyu that they are already contributing to the national health programs. They are contributing to the research programs in the medical colleges, other research organizations, and they are contributing to the program management and program implementation already. So you should not have to worry that there is a hurdle to you, or there is a, so those are the Ayush practitioners. There is a sky is the limit. They can do everything which any MD, MBBS or BDS, MPH can do, and ultimately skill set matters. And already about the skill sets which we were discussing from the initials of the session and now on, Archie's and team already explained that what are the skill sets required and what you are supposed to do when you are going to the job. And specifically when you are going to the job and you are trying to identify yourself that whether you are fit or not, you should read your CV carefully, and you should read that what job requires, and you try to match in between these two, and you will find the answer yourself. If you are moving towards that you are not suitable, that's not a good idea. If you are leaving those jobs you are suitable, so you identify suitable job, contribute and learn. This is the way forward, and have patience. Nobody will stop you. So I think this is enough has been said already, and I would not take much time and leave to Archis for concluding the session. Thank you, Archis. Thank you, Tapas, Abhimanyu, Pranab, and Sriram.
Yeah, thanks, Mohan. As researchers, we must describe the limitations. We have a couple of limitations to the deliberations we had. We did not have a female colleague, and of course, this panel was underrepresented in terms of PhD in public health. Those are two limitations, but then we tried to keep it unigender and relatable for all. There was rich information. One closing line that I would have is, if you want to win more, that means you need to play more. It's not about like having a very high strike rate, right? You need to play more. So just expose yourself maximally to as many networks, to as many people, and obviously opportunities will open up, opportunities that you have never ever actually imagined of. So for youngsters, get started with it, get connected with your alumni, with your professional networks, and then you'll definitely find guidance there. Thank you so much, Mohan, for co-moderating this session with me. It added to my confidence. It was shaky ground for me, but then your partnership helped. And thanks, Pranav in the US, Tapas in Geneva, Abhimanyu, Netherlands, Sriram, of course, India, and Prem for helping out with everything, like for all the going back and forth. All the people who sent out the recordings, Anil, Kaushik, Tanveer, Shobit, and Divita also, Abhimanyu. So thank you so much for all of that. Thank you, Sitanshu sir, for this opportunity, and IPH organizers for having us for this deliberation, and the audience for staying up with us. And we hope that you found it useful. Over to you.
Thank you, sir. It was a never-ending discussion, but we got close to 400 participants in viewing it online. And I take this opportunity as a participant as well to thank you all. So this is the last discussion for the day 3. Tomorrow at 9 o'clock, we will join for the last day of our conference. See you then. Thank you.
Thank you.
Okay,
Thank you,
bye-bye.
everyone. It was a privilege to be here. Bye.
Bye. Bye.
Hello, Jigma team. Hello, Jipmer team. Jipmer backup team, are you there? Hello. Jipmer backup team, are you there? Can you hear me?